Please just let me know. Huh?
You can start, ma'am.
Good morning, everyone. A very warm welcome to all delegates for our online CME on super specialty approach to specialty cases, organized by the Academic Committee of IMA Nanded. I'm Dr. Yasmin Zakaria, your host for today, and the organizing secretary is Dr. Sandeep Patil. First of all, I'd like to invite Dr. Manish Deshpande, our president IMA Nanded, to give a short welcome address.
Hello. Good morning, everyone. Am I audible?
Yes, sir.
Please change the screen.
Yes, sir.
Hello. Good morning, everyone. Have a nice Sunday. And Nanded IMA always tries to give you a good academic feast. In this session, actually, we had planned a good session for a pediatric community as well as even all the doctors of all the communities. But particularly, it was concerned with the pediatric community. I always wanted to, do a continuous medical education for the pediatric community. I mean, a broad specialty, like what they need to refer cases to the, you can say, specialist or the super specialist. So in this context, actually, we had planned the CME for all the pediatricians who face cases from all the kind of branches or all the faculties for whom they need to take help of the super specialist. So here today we have a cardiologist, here we have a hematologist and nephrologist and even a surgical persons like orthopedics and pediatric plastic surgeons. So please take advantage of this CME and have a nice time. Yasmin, over to you.
Thank you so much, sir. Today we'll be concentrating mainly on the super specialist outlook to routine OPD cases in a general pediatrician's practice. Before we start the first session, I'd like to request all delegates to note down their questions for the speaker in the question answer box. We'll have a brief question answer session after the end of each session. Without wasting much of your valuable time, we'll start with the first topic, which is evaluation of a first unprovoked seizure by Dr. Maruti Kadam. Dr. Maruti is a young and a very promising pediatric neurologist practicing in Nanded from 2019. After his fellowship in pediatric neurology and epilepsy from KEM Mumbai, he has also done a fellowship in clinical genetics. Let's hand over the podium to Dr. Maruti Kadam now.
Thank you, Yasmin Madam, for the kind introduction. Good morning to everyone, and I am also thankful to all the team of organizing this CME for giving me this wonderful opportunity. So my today's topic is, I would like to share the screen.
Yes, sir. Please go ahead.
So my today's topic is first unprovoked seizure in children. As we all are aware about the magnitude of this issue, whether we sit in emergency room or we are in general pediatric OPD or we are at pediatric neurology OPD. So before going in details of this topic, I would first like to refresh some of the basic terms which were frequently used in this presentation. So seizure. So ILE, that is International League Against Epilepsy, defines epileptic seizure as a transient occurrence of signs and or symptoms due to abnormal, excessive or synchronous neuronal activity in the brain. About up to 8 to 10% of the people will experience a seizure at some point during their lifetime, but only 2 to 3% will develop epilepsy. First seizure may indicate an initial presentation of epilepsy, or an underlying disease. As seizure is true substrate of epilepsy, we should know everything about seizure, like its types, semiology, etiology. So this is expanded version of classification of seizure types, that is ILE 2017. It classifies seizures on the basis of onset, like focal onset seizure, generalized onset, unknown onset, or unclassified. Unclassified here means we can't define exact onset or seizure semiology. So focal onset seizures are again divided as focal onset aware or focal onset impaired awareness, which again divided on the basis of motor onset or non-motor onset. Generalized seizures are also divided on the basis of motor and non-motor onset. There is one more term, that is focal to bilateral tonic-clonic, which was initially used to call it as partially with secondary generalization. These all are new terminologies, and more we use it, it will get established. And this is a nice expanded version. You can classify any seizure among these one of subtypes. So this is a diagram to differentiate between generalized and focal seizure. So generalized seizures means the seizure start at one location and it rapidly engages to involve the bilateral hemispheric networks. Whereas focal onset seizure starts at one point and it localized to one hemisphere only. It can be discretely localized, or sometimes it can be involve more widely distributed networks. Sometimes focal onset seizure can go and involve the other hemisphere, which is called as focal to generalized tonic-clonic, or previously called as focal with secondary generalization. In generalized seizures, though both hemispheres are involved, it is not necessary to involve the entire cortex. Neonatal seizures are not included in this classification, as neonatal seizures are mostly focal onset or multifocal onset. They are more often are Provoke seizure, and sometimes there may be only electrographic seizure. So neonatal seizures has a separate and exclusive classification. So after knowing what is seizure, we should also aware about the definition of epilepsy. ILE 2014 classification, ILE 2014 definition of epilepsy is based on the three criteria. The first one is at least 2 unprovoked seizure or reflex seizure occurring more than 24 hours apart. The reflex seizure here means provoked seizure. Though they are provoked, they can classify as epilepsy. One other point is that the multiple seizures occurring within 24 hours are considered as single episode only by this definition. This is important practical point which we should remember at the time of dealing patient with seizure. To second criteria, I willfully underline this criteria as this is some gray zone. Like second criteria is one unprovoked seizure or reflex seizure and probability of further seizure similar to the general recurrence risk after 2 unprovoked seizure, that is at least 60%, and it occurring over the period of 10 years. So this means that one unprovoked seizure can also fulfill the definition of epilepsy, provided that these children have showed some supporting evidences like abnormal EEG, abnormal neuroimaging, abnormal development, family history of epilepsy, which combinedly predict the future recurrence risk, which is equivalent to the recurrence risk after 2 unprovoked seizure, that is at least 60%. And the third and important diagnostic criteria is diagnosis of epilepsy syndrome. So these three criteria are important to define it as a epilepsy. So this is a simple framework to approach the child with seizure. So there are different levels of approaching. So whenever we dealing with children with seizure, first we should know about what is seizure type. That is, it is focal, generalized, or unknown. After knowing the onset of seizure, is it fits in definition of definition of epilepsy, that is focal epilepsy, generalized epilepsy, combined generalized and focal epilepsy, or unknown epilepsy, or whether it is an epilepsy syndrome. So these are three levels, that is seizure type, epilepsy type, and epilepsy syndrome. On the right side, we are seeing etiology, list of etiologies. So at each level, we can, whether we should look whether it is attributable to some etiology, like it is structural, genetic, infectious, metabolic, immune, or unknown. Sometimes the etiology can be mixed. Like in case of tuberous sclerosis, there are both like structural as well as genetic etiology. In case of neurocysticercosis, there may be infectious or structural etiology. In case of biotinidase deficiency, there is metabolic and genetic etiology. So these are simple etiology framework which should be used at each level, that is seizure type, and epilepsy syndrome. On the left, we are seeing column of comorbidities. Comorbidities like behavioral issues, cognitive issues, learning disabilities. So these are important for the prognosis of seizure or epilepsy and management point of view. So this is simple framework, and everyone dealing with seizure should be aware of this simple framework, and it is quite handy. So after refreshing the basic terms like seizure, epilepsy, so we should know what is provoked versus unprovoked seizure. So provoked seizure, also called as acute symptomatic seizure, is characterized by specific trigger like fever, CNS infection, electrolyte imbalance, head trauma, hypoxia, intoxication, and other provoking factors. Whereas unprovoked seizure is not associated with obvious precipitating cause, and it may be related to epilepsy. Then first unprovoked seizure. Eiley defines first unprovoked seizure as a seizure occurring in a person over 1 month of age with no prior history of unprovoked seizure. This definition includes multiple seizures within 24 hours with recovery of consciousness between seizures. This definition excludes neonatal seizures, which we already discussed. The incidence of first unprovoked epileptic seizure in children is around 40 to 104 per lakh children per year. So after knowing the definition of first unprovoked seizure, and we are dealing with first seizure case, we should know whether it is first seizure, because 7 to 10% presenting as first unprovoked seizure may have had seizure in the past, which may go unnoticed or unrecognized. Then nocturnal seizures could often being missed. Then vomiting or other autonomic phenomena may sometimes go unrecognized. And natural history of seizure type or epilepsy, like when the child with absence epilepsy comes to you, it is very unlikely that he comes with first episode. So common causes of unprovoked seizure. Unprovoked seizure can be remote symptomatic seizure, that is secondary to pre-existing brain insult which happened more than 7 days ago. Then epilepsy syndrome, an unidentified or idiopathic cause. So recurrent unprovoked seizures is equal to epilepsy. So approach to first unprovoked seizure. So going before detailed investigation, we should be confirmed that whether this episode was an epileptic seizure or not. Misdiagnosis of epilepsy is made in significant number of children who have never had an epileptic seizure. Up to 30% of children referred to for first seizure have not had any epileptic seizure. Good history taking is a key to distinguish between an epileptic seizure versus non-epileptic event, whereas video record of the event is extremely useful in these cases. So good history means state of child during event, presence of aura, description of event, post-ictal changes, prior developmental history, family history, history of prior brain insult. These all will help to differentiate whether it is a epileptic seizure or non-epileptic form event. Presence of tongue bite, urinary or bowel incontinence mostly suggests seizures, but sometimes it can happen in some anoxic event like prolonged breath holding spells can sometimes also cause urinary or bowel incontinence. The common seizure mimics in children are breath holding spells, which can be confused with tonic spasm, then syncope, migraine. Migraine can be confused with temporal lobe epilepsy or occipital lobe epilepsy, then transient ischemic attack, panic attack, stereotypes and tics, hyperventilation episodes, psychogenic or pseudo seizures. Sometimes GERD can also mimic like seizure. Then benign sleep myoclonus, which can be confused with frontal lobe epilepsy or nocturnal benign epilepsy like Rolandic seizure. I'm not going in very details to this. After going through all these hurdles, and once we confirm that it was seizure and it was first and it was unprovoked, then we proceed for further evaluation. So further evaluation is what was seizure type, if it fits in epilepsy or epilepsy syndrome, what was a general etiology idea, then investigations, treatment and counseling. So before going investigation, the focus examination is very much important in every case with first unprovoked seizure. We should first know what was the level of consciousness, child was in encephalopathic or not. Then some neurocutaneous marker which are specific to neurocutaneous disorders like capillary spots found in neurofibromatosis, Ashley macules found in tuberous sclerosis, facial photo-Weinstein or specific to Sturge-Weber syndrome, mucosal and skin telangiectasia are characteristics of hereditary telangiectasia. Then ophthalmic examinations, fundus for papilloedema, intraocular cysticercus, then ocular telangiectasia. Then focal neurological signs like hemiparesis, facial nerve weakness, vision problem, dysmorphic features, microcephaly, syndromic association, organomegaly, behavioral and cognitive issues. These all points are important while evaluating a child with first unprovoked seizure. This will help to guide us for the etiology. Then what is the recurrence risk after first unprovoked seizure? Why evaluation of first unprovoked seizure is important? That many studies concluded that around 40% will have another seizure, and this risk increases to more than 60% after 7 unprovoked seizure. The majority of recurrences occurs within the first 6 to 12 months. 80 to 90% of children after first unprovoked seizure recover within 2 years of first episode. That's why we consider at least 2 years seizure-free interval before tapering or stopping any anticonvulsant medications. Then the recurrence risk for remote symptomatic cause is more. That is 50% compared to an idiopathic cause, in which it is 30 to 50%. Then common risk factor for seizure recurrence, like remote symptomatic cause, abnormal neuroimaging, abnormal EEG, that is focal changes versus background suppression. Then nocturnal seizures are more likely to recur. Focal seizures, prolonged postictal state, family history of epilepsy. Status epilepticus is as such not a recurrence factor of seizure, but the child with status epilepticus, if he have second seizure, it is more likely to a status epilepticus only. Then there was one trial, MACE trial, that is called as multicentral trial for early epilepsy and single seizure trial. They prepared one prediction of prognostic index, which is helpful for prediction of risk of seizure recurrence. It has some criteria like one seizure prior to presentation has 0 score, 2 or 3 seizures prior to presentation scored 1, 4 or more seizures prior to presentation scored 2. Neurological disorder deficit like learning disability or developmental delay scores 1, abnormal EEG scores 1. On the basis of these 5 criteria, we classify for seizure recurrence like low risk group, medium risk group, high risk group. So if the final score is 0, then there is low risk. If the score is 1, then it is medium risk, and the score is around 2 to 4, then it is high risk for the recurrence. It is simple and we can use it in OPD basis practice also. So important blood investigation in child with first unprovoked seizure. So routinely CBC, blood sugar, electrolytes, serum calcium are done in every case with first unprovoked seizure. Sometimes whenever you suspect like metabolic, like biotinidase deficiency level can be done at that time. EEG is an important non-invasive and inexpensive diagnostic tool for the detection of seizure and further recurrence risk. It is extremely useful for classifying seizure types or epilepsy syndrome, recognition of subclinical seizures, recognition of encephalopathy or metabolic state, and to define long-term prognosis. The EEG abnormalities are more likely detected if EEG is done within first 24 to 48 hours. Up to 4 weeks, we can get EEG abnormalities after first unprovoked seizure. Is EEG must after first unprovoked seizure? There are many studies which found that there is increased risk of recurrence in a child who had epileptic activity on EEG. Like study by Stronick in 1998 found that a recurrence rate of 71% in children who had epileptiform activity on EEG. Schinner in 1994 also found that 54% children with epileptiform activity on EEG experience a second seizure. Paulman and Eden in 2018 in their study concluded that abnormal EEG, especially focal abnormality, seems to be an excellent predictor of seizure recurrence. EEG after first unprovoked seizure is found to have 57.8% sensitivity and 69.6% specificity for seizure recurrence. If an initial EEG is normal, then sleep-deprived state EEG, prolonged 24-hour video EEG, or serial EEG monitoring increases the diagnostic yield of detecting epileptiform activity on EEG. American Academy of Neurology recommends EEG to be performed after all unprovoked seizure in children. Then another important investigation is neuroimaging after first unprovoked seizure. Neuroimaging is useful to know the cause or etiology, to define prognosis, and to decide whether to treat or not on the long-term basis. Neuroimaging after first unprovoked seizure helps to identify epileptogenic focus in around 20%. And in case with focal onset seizure, the percentage is around 53%. While doing neuroimaging, MRI is clearly superior to CT scan except in unstable cases. So indications for neuroimaging in a child with first unprovoked seizure, we should advise neuroimaging in cases with developmental delay, abnormal CNS examination, focal seizure, status epilepticus, prolonged postictal state, abnormal EEG, or infants, that is age less than 1 year. Emergency neuroimaging after first unprovoked seizure. American Academy of Neurology recommend emergency neuroimaging after first unprovoked seizure only in children with prolonged postictal focal deficit or prolonged altered consciousness after seizure. So after evaluation, that is doing basic tests like EEG, MRI, blood investigations, it is decision whether antiepileptic drugs to be used after first seizure or not. It was common practice in the past thinking that all seizures were likely to recur. Seizures could be detrimental, causing permanent brain insult. Antiepileptic drugs were safe and with fewer side effects, and antiepileptic drugs prevent seizure recurrence. In psychological consideration, first seizure can cause significant anxiety to parents and medical practitioners. Taking daily antiepileptic drug is not an easy act. Child who is taking long-term anticonvulsant is perceived to have a long-standing illness by child, family, and school. And there is also burden for the family, both economical as well as psychological. So to decide whether to start antiepileptic drug therapy after first unprovoked seizure, we have to weigh between risk of seizure recurrence and a risk of side effect of antiepileptic drugs. Initiating antiepileptic drugs immediately following first unprovoked seizure reduces the risk of subsequent seizure, but it did not change the long-term remission or it impact overall mortality. This is Cochrane review, May 2021. That means treatment with antiepileptic drug is not indicated for the prevention of development of epilepsy. Treatment with antiepileptic drugs may be considered in circumstances where the benefits of reducing the risk of second seizure outweighs the risk of pharmacological side effect and psychosocial effects. So when we are in OPD or IPD setting and we are dealing with a child with first unprovoked seizure and child is still convulsing, then we can use in IPD setting IV lorazepam in the dose of 0.05 to 0.1 mg per kg, IV midazolam in the dose of 0.1 to 0.2 mg per kg, IV diazepam in the dose of 0.3 to 0.5 mg per kg. Whereas in OPD setting, it is we can use intranasal midazolam spray that is 0.2 mg per kg, or sometimes rectal diazepam, that is 0.5 mg per kg. The anti-epileptic drug of choice, the common, like for primary generalized tonic-clonic seizure, we commonly use valproic acid as a first choice, or sometimes lamotrigine topiramate, and alternative are phenytoin, carbamazepine, oxcarbazepine, phenobarbital, zonisamide. For partial seizure, carbamazepine, oxcarbazepine are drug of choice. Phenytoin is also drug of choice, but we can also use valproic acid and other anticonvulsant like topiramate, levetiracetam, zonisamide, and others. In case of absence seizure, ethosuximide and valproic acid are drug of choice, and we can also use lamotrigine or clonazepam. In case of atypical absence, myoclonic or atonic seizure, valproic acid, topiramate are drug of choices. We can also use lamotrigine, clonazepam, or felbamate. This is general idea. Then the next question is how long to continue antiepileptic drug after first unprovoked seizure. The duration of antiepileptic drug depend upon the etiology, like it is structural, infective, or metabolic. In cases diagnosed as epilepsy or epilepsy syndrome, continue treatment for at least period of 2 years seizure-free interval. Recurrence risk of 25% following stopping of antiepileptic drug needs to be explained to parents. Documenting a normal sleep EEG prior to stopping anti-epileptic drug is recommended. Take home message: don't take single unprovoked seizure casually, as it could be epilepsy. EEG to be performed after all first unprovoked seizure. Treatment with anti-epileptic drugs may be considered in circumstances where the benefits of reducing the risk of second seizure outweighs the risk of side effects. Counsel the parents regarding seizure or epilepsy type, recurrence risk, need of investigation, role of anti-epileptic drug, and use of midazolam nasal spray at home. Thank you.
Thank you so much, Dr. Maruti. Your delivery was very engaging and relevant. We'll open the forum for discussion and questions now. I don't think we have any questions from the delegates. We'll invite delegates to put down their questions in the chat and the question answer box whenever they feel like it. We'll have a question answer session after each talk.
Yes, ma'am.
I have a small question for you.
Yes, ma'am.
Suppose it's your professional opinion that your patient does not need treatment, but the parents are very scared of subsequent seizures, which might lead to brain damage, physical injury, or even death. So how do you balance this, the psychosocial consequences with the side effects of the drugs?
Ma'am, actually, if the parents are very anxious and they want to start treatment only, then we can give them option to start anticonvulsant drugs, but also to counsel them what are the long-term side effects and recurrence risks, because recurrence occurs in only around 40% cases, but still if they want to they insist, we can start anti-epileptic drugs therapy.
There might be other scenarios like the patient is from an interior village, he doesn't have access to emergency medical services, or the parents are not very educated or aware. In those cases, probably we'll have to make an individual decision.
Yeah,
ma'am,
this is purely individual decision. We have to base on the basis of side effect or and then we can advise them domiciliary management, like use of Midas spray, recovery position. So this will help.
I see. Thank you so much. It was so wonderful to have you here on a Sunday morning.
Thank you, ma'am.
So basically, we have to remember that it's an individual decision that a doctor has to make for each and every case.
Yes, ma'am. Yes,
thank you for sharing your valuable time and insights with us.
Thank you, ma'am.
We'll move on to the second topic of the day. We have Dr. Pankaj Bhansali here, who will be speaking on pediatric hematuria, a very worrisome symptom for parents. Dr. Bhansali is a consultant pediatric nephrologist practicing in Aurangabad and is well known in pediatric circles all over Marathwada. He also has a unique distinction of opening the very first pediatric nephrologic unit in Aurangabad. He has been a blessing for small children with kidney ailments here. I'll hand over the mic to you now, sir.
Thank you, ma'am. Congratulations, Manish sir and Sandeep, for organizing such a wonderful program and giving me opportunity to be part of it. Now I'll share my slides, ma'am. Good morning, everybody. So today I'll be discussing about hematuria. That is, how shall we proceed once we see red colored urine in pediatric patients? Once parent sees red colored urine, it causes a lot of panic in parents and kid as well. So whether he will require hospitalization, whether his child is very sick, may he need surgery also. So these questions we'll try to answer in further slides. We'll start
Dr.
with
Pankaj,
cases. Yeah.
I request you to go to full screen.
For my slide, it is full screen. I'll redo again.
Yeah, please try.
So is it full screen now?
No, sir, we can
No.
only.
It's okay, Pankaj, you can continue.
Sir.
Touch. Yeah, you can go ahead.
So we'll start with cases. A 5-year boy came back from school trip with red colored urine. There were no other symptoms like edema, oliguria, hypertension, or any lower urinary tract symptoms. And neither there was fever. Examination was done, urine was normal, KFT was normal, and even sonography was normal. So before we jump on the hematuria, let us remember that all that is red is not always need to be a urine. So there are a lot of other factors which can color urine red and confuse us and parents as well. So these are the list of agents. The one of most common agent what we are seeing recently are the coloring agents which are used in lot of chocolates and other eating material. So before jumping on evaluation and aggressive investigations, let us first rule out, is it really urine in the blood? Sorry, blood in the urine. So these are few simple ways to confirm it. We do urine microscopy. If urine microscopy shows RBCs, it confirms hematuria. But if urine microscopy is normal and still urine is red, we can use reagent strips where they will become chemically are there heme molecules in the blood. And if microscopy is negative but reagent strip is positive, then it is probably hemoglobinuria or myoglobinuria. And if both are negative, then it is coloring agent. Another test which we have been taught from our UG and PG, we can centrifuge the urine sample. If there is a precipitate at the bottom of test tube, then it is always hematuria. But if it remains consistently red throughout the tube, then it is either hemoglobinuria or myoglobinuria. Hematuria generally we divide in two subtypes. One is gross hematuria and another is microscopic hematuria. Gross hematuria is obvious, parents will come with the complaint, but microscopic hematuria is many of the time picked up when child is screened from some other disease, or sometimes it is screened when he is planned for some surgical intervention as a preoperative checkup. But one report showing RBCs is not significant. First of all, there should be more than 5 RBCs in high power field of a urine to label it as a microscopic hematuria. So if it is less than 5, it may be harmless, benign, and non-specific leak of RBCs in the urine. But even presence of one urine showing RBCs is not sufficient. We should have at least 2 urine samples out of 3 done over 2 to 3 weeks of duration. So once we diagnose hematuria, now what are the points? First and foremost, we should recognize and confirm whether it's hematuria. And once we confirm, try to find out what are the common etiologies behind it and pick up the patients which warrant further investigations and may require a referral for further management. Now, second case, a 6-year boy present with generalized tonic convulsion, no fever, trauma, or medications. I know just now we have a talk on seizures, but this being a nephro talk, I'm not going to go in detail about EEG. And MRI was done and which showed PRES, posterior reversible encephalopathy syndrome. Now this is very I won't say is the ideal way to pick up press after getting MRI. So what we missed here, we missed checking blood pressure. And honestly, this is very common scenario. Many of the time, hypertensive encephalopathy is picked up on MRI, and before that, blood pressure has not been checked. So whenever child presents with convulsion, make sure to check blood pressure. Once hypertension was there, then investigations of renal function and renal etiology started. Urine showed albumin 3+, RBCs, it was not gross hematuria, but urine RBC showed 8 to 10 RBCs, so it is significant. Pus cells 5 to 6, creatinine was elevated. As there was proteinuria, we even tried to rule out nephrotic picture, but albumin was 3.6. So then second possibility, nephritis. So we went ahead with ASLO, which was also normal, less than 200. Sonography had shown raised renal echogenicity, and sonologist mentioned it is a suggestive of nephrotic syndrome. Now, before going further, USG is not the diagnosis to pick up nephrotic, nephritis, UTI. These are not based on sonography. So
Dr. Pankaj,
yeah.
Sorry to interfere again, but your slides are not moving.
I don't know.
Could you please just exit full screen and then just keep it like that?
Okay.
Yeah, I can see the first slide now.
Yeah, are slides moving right now?
Yes, yes.
So shall I keep in this mode only or try to?
Yes, yes, keep it like this only, sir.
Okay, okay.
Thanks.
Thank you. Okay. So USG is not the ideal way to diagnose all these things because increased echogenicity is many of the time misinterpreted with nephritis, nephrotic or pyelonephritis. But now in this child who don't have history of throat infection, there is no gross hematuria, neither ASLO is increased. So can we really label it as a acute glomerulonephritis? Now throat infection is not always, should not be always there to pick up glomerulonephritis. Gross hematuria is present in hardly 60 to 70% of the patient, but microscopic hematuria is present in 100% of the patients with acute glomerulonephritis. So absence of gross hematuria is also does not rule out acute glomerulonephritis, and normal ASLO is not at all sensitive or specific pointer for picking up nephritis because it is positive in hardly 50 to 60% of the patients. So that's why nephritis is never a diagnosis based on just hematuria or ASLO. Now we have nephrotic range proteinuria also, but nephrotic range proteinuria can be there in acute glomerulonephritis, particularly in first 2 weeks of the disease. But we don't see low albumin or raised cholesterol in acute glomerulonephritis. So presence of nephrotic range proteinuria, let us not confuse that is a mixed nephritis or nephrotic picture. So what is another important test that will help us to guide is C3. And C3 is very low in acute glomerulonephritis. So low C3 with presence of microscopic hematuria, hypertension, and deranged creatinine, our first and foremost diagnosis is acute glomerulonephritis. Now, what are real problems in acute glomerulonephritis and what can really kill the patient are hypertension, fluid overload, and hyperkalemia. So another investigations here I'm emphasizing is potassium. Whenever we see deranged creatinine, make sure that we have electrolytes in our hand. And by some reason, if we are not able to get electrolytes, at least get a EEG to look for EEG changes of hyperkalemia. And all these three are emergency, which require ICU care and immediate and urgent interventions. All of us know how to treat glomerulonephritis, so I'm not going in detail, just to mention few points. Do not start an IV fluid. Sometimes we are forced, but particularly in these patients with acute renal failure or oliguric renal failure of any cause, avoid IV fluid unless child is altered sensorium. And in that also, if we are forced to start IV, avoid potassium into the IV fluid. Medicines of choice are definitely diuretics because they will reverse the physiology pathology of glomerulonephritis. So remove extra fluid and salt, and it will take some time to work. So by that time, we should add antihypertensive. The preferred medicine will be calcium channel blocker or alpha or beta blockers. Don't use ACE inhibitors or ARBs because these further decreases GFR, can worsen creatinine, and can cause significant and problematic hyperkalemia. Now, role of the antibiotic. Yes, we do use not for treatment of AGN, but treatment of prevention of carrier. So if we are treating carrier and if source is skin infection, I don't think antibiotics are going to work because already skin infection will be cured by 2 to 4 weeks. Steroid, strictly no, unless we have reached some diagnosis. When we need earliest reference in acute glomerulonephritis, so what are the pointers for poor renal outcome? One is anuria. Most of us have seen that even if it is acute glomerulonephritis, we hardly ever see complete anuria. And even if there is oliguria, it responds well to furosemide. So if there is no response to furosemide, it is an indicator that we need to rush for dialysis and rapidly rising creatinine. So these three markers will warrant reference for nephrologist and need of dialysis and biopsy. When do PIGN resolve? We expect resolution of gross hematuria, hypertension, and nephrotic range proteinuria within 2 to 3 weeks. C3 shall normalize by 8 to 12 weeks. Gross microscopic hematuria can persist almost up to 1 year. So if any of this has not reached by the stipulated time, we need to go ahead with biopsy. Second case, now looking at the photos, I think the first differential in our mind will be nephrotic syndrome, significant ascites, periorbital puffiness, otherwise okay looking child. But when we got the investigations, also child had hypertension, albumin was 4+ with hypoalbuminemia and raised cholesterol. So nephrotic component is there, but along with that, there are significant RBCs, and creatinine is grossly elevated. Now what it is this? This is definitely mixed nephritic plus nephrotic picture. So shall we start on steroid? Yes, we need to start on steroid, but biopsy is mandatory because biopsy finding will help us in decide after steroid which medicines we need, how long we need to continue immunosuppressants, and what will be the outcome of this patient. So in this patient, unless child is not in condition for biopsy, first child should be biopsied and then started on steroid. A 4-year boy, another case, a 4-year boy presented with fever of 3 to 4 days duration. There was no obvious focus and developed hematuria. Urine albumin was 1+, RBCs 15 to 20, pus cells 3 to 4. Now, before I proceed, one point I want to add. Many of the time we see pus cells in the urine sample with hematuria. Even for pus cells, we consider more than 5 pus cells as a significant, but pus cells is not equivalent to infection. So even if we see pus cells and there are no other pointers for infection, don't consider as UTI and start antibiotic and relax, because presence of pus cells is just an inflammation. So any interstitial nephritis, glomerulonephritis, renal stone, anything can cause pus cells. So again, pus cells is synchronous, not a synchronous for infection. Now in this child, significant RBCs were there and albumin 1+. When we went in history and investigations, we could not find anything in that. But what was in history was mefenamic acid. Probably with awareness of most of us, we have stopped using nimesulide. Use of ibuprofen has also drastically dropped. So another drug which is commonly used when fever is not well controlled with paracetamol is mefenamic acid. And this can cause hematuria. Mefenamic acid induced hematuria is because of interstitial nephritis secondary to NSAIDs. But the good thing is that most of them do recover well. Safest drug is definitely paracetamol, but all of us know practically many of the time we see a patient where fever is not coming under control and parents are losing their patience. So we are forced to use mefenamic acid. But during the use of any NSAID, ensure that hydration is well maintained. The most high risk factor for renal toxicity along with use of NSAID is dehydration, and which is common when child is in fever, when oral intake is very poor. So maintain adequate hydration to avoid complications secondary to NSAIDs. And the good thing is that it recovers well. So with just conservative management and use of paracetamol, fever resolved. Fever resolved and gross hematuria subsided. Now, do we need to follow? Yes, definitely. Whenever we see RBCs or protein in the urine, we should follow it up till everything resolved. Now, what are the indications of biopsy in these patients? If along with that we see deranged renal function, we see significant proteinuria and persistent hematuria. Why do we biopsy? Because there is a subgroup of interstitial nephritis which will be benefited with use of steroid. So it will cause a complete recovery. We have seen a lot of patients, particularly with adult with diclofenac, sometimes with ibuprofen also. If all the features related to interstitial nephritis does not resolve within 7 to 14 days, steroid may help in complete resolution and prevent progression to chronic interstitial nephritis. So child should be followed up till resolution of proteinuria, hematuria, and normalization of creatinine. Another case, a 6-year-old boy presents with second episode of isolated gross hematuria. What I mean here, isolated means along with hematuria, there are no other complaints like hypertension, no systemic features like fever, rash, arthritis, no proteinuria, creatinine is normal. So it is isolated hematuria. Investigations have suggested same, albumin is nil, KFTs are normal, and no urinary tract infection with normal sonography. So child had 2 episodes of gross hematuria with a gap of 3 months. Hematuria is always panic, and if it is causing recurrence, it will definitely create problem and trouble. And frankly, this is one spectrum of hematuria where we are also troubled. So here we need to distinguish between glomerular and non-glomerular. We see generally we have been taught cola-colored urine is glomerular, but remember, if urine is stagnant in the bladder for longer time, its color changes because change in the acid milieu of urine collected in the bladder, and it can turn into cola-colored. Hypertension goes in flavor of glomerular hematuria. But if child has dysuria, abdominal colic, abdominal pain, abdominal lump, it is a non-glomerular. But when there are clots in the urine, it is 100% non-glomerular. And when there are RBC casts in the urine, it is 100% glomerular. When asked in detail about history, father had history of renal calculi. So we went ahead to check for urinary calcium, and calcium creatinine ratio was significantly elevated. So when calcium creatinine ratio is elevated, we need to differentiate it whether it is associated with systemic hypercalcemia or normal serum calcium, and child had normal serum calcium. So it was a primary hypercalciuria. Now this is a relatively benign disease as long as we don't see nephrocalcinosis or renal stones, and can be managed conservatively very well. But before labeling it as a primary hypercalciuria, make sure that you have ruled out protein excretion in the urine, because primary hypercalciuria has been found in almost 5% of the patients in general population, and it's a huge number. So if we see primary hypercalciuria, make sure that we are not missing some glomerular etiology, and for that get a simple test, protein creatinine ratio, and if it is a normal, we are ruling out most of the glomerular etiologies which can cause hematuria. So what are the causes of recurrent gross isolated hematuria? In glomerular cause, IgA nephropathy, Alpert's disease, and thin basement membrane disease. The last one is benign, but first two needs regular follow-up, because if IgA nephropathy develops proteinuria or any other features, we need to biopsy and start on immunosuppressants. And Alpert's with time will progress to chronic renal failure. In non-glomerular cause, we have idiopathic hypercalciuria, calculi, sickle cell disease, tumor, and another favorite entity when we don't find anything is exercise-induced hematuria. There is no way to prove or disprove it. It's generally diagnosis of exclusion. Once we have ruled out all other pathologies, and we always correlate hematuria with exercise, then only we can label it as an exercise-induced hematuria. Non-glomerular causes are more common in isolated hematuria, and almost in 1/3 of the patient, we end up finding no diagnosis and proceed for biopsy just to rule out. We hope that we don't miss any significant renal disease. The last case, a 7-year-old female, otherwise healthy, asymptomatic, went for school health checkup and urine showed RBCs. Rest findings were normal. Now here, shall we be worried or no? Now, how do we proceed in asymptomatic, isolated, and microscopic hematuria? We have seen gross hematuria. Now we are discussing microscopic hematuria. We shall repeat microscopy almost 2 times in next 2 weeks. If we see more than 2 reports showing significant RBCs, that means more than 5 RBCs in the urine, then we need to evaluate and ask history in detail. Ask for family history, because that will be an important clue where we should work up. Look for edema, hypertension, assess proteinuria. Urine routine is not sufficient. Either 24-hour urinary protein or protein creatinine ratio is mandatory. Confirm creatinine is normal. Rule out hypercalciuria. Screen for family members, because when there are significant family members also may be having same disease with isolated microscopic hematuria, and they may be asymptomatic. So that will be an important pointers, and our list of probable cause will be narrowed to very few diseases. And most of them resolve spontaneously. If it persists for more than 1 year, I think it's a time to consult pediatric nephrologist. But remember, when it is an isolated hematuria, isolated means, again I'm repeating, no proteinuria, no hypertension, no deranged creatinine, and no systemic features. Hematuria per se does not damage kidney. As a nephrologist, we are not worried of hematuria, rather we are worried of proteinuria. So there are no significant renal diseases as long as it is isolated hematuria. And if an isolated hematuria persists, probably we can continue follow-up. Unless parents are very anxious, then only we proceed for biopsy. But when hematuria remains no longer isolated, we need to proceed for biopsy. We followed up this child, and after 1 year, when we re-evaluated, protein creatinine ratio has increased, and USG also had shown increased renal parenchymal echogenicity. That means there are changes in glomerular already. We biopsy, and it was a Alport syndrome. So now Alport's has bad prognosis, but whatever it is, there was no point in biopsying earlier, because that would not have changed our management. Same thing of IgA nephropathy also. Now it's easy to rule out by simple biopsy, but if there is IgA nephropathy and no proteinuria or no other features, we are not going to treat, or we are not going to give any medicine and just follow up these kids. So that's why biopsy will be warranted only when hematuria is associated with other symptoms. Thank you.
Thank you so much, Dr. Pankaj. We thoroughly enjoyed your talk. We have a couple of questions for you. These are from Dr. Suhas Bendrikar. He wants to know, in which cases should we screen for hypertension in children?
Hypertension shall be screened. It is recommended that any child above 3 years should have blood pressure checked at least once a year. And if child has history of renal disease, endocrine disease, cardiac disease, then even child less than 3 years should be screened annually. So every child above 3 years in OPD should have hypertension at least once a year.
I see. He also has a follow-up question. What is the correlation of repeated UTI with renovascular hypertension?
No, there is no correlation between repeated UTI and renovascular hypertension. But yes, repeated UTI can cause reflux nephropathy. And reflux nephropathy is one of the high risk factor for hypertension, but it is not renovascular. It is due to parenchymal injury, which increases renin secretion and causes hypertension. Probably it is one of common cause where we see early onset hypertension in second decade. So probably second decade hypertension, DMSA scan is mandatory to rule out for reflux nephropathy causing scarring.
Right. I also have a simple question for you. In which cases can we safely treat isolated gross hematuria at home, or we should always admit such cases?
Ma'am, isolated gross hematuria, I think I will hospitalize for a day or so to check for blood pressure and evaluate everything. So in that, as I said, if creatinine is normal, no proteinuria, no systemic features, then probably, and no hypertension, probably we can discharge and follow up every third day just to confirm whether hematuria has resolved. We expect complete recovery of gross hematuria whatever might be the cause, whether it's a drug, stone, or any other disease, within 2 to 3 weeks. If it persists beyond that, then probably it's a time to referral. If it persists beyond 2 weeks, isolated hematuria.
Right. Thank you so much. We don't have any more questions. In case the delegates have any questions, you can write them down in the box. And Dr. Pankaj, if you have time, you can give written answers then.
Yes, ma'am.
I'll hand over the podium now to Dr. Mayura. She'll be hosting the rest of the CME.
Manish sir is...
Yeah, Mayura is a little late. Am I audible?
Yes, sir.
Though this is going to be a pediatric CME, there are many occasions on which pediatricians, they encounter the surgeons. It is like, and we are going to have an ophthalmologist on the board, ophthalmologist, ENT surgeon, orthopedician, as well as a plastic surgeon. So I would take privilege to introduce the next speaker, who is a surgeon and who is a ENT surgeon. So I'm glad to introduce you Dr. Shyam Somani, who is a senior ENT surgeon at Latur and who has a tremendous work in a pediatric stridor as well as laryngoscopy and I mean all interventional pediatric ENT work he does. So it is over to you, Dr. Somani, sir. Piyush?
Yes, sir.
Dr. Somani, sir?
Yes. I'm sharing my screen. Am I audible?
Yes, sir.
You are audible, yeah. Screen we can't see, sir.
Now it is, the screen is seen.
Not yet, sir.
Yeah, not yet. It is in process.
Presently,
Apparently, it's on the last slide. Yeah. Please make it full screen, sir, if possible. Yeah, it's all done, sir.
Okay.
Yes, sir, all well.
First of all, thank you for involving me in your CME, and all pediatricians, I suppose, are the audience. My topic is on congenital stridor. Am I audible? Hello? Hello?
Yes, sir, we can hear you.
Okay. My topic is congenital stridor. My first half of the talk would be on diagnosis of congenital stridor. And diagnosis best possible is by history, clinical examination, imaging, and endoscopy. I believe endoscopy is a must for diagnosing any kind of congenital stridor, so that we can pinpoint the diagnosis, because every stridor may not be a Laryngo Malaysia. Okay, so we'll start with how to diagnose a case with infant or neonate with stridor. There are many conditions where stridor occurs in a neonate or newborn, and commonest being Laryngo Malaysia, followed by either vocal cord palsy, subglottic stenosis, laryngeal cleft, cyst, webs, Tracheal Malaysia, atresia, hemangioma, all other conditions they follow, though rare. The symptoms with which the patient comes are respiratory obstruction, stridor, weak or hoarse cry, dyspnea, tachypnea, all other symptoms. And failure to thrive is one of the symptoms where patient doesn't gain weight. Now, as we all know as a clinician, history is a main important thing, whether the child is premature with medical problems, whether there is an intubation at the time of birth, asphyxia is there, and whether it was acute onset or it started after 2 weeks or so. and any fluctuations which is related to position and feeding and choking attacks. All these things are important when we take history, and it gives a lot of clues regarding to the diagnosis. And as we discuss every condition, we come to know that how the history becomes more important. The physical examination is again just an observation how the stridor is, whether it is inspiratory, expiratory, biphasic, whether the retractions are there, whether all these things, and voice. If it is aphonic child, or the child with a weak voice and stridor in different positions. Imaging, of course, neck films or chest films, they do help, but their role is very little. What comes next is a flexible endoscopy under local anesthesia, preferably, because general anesthesia, we don't give a patient with a stridor. And direct laryngoscopy or bronchoscopy under GA is very rarely indicated, and very few indications are there for diagnosing under general anesthesia. Flexible endoscopy under local anesthesia is very safe. It evaluates nose, nasopharynx. Say, for example, any nasopharyngeal mass you can diagnose. Then larynx, tracheobronchial tree, hypopharynx, everything from nose to bronchial tree, you can examine with the flexible. And contraindication, only contraindication in severe stridor or cyanosis, you may not be able to do even flexible scoping. Say, for example, subglottic stenosis, you cannot pass a scope beyond the subglottic stenosis. You can just visualize that, that's all, because you are going to add to the inflammation. General anesthesia carries itself risk, does not assess in physiological state, and indicated in only a few conditions like laryngeal cleft or subglottic stenosis. How flexible scopy is done? It's a pre-oxygenated child with decongestion of the nose, and nebulization preferably with xylocaine or without nebulization is also done. No sedation and in awake condition and in operative room. And monitoring, of course, all is needed. The scope can be passed transnasally or transorally. The scopes which are commonly used are with the suction channel, because that helps in sucking out the secretions, saliva, so that you can have a better visualization of the structures. The commonest scopes which are used are 3.2 millimeter diameter or 2.8 millimeter diameter with the suction channel of 1.2 millimeter. This is connected to the camera and recording system. And then examination starts from nose, nasopharynx, oropharynx, and then larynx and tracheobronchial tree. Now this is a child with a slight mild inspiratory stridor. Here you can just hold the child and pass the scope through the nose, and it just passing like a rails tube. You just lubricate the scope, hold the child, and see it connected to the camera, and you can observe everything on monitor. This is how the endoscopic picture of the larynx will look like. Now, commonest condition which we look into in a child with a congenital stridor is a Laryngo Malaysia. And the classical features of Laryngo Malaysia are a very oblong epiglottis, long elongated epiglottis, short afold. At the same time, we can pass the scope through the glottis and we can visualize right and left tracheobronchial tree, or left and right bronchial tree, carina, and tracheal area also. So this is the advantage that we can examine the whole tracheobronchial tree. The Laryngo Malaysia itself, as it is described also, it's an omega shaped epiglottis. The epiglottis is omega shaped. The aryepiglottic folds are short, and the arytenoid mucosa is with redundancy. Everything from supraglottis falls in the glottis and causes stridor with every respiration. Sometimes, if the severity is there, then the epiglottis may fall inside with every inspiration. And this is one of the severe Laryngo Malaysia where epiglottis fixation is also needed during surgical correction. So these are few videos which show how the Laryngo Malaysia look like on endoscopy. Another condition is valvular cyst. Here the presentation is almost same with choking attacks during feeding, and sometimes it is associated with the Laryngo Malaysia because this valvular cyst lies in the valvular fossa and presses the epiglottis with each respiration. So this is one of the common conditions where we get respiratory difficulty, and it is treatable and easily amenable to surgery, and stridor can be relieved completely. Here just marsupialization is a treatment for valvular cyst. Another that rare condition is a bilateral hucal cord paralysis. How to diagnose bilateral hucal cord paralysis? The hucal cord abduction is absent. Only adduction. What happens here is child is having a normal cry, voice is normal, and severe inspiratory difficulty. The moment we intubate this child, the stridor is gone. So this is another example how the bilateral abductor palsy. One of the reason is it may be acquired, like Arnold-Chiari syndrome or anything which is causing bilateral vagal affection can cause, or posterior fossa lesions can cause bilateral abductor palsy. In absence of all those lesions, it may be just idiopathic where bilateral hucal cords are not abducting. So we have to do imaging in those cases. Isolated left hucal cord palsy or right hucal cord palsy, that for that matter, can be seen very effectively, very easily. Here it is a left hucal cord palsy where left hucal cord is not moving, right hucal cord is moving. Here we have to investigate the child by doing anything, whether anything is there in the chest or mediastinum, which is causing left hucal cord or left recurrent laryngeal nerve affection, and treating accordingly. Even a cardiac status we have to find out. Here the child has very weak cry or very minimal cry. The phonation and the sound intensity is very less. So otherwise the child doesn't need treatment. You have to just observe and see for lower tracheal any obstruction in that case also. One more serious condition is a subglottic stenosis. Subglottic stenosis may be congenital or acquired. Congenital subglottic stenosis has different gradings by Cotton's classification. It may be 25%, 30, 50%, 75% or so. In some cases, if the child is intubated and if the intubation is a bit traumatic or the child is ventilated on ventilator for some time, then one can expect acquired subglottic stenosis. How to diagnose? Just see the lumen below the glottis, and if the scope is not going to get negotiated, you just understand that this is subglottic stenosis. A few rare things like vascular compression in the mediastinum can cause anterior wall of trachea compression just above the mediastinum, and this is a vascular ring which is abnormal and should be treated by the maybe cardiothoracic or vascular surgeon for decompressing trachea at that level. Tracheal stenosis, though rare, is seen sometimes at a lower level, and one or few tracheal rings may be just circular and you may get stridor. Here the stridor is biphasic and you can negotiate it up to the carina. If you are not able to go to the carina and you are seeing the circular concentric narrowing, that it is tracheal stenosis. Glottic web is one more condition. Sometimes isolated glottic web or a thick glottic web along with the subglottic stenosis may be there. Here the child has absent cry or euphonic child no cry, no sound since birth, and just the child is having respiratory difficulty. Here, while assessing, one should assess the thickness of and firmness of the web and whether it is associated with the subglottic stenosis in association to that. And the treatment is cutting the web anteriorly with laser. These are few of the anomalies, doesn't need much of the treatment, just for documentation. Maybe a tracheal bronchus may be there. But tracheoesophageal fistula is one of the conditions which we can diagnose on flexible scopy by giving some methylene blue to the child. And when the child swallows, you can see the trickling of methylene blue from the posterior wall of trachea, and easily can diagnose that there is a leak. This can help in postoperative assessment of tracheoesophageal fistula also. So these are the few anomalies, the commonest being Laryngo Malaysia. In some studies, it is reported up to 75% of the congenital stridor may be due to Laryngo Malaysia. Rest of the conditions are in sequence: focal cord palsy, subglottic stenosis, valvular cyst. And this is one of the study which we conducted, and the percentage of those, this thing. The advantages of flexible bronchoscopy are it is in an awake state and automatic, and it is in dynamic physiological state, undistorted view because we are not fixing the larynx, and allows examination of nose and all other tracheobronchial tree. Repeated viewing, analysis, and video recording is possible. But only caution is it should not be done in severe respiratory distress. In cricoarytenoid fixation, we need to evaluate by direct laryngoscopy. It's a quick, safe, simple, and cost-effective. I have one more presentation. I'll quickly go to that, and that is regarding how to manage these cases. Is it seen on the screen? Hello? Hello?
Yes, sir.
Yes.
Screen is shared.
Now, another part of the topic is management, how to manage all these cases surgically. Now, this topic, I believe those who are surgeon in the audience may be of interest for them. But as a curiosity, you can just, I'll run through a few of the slides, how we manage Laryngo Malaysia surgically and when to manage and how to manage, and few other conditions. Because in our center here also, we are managing Laryngo Malaysia, valvular cyst, bilateral abductor palsy, then supraglottic all masses, and the glottic web. So all these conditions are managed effectively. Some cases of subglottic maybe, and these are difficult cases. Naturally, subglottic stenosis is one of the difficult case to manage in congenital stridor patients. Now coming to management of Laryngo Malaysia, every pediatrician a neonatologist and pediatrician, they come across these cases quite often. In this presentation, another few minutes, I'll go through what are the types, clinical feature, investigation, medical and surgical management. Now, I'll not go into detail about etiopathogenesis and how it looks, but most common congenital anomaly causing stridor. Secondary Laryngo Malaysia is very rare. What is commonly blamed is a cartilage immaturity and anatomical abnormality or neuromuscular maturity. One of the most common anomaly, more common in boys and maybe severe, and usually starts after 2 weeks of life. Now, there are different types depending on the invert collapse, whether it is a type 1, type 2, type 3, where anterior and medial collapse type 4, and where posterior displacement of epiglottis occurs, and type 5 where short epiglottic folds are there. Now, clinical presentation is very typical. High-pitched inspiratory stridor worsens with agitation, crying, feeding in the supine position. The feeding symptoms are choking, coughing, and prolonged feeding time, and dysphagia and weight loss. Failure to thrive is one of the common symptoms. What are the conditions seen along with the Laryngo Malaysia? Sometimes is prematurity and synchronous airway lesion may be there along with the Laryngo Malaysia. Say, for example, subglottic stenosis, the child will have an inward indrawing of the supraglottic structures. Sometimes it is bronchomalacia, pharyngomalacia, which is commonly associated, and it is very difficult in those cases. Valvular cyst sometimes pushes the epiglottis down. Now, clinical features, as we know, feeding problems is there, abnormal swallow, GERD, and obstructive sleep apnea. What is more important for us is mild cases we can observe. That there is a span with the follow-up. If we find that a case is going from mild to moderate or moderate to severe, then we need to intervene. Otherwise, mild cases are, as usual, can be treated medically and by some modifications in feedings. And they have only occasional stridor and positional, very mild symptoms. But the cases where moderate to severe or severe cases are there, they need surgical management, and the results of surgical management are excellent if the selection of case is good and surgical skills, of course, they are involved. Severe cases, they need surgical intervention. You cannot ask the child, okay, this will go on. The repeated pediatric assessment is needed and is a must, whether the child is really gaining weight and whether how the child's growth is there. Associated syndromes, these are very difficult cases to manage, because these cases, if they are with the associated syndromes, the outcome may not be very good. Now, this we have already talked how the flexible bronchoscopy is done and what are the scopes which are needed. We have seen these videos earlier. How Laryngo Malaysia looks like on Scopy. What are the complications? Because the Scopy part we have already seen, so I'm not repeating that. The complications are poor oxygenation, pulmonary hypertension, alveolar hypoventilation, failure to thrive. Now, in medical management, definitely we have to give some positional adjustments. Then repeated assessment by pediatrician for growth, feeding, and breathing is needed. Reflux precautions and other things are already discussed. Always feed the child with thickening formula feeds and upright feeding position. The indications for surgical intervention are so many, where the child is with a moderate to severe or severe case, and with all those conditions like failure to thrive, stridor with respiratory compromise, pulmonary hypertension, and relative contraindication is difficult to feed child, weight loss with feeding difficulty, aspiration, repeated admission to the hospital with the lower respiratory tract infections. Contraindications for surgery are multi-level airway obstruction, severe neurodevelopment comorbidities or syndromic child, and active infection. Now, this is just regarding anesthesia part. Maybe I can skip over it. And what at our center we do is the child is thoroughly assessed by the pediatrician, neonatologist with the NICU setup. The pediatric or neonatal anesthesiologist looks after the child. The child is evaluated for other congenital anomalies and assessed by a pediatric cardiologist also. Once the child is assessed thoroughly and with no active infection, with the consultation of neonatologist with NICU setup and neonatal anesthesiologist, the child is taken to the theater for surgery. And after surgery, the child is shifted to the NICU another 7 days. So this is how we do in our setup. Now anesthesia is our anesthesia. We are lucky to have anesthetists who can give tubeless anesthesia. So without only inhalational anesthesia is there, and the tube is placed in the nose up to the nasopharynx, and the inhalation of gases of halothane oxygen is given, and TIVA is given. So I get a complete view. What are the different types of supraglottoplasty are either with the cold instruments by cutting, by laser, by radio frequency, or by microdebrider. What is the typical purpose of doing it is opening the larynx. This is just a few pictures showing how the epiglottis can be fixed to the base tongue with the stitches. So this is epiglottopexy, where epiglottis is fixed with the sutures by creating raw area with vicryl, and it will not fall in the glottis. Another principle is how the surgery is performed by trimming the arytenoid redundant mucosa removal, or by cutting the aryepiglottic fold and opening the glottis or glottis supraglottic intake. Lasers, we have different lasers. We are using CO2 laser and diode laser in our setup. But diode is more preferable because it is contact laser and easy to handle, and no intermittent breaks are needed because the beam is needed for CO2 laser. It is with the effective and high security for CO2 laser, but the disadvantages is difficult in management of deep and curved areas because it is a beam. On the contrary, diode laser, which we are using very frequently, is a contact laser delivered through the fiber and in all angled and curved areas. So it can be passed through the suction cannula. The fiber goes in the supraglottic area, and there we are seeing it is almost 4 to 5 to 6 handed technique, 2 assistant and 6 hands. Almost 5 to 6 hands are needed. One is holding direct laryngoscope, other is with the scope, other with the camera, another is with the diode laser fiber, and sometimes retraction. This is how the surgery goes. In first picture, we are seeing the preoperative video of the child, and in second operation video, how the diode laser cuts the aryepiglottic fold. If you can appreciate, it is without tube. The anesthesia is tubeless. The tube is placed in the nasopharynx and continuous flow of gases is there. And this is how the fiber or a diode fiber going through the suction cannula, cord cannula, can reach up to the false vocal cord. Now this diode fiber is also removing or vaporizing the redundant excess mucosa on the arytenoid so that it will not fall inside and have a great open airway. This is how it is seen after 3 weeks and 1 week. Complete open glottis and the distress is not there. This is just a repetition how or revision maybe that how the diode fiber we are cutting with the very precision and magnified endoscopic view. Under vision, everything is being monitored, and once we know that the aryepiglottic folds are open, the prolapse in the supraglottic area doesn't occur. Sorry. This is how it looks in maybe the child is more comfortable now and no stridor and the glottis is all open. Another case, almost similar. We'll just run through it so that we can save the time there. And the principle is opening the epiglottic folds by cutting, then vaporizing the mucosa on arytenoid. And if epiglottis is also falling inside, then one need to do epiglottopexy. So many cases, and one of the very frequent conditions which we come across is Laryngo Malaysia, definitely. So in post-operative period, the child is kept in NICU maybe about for one week, and the child is with the orotracheal tube for 24 hours. After that, the tube is removed under supervision of neonatologist in NICU, and the child's feeding is with the Riles tube for 4 to 5 days, and then the Riles tube is removed, supervised feeding, and then breastfeeding is started. So by 6th or 7th day, the child is discharged. These are advantages of diode laser. Another instrument which is used for Laryngo Malaysia, which we have, is a radio frequency. Radio frequency is a probe, handheld probe, which cuts with the radio frequency principle. And if you look at the surgical things, it's almost similar repetition, but the cutting instrument is here a radio frequency and not the diode laser. The advantage of these instruments are lateral damage to other tissues is very less, and morbidity definitely will be very less. So radio frequency in Laryngo Malaysia is again a very comfortable, common surgical practice which we are doing and having excellent results. Only thing is post-operative management is equally important or more important than surgical thing, because once surgery is over, the neonatologist has a great role. See the child with the spontaneous respiration, intermittent inhalation, and on TIVA, and cutting all those bands so that the laryngeal inlet opens and the child will be having a complete open glottis for respiration. So these are post-operative videos and intraoperative videos. So this is just a few of the videos which I shared. Micro debrider is one more instrument which can be used for all these purposes. And I have not kept any video of this, but this is one more tool which can be used for supraglottoplasty. Post-operative is NICU setting, orotracheal tube, as I told, extubation after 24 hours, Riles tube feeding for 48 hours till 5th day, and nebulization and bronchodilator and monitoring by chest X-ray, and everything is done. Role of tracheostomy is very rare. If there are multiple comorbidities and surgical result is not going to improve with by any chance, then only it is needed. Or revision supraglottoplasty and revision also, second revision doesn't cure, then that is the last chance. These are complications of surgery. What happens in mild cases, they improve by 1.5 to 2 years of age. Now, one more condition after this is valvular cyst. This I have included in this talk because it is one of the common conditions where stridor can occur, and it is sometimes associated with the Laryngo Malaysia. So this is a child with indrawing, and cyst is seen with the flexible scope. So here, the instrument which is used is cobblator. Cobblator is one of the wonderful instrument which has 4 or 5 different functions where irrigation is there, suction is there, cutting is there, then coagulation is there. So all in one. Once you pass the instrument, this is valvular cyst, which is seen. The tube is passed beyond the valvular cyst. Now this is the instrument which irrigates, cuts, sucks, and coagulates also. So now in the first part of the surgery, you are seeing I'm coagulating with the same instrument. So all surface vessels are coagulated, and then the excision of the cyst will be achieved later. Now here the skill of anesthetist is very important because intubating a child with a valvular cyst is really difficult because cyst comes in your way, and sometimes it is really difficult to find a glottic opening for intubating. Once we achieve devascularization by surface coagulation, we go for a cobblator mode. So it has a 2 modes, coagulation and ablation, and different settings. So once we go to the coagulation mode, we puncture the cyst, aspirate and remove the surface wall. So what is exactly being done is a coagulation and then ablation or removal. The whole content of the sac will be aspirated and the superficial wall or covering wall will be excised. Now, differential diagnosis of valvular cyst. Best thing is to do sonography because this can be seen on sonography, exact dimensions, contents, whether it is really containing fluid, because the differential diagnosis in the tongue-based swelling are maybe lingual thyroid, maybe teratoma, maybe another swelling or hemangioma. So one should be very sure about the diagnosis before venturing on surgery. These cases do well because we are not handling the glottis as such. So still the intubation and rest of the management remains safe, and removal of superficial wall. What is left behind is a raw area in the base tongue area, raw area in base tongue or valvular area, and that heals by fibrosis. The recurrence chances are very less because we are removing almost every bit of the superficial covering of the valvular cyst. Another condition where we definitely give a best result is a bilateral abductor palsy, where the procedure is called as it's actually teamwork by otolaryngologist, anesthetist, and neonatologist. But parents are involved at every step of the management because everywhere the parents are needed, right from diagnosis, consultation, post-op management, and outcome. Everywhere they are needed for counseling. Repeated counseling is needed to have a best outcome by a teamwork. Now, the videos which I have not included are bilateral abductor palsy and other videos of glottic web. In bilateral abductor palsy, I'll just tell you in a nutshell that one of the vocal cord we cut posteriorly and gives excellent result by having a triangular window in a posterior glottis, and the stridor improves. Only here the child loss of voice or a change of voice is there for a few months, but false vocal cord takes function later on and the child's voice improves later on. But there is definitely compromise on the voice quality if bilateral abductor palsy is there, and if we are doing Kashima's operation, that is posterior chordotomy. Anteroglottic web, as I told you, by cutting the web and putting some splint so that adhesion should not reoccur. Thank you. Thanks a lot.
Thank you, sir.
Yes.
Mayura ma'am.
Yes, sir. Sir, any questions?
I can see in chat box the people has appreciated the way of presentation and large number of cases and videos sir has shared.
Thank
And
you.
I can see one question is there. Sir, there is one question.
Not getting. Your voice is cracking. I'm not able to listen to your voice.
Sir, I'll tell you the question. Someone wants to know whether there are any imaging modalities for Stridor like MRI or CT scan which can help.
You mean to say the question is MRI and CT scan in
Right, sir.
diagnosing the Stridor cases? Is it?
Yes, sir.
Okay. If we are suspecting anything in the chest for vocal cord palsy or mediastinal masses or tracheal obstruction by vascular ring, definitely imaging is a important thing. If we are want to rule out any cause
I'm
for
audible now.
Hello. Yes. If we want to diagnose a case of bilateral abductor where there is central lesion, then definitely imaging has a role. But believe me, the flexible endoscopy still remains the best instrument for diagnosing cases. And those who really want to get those scopes and training, I'm always available for every one of you. And you can procure the scope in your neonatal setup. And another advantage of these scope is the child who is on ventilator, you can definitely go in and have a suction of those secretions which are thick in the bronchial tree so that the collapse and other things may not occur. So it serves two purposes for neonatologist in an ICU setup. One is for diagnosing so many cases, and second for the ventilatory management, the scopes may be needed. Okay.
So I have a little question for you. Like without any evidence of hypocalcemia or parathyroid gland involvement, do oral calciums really help in the treatment of Laryngo Malaysia? It's a very common practice in pediatricians. We give a lot of calcium whenever we suspect Laryngo Malaysia.
Doesn't prove with the literature itself, definitely. Secondly, I have not touched upon the conditions of congenital stridor where the metabolic cause is there, because that is one more topic which I should have talked about or touched upon, so that investigations for a stridulous child and the condition is not, the tracheobronchial tree is normal, and then you definitely have to find whether the hypocalcemia is there, or then in those cases definitely proved by serum chemistry definitely has a role. But otherwise I feel it is empirical. I have not come across the literature where the calcium really supports the cartilage development and improves the stridor. No, it is by the growth of the child itself, the maturity occurs and strengthening of the cartilage and ligaments, they do occur. But definitely a child with a normal scopy, we need to find out other causes for stridor, as you told.
Thank you, sir.
Okay, thank you.
Now we will move on to our next speaker, Dr. Aditi Pandit, who is endocrinologist at Narayana Hospital. And she has many accreditation in her sleeve, like Best Speaker, Best Research Fellow, and many more. Over to you, Dr. Aditi ma'am, for approach to short stature. Aditi ma'am, are you there?
Thank you, Mayura, for the kind introduction. I'll just share my screen. 1 minute. Yes. Good morning, everybody, and a very warm welcome to everybody who has joined on a Sunday morning for the CME. And first of all, I'd like to thank IMA Nanded, the President Dr. Manish Deshpande sir and Dr. Sandeep Bokhare sir for inviting me on this to the CME. I'll be talking about a topic about approach to short stature. And this is so relevant because everybody, in spite if even if the child is growing well, or even if the child is having tall parents, every parent feels that is my child growing well, or is my child too short, or will he remain short, or how tall will he grow? These are the questions which are always there on the parents' minds. So first of all, I will come to that. When do we suspect short stature? So this is that if the height is below the third centile or less than 2 standard deviations, if the height is within the normal population, that is if the height is falling for the 50th or the 25th centile, but it is short for the mid-parental height or the target height, or even if the height is within the normal population, the growth velocity is below 25th centile. Now we'll come to this step by step. First of all these measures or all these values which are mentioned, at height, velocity, mid-parental height, it is all these things. It first starts with the measurement of the height. Now, height is to be ideally measured on a stadiometer. This is an old photographer stadiometer. There is a lot of improvisations. You don't see the desk nowadays, which is so much there. But this is how a stadiometer it is. And we should measure the height. When the child is standing, he should be without his shoes. His shoulders, his head should be touching the wall. His shoulders, back of the shoulder blade should be touching the wall, and his buttocks and the yes.
Excuse me, ma'am. Your screen is not visible. That slides are not moving.
Is it moving now?
No, ma'am.
Okay, 1 minute. One second, sorry.
Yes, ma'am.
Is it visible now?
Visible, ma'am. Yes, ma'am. Yes.
Yes. Okay. I will not do the screen sharing. Means I will not do the. Okay.
Full screen.
No, full screen. When I'm going on full screen, it is not getting I think transmitted. That's why I'm just keeping it on this. Okay. So coming to this, what I was talking about is that when do we suspect short stature? That when the height is below the third centile, when the height is in the normal population but is short for the mid-parental height, and the third is the growth velocity below 25th centile. Now, what do we see over here is that all the terms which I've been using, that is the height, velocity, the mid-parental height, the third centile. First, it starts with the basic measurement of the height. Now, height is always measured on a stadiometer. Now, when the height is measured on the stadiometer, what is happening is that when we measure the child's height, the child should be without his shoes or the chappals. His back of the head should be touching the wall. His shoulder blade should be touching the wall. His buttocks should be touching the wall. And the back of the ankle should be touching the wall. His head should be measured in the Frankfurt plane. That is, his head should not be either upwards or it should not be downwards. It should be the Frankfurt's plane. That is a plane which runs from the middle of the ears to the lateral aspect of the eyes. That line should be parallel to the ground. That is called as a Frankfurt's plane. Now, this is how we measure a normal height. So let us just kind of go, what is a normal growth? All of you are pediatricians, I don't need to say anything. But first is approximately around the first 2 years of life, it is around 15 centimeters. Later on, they go on to 6 centimeters per year, and the pubertal growth centile is approximately 25 centimeters. So as we can see is that there is something called as a crossing of centiles. Now, these are the growth charts. Now, in the growth charts, which are recently been published in 2015-16 by IIP by the Khadilkar sir and group, and this combines the WHO growth charts and the IIP growth charts, which are standardized to the Indian population. So now what I was saying over here is that in the first 2 years of the life, there is something like the crossing of the centiles. Now, these various lines are the centiles which we are seeing, the 3rd centile, the 25th centile, 50th centile, 75th centile, later on the 90th centile. Now, in the first 2 years of the life, either there can be a catch-up growth or a catch-down growth. Suppose if the child is large for gestational age baby, somewhat which we see in the diabetic mothers, there can be a catch down growth. That is, they can drop centiles. Say they are born at 75th centile. At the time of the birth, they can go down to 15th centile or 50th according to their mid-parental height. Second is the catch-up growth. That is, some patients, some babies who are born as SGA babies, they have a catch-up growth. And this catch-up growth is usually seen up to 2 to 3 years of age, when they are having adequate nutrition, when there are no real illness or no metabolic abnormalities in them. We see a good catch-up growth, and they usually catch up with their mid-parental target height by around 2 years of age. Secondly, after this 2 years of age, whichever centile they kind of hold, say if the child is on 15th centile or the 25th centile, the child grows steadily at 6 centimeters per year. The child goes steadily for 6 centimeters per year. And then if ever the child till the time of the pubertal growth spurt, in the middle childhood phase, he grows around 6 centimeters. And if he's on the 50th centile, he will grow on the 50th centile. So if the child after 2 years of age, he is crossing centiles, if he is having a going down from 50th to 25th centile, we should always look for something else. What is happening? It can be any endocrine disorders, it can be any nutritional deficiencies, it can be any metabolic abnormalities. We should always look if the child is falling off the growth curve. If he is crossing the centile after 2 years of age, we should always look for certain underlying abnormality. Thirdly, what we see is in the growth chart in the pubertal group, it is the children grow up to 25 centimeters. The males, they grow slightly higher. They grow up to 28 centimeters in the pubertal peak. And the females, they grow approximately 22 to 25 centimeters, which includes the pre-pubertal growth velocity also. Now, what I was talking about is that this is a growth chart of WHO growth chart for up to 5 years of age. Even if you don't have, these are very good charts for up to 5 years of age, WHO growth charts which are seen. And what we can see is this red line which you see over here is the 85th centile. That is the mid-parental height of this present child. This blue line is where the child he is presently present. So if the child comes and if it is falling within the mid-parental height, now mid-parental height is the target height which is calculated by calculating the average of both the parents' height, and you add either 6.5 centimeters if they are males and subtract 6.5 centimeter if they are females. From the mid-parental height, either they grow 8 centimeters less or 8 centimeters above. That is the target, means that is the range from where they should fall into. If they're not falling below this range, say suppose this is the child, he's falling, the blue dot which you see is where he's falling within the target height. But for a child with an MPH of around almost in the 85th centile, if the child is falling on the green dot, that is on the 15th centile, definitely there is a problem. And this chart is, this red dot is very clearly seen that the child is short, and we don't have to, there is no debate over it. So next is that multiple growth charts are there. Now, which growth chart to use? Now, there is WHO, CDC, KN Agrawal, ICMR, now Khadilkar 2007, and now 2015 charts have come out. But the most important thing is that we should use a growth chart. Now, unfortunately, in the growth hormone deficiency definitions, there is lot of emphasis on growth velocity. Now, growth velocity or the growth velocity centile, there are Khadilkar sir is working along the charts for the height velocity centiles, which will soon be out. But approximately, you should remember that if the child is not growing, if the child is growing for less than 5 centimeters per year, or if the height velocity is falling below the 25th centile, or if he is dropping off the centile, to be very simple, then we should think of some abnormality. Also, there are the Turner, any syndrome specific growth charts. This is the Turner growth chart, which can be seen. And as you can see, the 3 red lines are the normal stature, and the white lines with these lines are the Turner specific charts, Turner specific growth charts. Now, when do we initiate growth hormone therapy, or when a pediatrician should refer a Turner syndrome for growth hormone therapy to an endocrinologist is when the child is falling off the centile in the Turner growth chart. That is when he needs growth hormone therapy. That is when the child should be initiated on growth hormone therapy along with estradiol or estrogens, whichever that is preferred. Now, just before going on to the evaluation of short stature, I would just like to brush up upon how is the hypothalamic pituitary growth axis. Now, first is from the hypothalamus, that is the GHRH releasing hormone is released. Then it goes on to the pituitary, GHRH receptor is there. It binds with the GHRH receptor, activates the GH gene, growth hormone is secreted, and it further binds with the growth hormone binding protein. It goes on to the liver where the JAK-STAT pathway is activated and IGF-1 binding proteins. IGF-1 is released. Now, IGF-1 is the ultimate crux, in the sense that IGF-1, that is the insulin growth factor 1, which is stimulated. And what it does is that the growth hormone IGF-1, growth hormone stimulates the production of IGF-1. It further binds on to the IGF-1 receptors, which are present on the epiphyseal plate of the bones. Now, as we all know, see, there is an as we all know, there is a epiphysis. There is a metaphysis, there is an epiphyseal growth plate which is present, there is a diaphysis. Now, whatever we see, the growth plate which we see over here, the IGF-1 receptor acts on this, and this is where the growth hormone functions, and that is why we grow taller. And why do we stop growing after a certain age? Because there is a epiphyseal plate fusion. That is, the estrogen is the culprit in this. In males as well as in females, the estrogen causes a fusion of the epiphysis, and the growth plate is no longer available for further growth. So why this thing is important, this axis is important, because various mutations which can be seen at the level of the hypothalamus, level at the hypopituitary, level at the GH receptor, level at the IGF-1 and the JAK-STAT pathway, and further in the bone also. Now, coming to the causes of short stature. What are the causes of short stature? The short stature causes can be divided into 2 parts, namely being physiological and pathological. Physiological is a familial short stature. That is, if the parents are short, you tend to be short. Second is a constitutional delay of growth and puberty. Third is the idiopathic short stature. Now, all these 3 are a topic by itself, where there is a lot of controversy in the treatment, use of growth hormone for the treatment of these patients, because this is the most common subset of patients which come in our OPD. That is, one is the familial short stature and other being the constitutional delay of growth and puberty. I will talking about it a bit in detail later on. Next come the pathological causes. Now, pathological causes can be anything from IUGR, growth disorders, endocrine causes, genetic causes, and even there is something called as a psychological short stature, that emotional dwarfism leads to suppression of the hypothalamus and decrease in the release of the GHRH, leading to short stature. This we can see where it is kind of seen in those who are present in orphanages. It is seen. Now, this is just another classification of growth retardation, which can be divided again into disorders of GH-IGF-1 axis and those which are outside the GH-IGF-1 axis. I've talked about them already. Now, what about the Indian data? Now, the Indian data, this is from the 1994. It is quite an old data, but over here it is seen in SGPG and Vadia. Almost growth hormone deficiency constituted a surprising 16% of the population in their data. Why it is so? It is, I guess it is because these are tertiary care institutions where a lot of referrals take place, and usually familial short stature CDGP probably usually don't land up with an endocrinologist in over there. So we should take it with a pinch of salt. Now, coming to a diagnostic algorithm. Now, a patient comes to you, you know that he's short, he's less than third centile of A. So we have categorized that a patient is short. So patient is short, that means he's less than third centile, or he's growing less than 5 centimeters per year, or he is falling 2 standard deviations, or approximately 2 centiles less than the target height. And thirdly, and fourthly, his poor growth velocity. So the patient comes to you. Now we have to kind of divide, we have to kind of form a diagnostic algorithm. So for the diagnostic algorithm, they can be divided into whether it is proportionate or a disproportionate short stature. Proportionate can be caused by, proportion can be measured by the upper segment and the lower segment ratios, and clearly it can be disproportionate short statures. They can be very well diagnosed on clinical listing. They are the skeletal dysplasias. Proportionate being the systemic disorders, psychological assessment, karyotype, endocrine disorders, and lastly coming to the growth hormones test. Now, how to approach a case of short stature? The history is very important. The antenatal history, whether the mother was suffering from diabetes, whether any malnutrition was present in this thing, because the mother height correlates with the birth length. Mother's height and the mother's nutrition correlates with the birth length, and the father height kind of correlates with the total height, adult height. Now, it is not always true, but this is just an observation which has been made. Second is the natal, postnatal history is also important, because presence of birth asphyxia. Birth asphyxia leads to growth hormone deficiency very commonly, which can be seen, or presence of SGA. Around 10% of SGAs, they do not have a catch-up growth. So you should always remember that. Dietary is very important, immunization, so that we know that the child is not falling sick. Socioeconomic, family history, all this is very important. Now, how do you assess the growth? Now, while assessing the growth, we need a growth chart like I told you. We have to assess the chronological age. The chronological age is the birth date of the child. That is, how old is the child? The height or the height age, that is where the child comes on the growth chart. So if the chronological age is 13 years, but the child falls on the growth chart at 8 years, his height age is 8 years. Next comes the bone age. Now, bone age is very important and in a very significant, because before we go on to any test, just the bone age will tell us how to divide which way to go. So fourthly is the weight, because weight, undernutrition, malnutrition, any chronic systemic illness. And third is the body, lastly is the body proportions. Now, these are the body proportions which are usually seen. Like we all know, 1.7 centimeters at birth, 1.4 at 1 year. At around 10 years of age, the upper segment, lower segment is 1, and adults it is usually 0.9. Now, assessment of growth is the height velocity. Height velocity, it is better measured at least 6 monthly apart, or at least once a year. Now, pediatricians, it is very important that whenever the child comes for assessment, just plot on the growth chart, because any deviation you can find out if the child is really not growing well, because all mothers, they all complain, mera bacha badh nahi raha, mera bacha kha nahi raha, mera bacha ye nahi kar raha. Even if the child may be obese, but still the mother will feel like that. So just plotting on the growth chart gives us a visual impact. The visual impact of a growth chart is tremendous. because you can explain to the mother also how the child is doing, how he is faring, and we can kind of predict also. Now, what I was talking of the bone age is measured by the X-ray of the left wrist hand, and it is done by the Tanner-Whitehouse method or the Greluche-Pyle atlas, which is available. Now, this bone age is kind of very significant because it gives us an idea in relation with the height age and the chronological age. Thirdly, it is the all the appearance of the, while coming to the examination, at the time of the neonate, if the child is having micropenis or if is having hypoglycemia, growth hormone deficiency should always be kept into mind. Also, if he is having neonatal jaundice, that is another marker of growth hormone deficiency. His anthropometry, as I already mentioned, is very important. SMR, because micropenis is seen. Dysmorphism, and when the child of growth hormone deficiency comes to you, what is there is that the child will usually have frontal bossing or mid-facial hypoplasia, which can be seen, or any endocrine stigmata, being a goiter, which can be seen, malnutrition, any bony deformities, or any skeletal dysplasias. This I've already mentioned. Now, what are the key pointers to the growth hormone deficiency? I've kind of covered it. But another thing we should also remember is that whether there is a history of any head trauma or any central nervous system infection, like if the child had a past history of meningitis, if he was growing well and he suddenly starts dropping the growth centile, then we should always think about growth hormone deficiency. Another aspect of growth hormone deficiency is the child of isolated growth hormone deficiency is always a cherubic child. A cherubic child in the sense that he looks, he's chubby, he's plump, and he's short. There are very few causes of a short and an obese child, which can be counted on hand. Short stature with obesity. First being growth hormone deficiency. Second, which is more commonly seen, it is a severe primary hypothyroidism. Thirdly, it is any monogenic causes of obesity, that is Prader-Willi syndrome or the Lawrence-Moon-Bardet-Biddle syndrome. These are the causes of short and an obese child. Rest of the short stature kind of comes with a low height and low weight also, because that comes in the systemic nutrition. Now, usually, always we should remember, that is, which we have always learned in MBBS also, that growth hormone deficiency children are always good mentally. They are good academic performers, they're toppers, and mind you, they can be very good sportsmen also. We all know Lionel Messi. Messi was diagnosed as a case of growth hormone deficiency, and he was on GH hormone therapy for a very long time. I don't know if he's still taking it, but he was a case of growth hormone deficiency. So growth hormone deficiency should never be a hindrance to anything. Now, Turner syndrome, we all know the signs and symptoms of it. I'm not going to go. I think I'm less of time now. Thirdly, it is the CDGP. Now, CDGP forms a big chunk in the measurement of in the endocrine OPD. Now, CDGP, they do not have any nutritional, systemic, chromosomal, or any psychological factors affecting growth. They have normal thyroid and GH levels. Their blood work is usually normal, but their height is less than 3rd centile. But their annual growth rate is more than 50% for age. Now, this why it is important. That means they're less than the 3rd centile, but they are growing but the growth velocity is good. That is, their growth velocity is about 25 centile, or they're at least growing 5 centimeters per year. So what happens that usually these CDGP children, sometimes after the first 2 years of life, they fall down the growth charts, and they come down to settle down at 3rd centile, and they grow very slowly. Now the children come, the parents get the child to you. What we have to do is plot on the growth chart, do serial growth monitoring, that is at least up to 6 months to 1 year. And if the child is following the growth centile, we can assure them, and if he's growing at an average height of 5 centimeters per year, we can assure them that your child is going to grow. What happens with CDGP, that they have a delayed puberty. Now, delayed puberty is there. So what happens that at 14 years of age, some of the boys, they have still not entered into puberty. And girls also at 13 years of age have just started a B2 breast development. So what happens is that these children, CDGP children, they will have delayed puberty. So when their peers, that is at the age of 15 years, most of them have taken their growth spurt and have grown tall, they are still short. So there is a considerable level of anxiety both among the children and the parents. So you have to just assure them that if they have entered the puberty and the child is growing at a normal growth velocity, you have to just reassure them and tell them that rest of the class will stop growing, but you will keep on growing. So you can remember certain schoolmates that they were very short, but suddenly when the puberty hit them, they just rapidly short. They always have a normal adult height. These are the CDGP patients, and they have a delayed bone age. Now again, bone age is coming. Now, why it is bone age is important? First of all, it gives us an idea of the prediction of the adult height, and that is by the Bailey Pinout table, which we use, where we can, from the bone age, we can predict what the height age of the child is. Now, this is a differential diagnosis of according to the bone age. If bone age is equal to the chronological age, but more than the height age, then growth rate is approximately normal. That is a familial short stature or genetic syndromes. Delayed growth in this, what is that? The bone age is equal to the height age, but it is less than the chronological age. This is usually seen, that is the bone age is equal to the height age. This is seen in usually the CDGP. Now, mind you, the CDGP and the familial short stature, in familial short stature, always the bone age is equal to the chronological age. That is, the child is 12 years old and the bone age will be also 12 years old. But in CDGP, that is a constitutional delay, which is a normal variant, you will see delayed bone age, but it is equal to the height age. Whereas in endocrinopathies, what we'll say is remarkably delayed bone age. That is, even the bone age is less, that the child is 13 years old, his height age will be 8 years old, and the bone age will be less than 2 standard deviation, that is approximately 6 years or 5 years of age. This is how it is helpful. Now, how to immediately suspect for GHD? Like I've already told you, go for the growth velocity, go for the growth chart. And this is the measurement, actual definition, how we say is measurement of the height SDS. Now, SDS charts are also available, which we use sometimes. And severe short stature, that is less than the third centile. Height is growing less than the 1.5 standard deviations. Signs of intracranial lesions, signs of multiple hormone deficiencies, neonatal signs and symptoms of GHD. I will not go into height SDS. I'll skip this. Second is the first we decide the child is short or not. Look at the height percentile, MPH, growth velocity. If the child is short, check the history, decide for the ask for the time of growth deceleration. That is it from infancy, is it from 2 years of age, or is it something recent? Recent means then it can be some illness, systemic illness, malnutrition, or something sinister happening in these things, like say a brain tumor or some autoimmune disorder like a celiac disease has taken place. Now, this is a basic workup. Now, first is a complete hemogram, which will give us an idea of anemia, infections. RFT, LFT, electrolytes will give an idea of renal failure or metabolic disorders. Thyroid for the hypothyroidism, celiac disease, Turner syndrome, renal tubular acidosis, and urine exam, of course, renal disorders. Now, the monosymptomatic presentations of short stature, that these children will come as having short stature, but they will have no other signs and symptoms. There are only 2-3 causes. First is the hypothyroidism. They can just present with just short stature. Second is celiac disease. They will have no other signs and symptoms, but they say just short. The celiac disease should be kept in mind. And third is the RTA. That means, of course, you go into the details of the history, they will have something or the other. But once when the child is entering in the OPD, what we'll find is this. Okay, that they will not have anything, but these 3 diagnoses we should always rule out. Now, all these are normal. Then we can go on to the growth hormone stimulation tests, such as a clonidine stimulation and insulin tolerance test. These are the various protocols which are available. I'll not go into the detail. There is lot of controversy in everything, that what is the growth hormone cutoffs which are to be used. Also, whether we should prime, sex steroid priming should be done for the test. There is never a consensus. But these are the protocols which you use. That is, testosterone injections are to be given for any 8 years of age. We should always consider for sex steroid priming. Then these are the IGF-BP3 charts which are used in the diagnosis of short stature for less than 2 years of age. These are the IGF-1 charts. Now, IGF-1 values which are there, they are according to the bone age or to the according.
Excuse me, ma'am.
Yeah.
You are running out of time. How much time will be required?
Yeah, I'm just finishing now. The growth hormone therapy, and we should think about growth hormone therapy. Of course, just one thing to summarize, I'll not go into the details of the growth hormone therapy, but one thing is there, that if the child has growth hormone therapy is indicated for the child and you give growth hormone, nothing will happen. But if the child is not indicated for growth hormone therapy, and if we give growth hormone therapy just to satisfy the whims of the parents, then definitely usually they land up with side effects. So I will conclude my presentation. I would just like to conclude with this slide, that children have a short time to grow, but a lifetime to live with results. Thank you.
Any questions? Yes.
Hello, ma'am. It was a very nice presentation. There are few questions, ma'am. One question is, when does GHD presents, in what age?
Sir, the diagnosis of growth hormone deficiency is usually after 2 years of age.
Ma'am, please unmute.
Sir, I've unmuted now. Am I audible?
Hello, ma'am. You are not audible, ma'am.
Hello.
We can hear you, ma'am.
Yes. Hello.
We can hear you, ma'am.
Yes. Okay. Growth hormone deficiency is usually diagnosed after 2 years of age. You should never make a diagnosis of growth hormone deficiency, even if you suspect after 2 years of age, because the children, like I have said, they cross centiles in the childhood, means from 0 to 2 years of age, they cross the centiles. So whatever diagnosis we need to make is after 2 years of age. And after 2 years of age, GHD can be diagnosed. Even in infancy and neonates also, GHD can be diagnosed. There is no cutoff, but usually we should never label a child GHD till after 2 years of age.
Okay, ma'am. There is another question, ma'am. Are there any specific charts for Down's babies for growth monitoring?
For Down syndrome, some growth charts are available, but none of them are standardized. And the GH therapy response in Downs is not very encouraging.
One more question, ma'am. How to calculate bone age for different age groups?
Bone age is calculated by the Tanner-Whitehouse charts which are available, which is the TW2 or the TW3 charts are available. But that needs a certain amount of training to do the Tanner-Whitehouse estimation. But the easier way is to do the Greluch pile, which is an atlas which is available, which has various photographs of various bone ages, and you have to just take out a photograph and compare it with that age group.
Okay, thank you, ma'am. There are many questions are there, so we will ask later as we are lagging in time. So over to you, Mayura, ma'am.
There is a last minute change. There is last minute change in the speaker. Dr. Tushar Redate sir, he is a pediatric hemato-oncologist at MGM Hospital and Orbit Hematology Center, Aurangabad. He will enlighten us about ABC of CBC. Over to you, Dr. Tushar sir. Tushar sir, are you there?
Yes. I'm just sharing my slide. Can you see my slide now?
Yes,
Sir,
your screen is shared.
Okay. So good morning, everyone, and I would like to thank IMA Nanded, Dr. Sandeep Patil sir, Yasmin madam, for giving me this opportunity to share my views with you. I'm hoping that I'm audible and my slides are visible properly, right? Sandeep sir? Hello? Hello?
Sir, tell me, sir. You are audible, sir.
Audible and slides व्यवस्थित दिसतात ना?
Chan दिसतायत, sir. You
Okay.
can go ahead.
I will go ahead. So topic given to me today is about CBC, and we'll speak about basics. That is the reason it is called as ABC. It is just the basic of CBC, which will be relevant to you in your day-to-day practice. So this is the CBC what we all routinely see. It has got many components, but whenever we say CBC, we end up seeing only hemoglobin, WBC count, and platelet count. But unfortunately, we do not look other parameters which are there in the CBC, which include RBC count, MCV, MCH, MCHC. Along with that, there are differentials like neutrophil, lymphocytes. And there are
आणि आपण किती वेळ जाणं 2 वेळ जाऊ ना आता तर बरे यो भी करकर
सीमा
हां नाही चालू आहे
सीमा ma'am mute. Excuse me. Sir, you continue. Tushar sir.
Yeah. So there are two more points. One is RDW and last one is reticulocyte count. Okay. So what is RDW? It is actually red cell distribution width. Normal range is 11.5 to 15, and it measures variation in size of red blood cells. So what is, if all the cells are small, RDW will be in a normal range. If all the cells are large, still the RDW will be in a normal range. But if there are few cells which are very small and there are few cells which are very large, then the distribution width will be very high. So that signifies there is a variation in size of RBCs, which is generally seen in all types of nutritional anemias. Then there is something called as reticulocyte count. Normal range is 0.42 to 1.82, and it is considered as a window to the bone marrow. If reticulocyte count is in a normal range, it means bone marrow is functioning normally. If the reticulocyte count is very high, it means bone marrow is functioning hypernormal, or it is secreting the cells excessively, which indicates that there is some stress on the bone marrow produced due to hemolysis occurring in the body. And if the reticulocyte count is less, that means that bone marrow is not functioning normally. Either it is failed because of some infections or some pathology, or it is infiltrated by the other cells. When the bone marrow is failed, we call it as aplastic anemia, or viral infections or bacterial infection induced myelosuppression. When the bone marrow is infiltrated by other sort of abnormal cells, it can be leukemia, so blast cells can infiltrate the bone marrow. It can be storage disorder, where the storage cells can replace the normal stem cells, which will produce mature blood cells. So RDW and reticulocyte count are the two parameters which are very essential and basic, and they are readily available, but unfortunately we are not using it. And we all should see the importance of these two parameters in our next cases. So what I have tried to do is, rather than keeping it theoretical, I have taken few of the cases which have been referred to me by general practitioners, pediatricians across the region, and they look very similar. And what is the difference? What information you can gather from basic CBC, that I have to sort of give message to you, that even with just the CBC we can get so much information. So as you can see, all three cases, case 1, 2, and 3, have hemoglobin in the range of 5 to 6. It is 5.8, 5.5, and 5.5. So all three cases actually look very similar. But when we will take one case at a time, we will see what is the difference. So it is a first case is a 2-year-old boy who is admitted with some respiratory infection. You have noticed there is a pallor, there is a liver of 2 centimeters, but spleen is not palpable. So significant organomegaly is not there. And because there was a pallor, you have done the CBC. And this is the report. As you can see, hemoglobin is 5.8. The next thing as a reflex we look at is WBC count, which looks little bit on a higher side, might be because of infection. Platelet count looks normal. And other parameters which reflexly you should see is RBC count, MCV, MCH, MCHC, RDW, and you can order reticulocyte count in this patient. So as you can see, MCV is on a lower side. 70 to 85, 90 femtoliter is a normal range. So it is on a lower side. MCH and MCHC are also low. So this is called as microcytic hypochromic. When the MCV size is low, it is micro, means the size is small, microcytic. And chromia means what is the iron content of the cell, that will reflect the chromia. So if it is a hypochromic, means there is a deficiency of iron. So microcytic hypochromic anemia. The next thing you look at is RDW. RDW, as we have discussed, up to 15 is normal. In this case, it is wide, it is increased. As I already mentioned, RDW generally increase in cases of nutritional anemias. So looking at the CBC, we can get the information that this is the anemia which has got WBC and platelet count normal. It means other two lines are functioning properly. Only there is a problem with the RBC series. It is a microcytic hypochromic anemia, and the RDW is on a wide side, while the reticulocyte count is normal. So what are our differentials? The most common anemia in our country will be our first differential, that is a iron deficiency anemia. While the similar picture can be there in thalassemia trait as well. So in peripheral smear, we can get some clue, but it is very difficult to differentiate iron deficiency anemia from thalassemia minor. Okay, I am saying thalassemia minor. So peripheral smear definitely will give clue. You will at least get to know that it is microcytic hypochromic anemia. As you can see, the size of RBCs is very small, and the pallor normally is actually 2/3 of the RBC, but you can see all the cells are looking very pale. There is nothing red content in the cells. So you order some specialized test for confirmation of your suspicion, and those tests will be iron studies, serum iron, ferritin, and TIBC. In iron deficiency anemias, iron is reduced. Ferritin is a storage of iron in the bone marrow, that is also reduced, and total iron band capacity is increased. So this was case of iron deficiency anemia. Now the next question is, how do you treat iron deficiency anemia? In pediatric patients, if there is some history or there are some factors which are sort of giving you clue that it might be beyond iron deficiency anemia, it will be advisable to do stool examination to rule out occult blood. Generally, iron is given as a treatment dose in the dose of 6 milliequivalents per kg per day. This is an elemental iron. Most of the times we make mistake of looking just as a milligram. In 100 milligram, that is written as ferrous fumarate as a 100 milligram, but below that line is written as elemental iron is 30 milligram. So that we have to look at. Okay, so 5 ml of routine preparations which are used in the market, I will not take any brand name, but they generally contain 30 or 33 milliequivalents of elemental iron in 5 ml. Now the dose we have known. Now these are the routine questions which are asked to me do you give oral iron as a OD or BD? Do you give it empty stomach? Which preparation to use? What is the duration? And if there is no response to the iron, what should we do? So basically, OD and BD actually doesn't have much sort of significance. If the dose is very high, you can divide it into two divided doses. If the dose is small, you feel that the child or even the adult will be compliant, then you can give it in a OD dose. Empty stomach, iron given on an empty stomach has got better absorption. But if you directly start iron in pediatric as well as in adults on an empty stomach, then there is a gastric discomfort. Some of them get loose motions, some of them get vomiting, some of them get nausea, some get abdominal pain. So I will advise that you start it after food. Definitely absorption will be less compared to empty stomach. But once they get used to the iron, after 15 days or 1 month, you can ask them to shift to empty stomach. Now all the preparations are same. There is no any clinical trial which will prove that fumarate or sulfate or ascorbate or gluconate is better than the other one. So any preparation which you are comfortable with, you can use. Duration of iron, it is 3 months after normalization of the hemoglobin. It means at 5.5, if you have started on oral iron, you have to continue oral iron till the hemoglobin reaches up to 10, 11, 12. Okay. And once it has reached to that range, which might take 3 months, 6 months, or even 9 months, but routinely 3 to 6 months is a time when you should get a good rise of hemoglobin. After that good rise of hemoglobin is reached, for next 3 months, you have to give iron to replenish the stores of iron in the body. Okay. So the total duration can be 6 months or it can be 9 months, depending upon when the hemoglobin is normalized. After the normalization of hemoglobin, you give it for 3 months more. Whenever there is no response to the iron, there are many other causes. There can be some blood loss, there can be celiac disease, there can be leukemia, there can be sort of iron refractory anemias, there can be some genetic mutations which may not cause absorption of iron. So these are complicated patients, and whenever you don't get good response as you expected, you should consider referring these patients to hematologist rather than keep playing with them. There is no point in giving another preparation of iron when you know that the family has been compliant with the oral iron with one preparation. The other preparation or other brand is not going to give you the rise. It will just waste the time of patient and yours also, and you might miss something big diagnosis in that bargain. This is the second patient in our series. Hemoglobin is 5.5. Here also WBC count is on a lower, higher side. Platelet count looks normal. As we have seen in the previous case, here also MCV looks on a lower side. MCHC is on a lower side. MCH is on lower side. MCHC looks okay. So this is again a case of microcytic hypochromic anemia, where other two cell lines are preserved, and RDW in this case is normal. So it is not wide, while the reticulocyte count can be considered normal. So what next? What differentials we have? Of course, iron deficiency anemia we will again like to rule out because it is a microcytic hypochromic anemia. Although RDW is normal, we'll keep that in mind. We'll also like to order HB electrophoresis, which was an old terminology for a test which is now called as HPLC, high performance liquid chromatography. So only the technique has changed. The principle remains same, that different hemoglobins travel at a different speed when they are given electrical stimulation. So depending on where they go on that paper, initially it was called as electrophoresis. Now it is done on an automated machine. So that test we should order in this patient. This was a case of 4-month-old boy who presented with pallor, and he had hepatosplenomegaly. So as you can see in the previous patient, case 1, we did not have organomegaly, while this patient has got microcytic hypochromic anemia along with organomegaly, which makes it more suspicious for having thalassemia major, because thalassemia major is a hemolytic anemia, and hemolytic anemia generally have organomegaly with them. Okay, so this was diagnosed as a thalassemia major. You can see the peripheral smear, it is called as dirty smear. There are target cells, polychromasia, there are some nucleated RBCs, there are some pencil cells also. So when you order electrophoresis, this is the report you can see. There are different hemoglobins, HbA, A2, F. I have mentioned the normal range in the bracket. So this patient's HbF, fetal hemoglobin, was more, which is suggestive of thalassemia major. His both parents were also having thalassemia minor. As we know, thalassemia major is an inherited disorder where both the parents are carriers. Thalassemia major needs extensive monitoring and treatment. This is the protocol which we use at our center at MGM Hospital, Aurangabad. The third patient in our series, a 9-year-old boy who presented with fatigue and pallor since 2 to 3 years. Child had pallor as well as organomegaly, livers of 3 cm and spleen of 2 cm. So this also looks like a similar case where hemoglobin is low, WBC count looks okay, platelet count looks okay. Anemia is again a microcytic hypochromic anemia. MCV low, MCH low, MCHC low. RDW looks okay. So we can see the pattern is almost the same, but we have to be very vigilant when to label it iron deficiency and when to be sort of thinking about other differentials beyond iron deficiency anemia. So this will look to you as a simple and similar case of iron deficiency, but you should keep other differentials and investigate the patient. This patient electrophoresis was normal, HPLC was normal, and iron studies had revealed increased iron ferritin transference situation. Now I would like to give very clear-cut message. This is a 9-year-old boy who had organomegaly. Okay, that is the reason we have ordered all these investigations. I am not giving you the message that each and every patient of anemia should be advised iron studies or electrophoresis. My message is, if you have organomegaly, if you have growth retardation, if you have icterus, if you have any signs beyond just plain simple patient coming with anemia, you should investigate that patient. That is the message. And of course, if other two cell lines are affected, that we will see in the next series, that also should be investigated further. So this patient, electrophoresis and iron studies had revealed that instead of having low iron, actually iron, ferritin and everything was increased. So we did bone marrow examination of this patient, and it was actually a case of sideroblastic anemia. So when you have microcytic hypochromic anemia, you will have only out of these 4 disorders, one of them will be there. So when you have HB low, look at WBC, look at platelet count. If WBC and platelet count look okay, look at MCV. If MCV is on a lower side, less than 70, MCH is on a lower side, it becomes a microcytic hypochromic anemia. And when you have microcytic hypochromic anemia, just keep these 4 disorders in your mind and investigate accordingly. It will either be a iron deficiency anemia, it can be thalassemia trait or thalassemia major, it can be sideroblastic anemia, or it can be anemia of chronic disease. Like Madam was discussing endocrine disorders. Now Pankaj Bansali sir will be discussing about the renal disorders. All these disorders can also come with anemia. They can have microcytic hypochromic anemia, or they can even have normocytic anemia. Okay, so these disorders also should be kept in mind. And simple basic iron, ferritin, TIBC and HPLC will give you the clue. This we were taught as UG students, Menzer index. You look at MCV and RBC count, and if it is less than 13, it will give you a clue that it looks like thalassemia trait, and if it is more than 13, it is suggestive of iron deficiency anemia. I will make it simple for you. Suppose you are sitting in a busy OPD. Just after you have noticed anemia, and after you have seen that WBC and platelet count looks normal, look at MCV, look at RDW. If your RDW is narrow, think about sending HPLC. It can be a case of hemolytic anemia, thalassemia. If your RDW is wide, this looks like simple case of iron deficiency anemia. Just start on oral iron. Now I have taken second series of 3 cases just like the previous one, where we will have three cases which look very similar. But if you approach them properly, you will get the different disorders. So as you can see, I have highlighted in red. In first case, hemoglobin is low, WBC count looks okay, platelet count is low. But in first case, if you look at the differential count, neutrophils and lymphocytes, neutrophils are very low. So when we calculate absolute neutrophil count, what is absolute neutrophil count? मी जसं पेशंटला एक्सप्लेन करतो की WBC तर पूर्ण आपण युद्धाला जाताना ज्या ज्या गोष्टी घेऊन जातो त्या सगळ्या आहेत. म्हणजे त्याच्यामध्ये तुमचे सैनिक पण येणार, डॉक्टर्स पण येणार, नंतर जे हाऊसकीपिंगचे लोक आहेत, बाथरूम वगैरे समजा, किंवा वॉटर बाकीचे जे काय सपोर्टिंग स्टाफ जे म्हणतो आपण. सो दॅट विल बी टोटल. Okay, each one is an important person. Each one has got different role in different sector. But generally, the neutrophils are considered important for the bacterial infections, and lymphocytes are for the viral and other disorders where they are important. So when you calculate absolute neutrophil count, you can calculate absolute lymphocyte count. So there is a range of each of them, and it should be a proportionate distribution of them. You can get normal WBC count, but the differentials, what is the proportion of these cells, if that is also abnormal, that is not good for your body. So when you get neutrophils of 12 and you calculate absolute neutrophil count, as in first case, you can see there is a 924 only. So A and C less than 1500 is considered as having neutropenia. So this patient has got anemia, there is thrombocytopenia, and there is neutropenia. So this is called as pancytopenia. Whenever there are two lines abnormal, we label it as a pancytopenia. Means all the lines are abnormal. Even if one line is normal, we can still label it as a pancytopenia. Even the second patient, you can see hemoglobin is low, WBC count and absolute neutrophil count is low. Even the platelets are low. Third patient is also the same case. Okay, here I would like to give you the message that when you look at WBC count, please look at the differential count. WBC count may look normal to you, but if you calculate absolute neutrophil count, absolute lymphocyte count, that might be abnormal, and that should be alarming for you. I have seen many leukemia cases where WBC count is in the range of 10,000 or 5,000, but the neutrophils were only 5%, 10%, 20%. Lymphocytes of 80 to 90% are not seen any viral infection or any other differential. Most of these are actually lymphoblast. The Coulter doesn't know difference between lymphoblast and lymphocyte because Coulter measures cells based on their size, and the size of lymphocyte and lymphoblast is the same. So Coulter will measure all those lymphoblasts as lymphocytes and wrongly give it to you as a lymphocytes are 86. So whenever the lymphocyte count is more than 80% and the neutrophils are less than 20, it is something fishy, and you should be sort of watchful for these patients. So we'll take one case at a time. First case is a 10-month female who presented with increasing pallor. There was history of developmental regression as well. Child was exclusively breastfed. Child had pallor. There was organomegaly, not very significant, 1 or 2 centimeters of organomegaly. So this is a CBC, as we have already seen. Hemoglobin is 4.76. WBC count, neutrophils are less, so there is neutropenia. Platelet count is low, so pancytopenia is there. As we have discussed, we'll look at RBC count, MCV, MCH, and MCHC. The clue in this case is MCV. MCV is very high. Up to 80, 85, we have seen the normal range. Here it is 97. So it is very high. So as we labeled first three cases as microcytic hypochromic anemia, this patient looks like a macrocytic anemia. The size is high. So that is called as macrocytic anemia. And the next thing we have learned that we look at RDW. RDW is very large, very wide in this patient. So increase MCV, increase RDW, and pancytopenia will give you the clue that looks like a very common type of anemia another nutritional anemia, and that is a megaloblastic anemia. This is very classic smear we have been learning since our undergraduation days. Hypersegmented neutrophils, macrocytes, polychromasia. So that will give a clue towards megaloblastic anemia. Doing B12 and folic acid levels or doing bone marrow aspiration is not essential in all such patients, but you should definitely have clinical sort of clue towards this, such as knuckle pigmentation. There can be ball tongue, angular cheilosis. You may have some developmental regression. CBC should be very clear. MCV should be on a very high side. Child should be malnourished. Vegetarian diet. So if all these clues are fitting, then you can straight away start these patients on B12 therapy rather than doing some fancy investigations. So this is a protocol we should be treating with. I have seen many sort of colleague of ours giving 1 or 2 doses of B12, or giving 3-4 random doses. That doesn't help actually. So you should give total 7 doses of B12. 1000 micrograms is a dose. You can give it IV or intramuscular. If the platelet count is normal, more than 1 lakh, you can even give it intramuscular. There are different commercial formulations which are used. Elderweight and Witkofol are the ones which are routinely available and used by many of our colleagues. That has got 1 ml is equal to 2500 microgram of cyanocobalamin. If you give 0.5 ml also, that will give 1000 to 1200 microgram of B12. That should be sufficient. So that you can use. Another common question which is asked is vitamin C is supplemented with that. So should we give that also? It is not required. It is not essential. It was made for pernicious anemia where the vitamin C will help in a sort of absorption. But in the routine cases, vitamin C sort of administration along with B12 is not required. So you can just give cyanocobalamin 1000 micrograms IV or intramuscular for 7 days. After that, you have to give 1000 micrograms weekly, 4 doses. And then if it is an infant who cannot take properly oral, then you can use 1000 micrograms intramuscular 3 monthly for 1 year. So this should be the total treatment protocol which we should be using, because it will replenish not only the blood, but it will help in development of the child also. So 7 plus 4 plus 4, that is how I remember it. 15 doses of B12 should be given. If it is an infant, do not mean that mother definitely must be having sort of vegetarian diet. You can do CBC only if MCV is on higher side. You can straight away start the mother on B12 supplement. Oral tablets can be given to adults. At least 500 micrograms daily for 6 months should be given. There are many different preparations. Do not randomly give any multivitamin. You have to actually look की त्याच्यामध्ये सायनोकोबॅलामिन जे आहे B12 ते खरंच आहे की नाही ते बघायला पाहिजे. नाही तर रॅन्डम मल्टीव्हिटॅमिन देऊन त्याच्यात कुठल्याच विटॅमिनचं प्रॉपर कंटेंट नसतं. So you should look at the brand whatever you are using, that cyanocobalamin at least 500,000 आहे.
Tushar, sorry to interrupt.
Yes,
how much time is there?
5 minutes.
Okay.
I will wrap up in 5 minutes.
Oh, thank you.
So this is the another case. We can see hemoglobin is 2.7. WBC count is on a lower side. Platelet count is on a lower side. And MCV looks normal. So this is again hemoglobin low, WBC count low, platelet count low. So this is a pancytopenia. And here MCV looks normal. Okay. So this is the more or less similar case. But as you can see, MCV is on a normal range. RDW is also normal. And the reticulocyte count is low. And it was a CBC of 14-year-old girl who did not have any organomegaly. So this is a patient where you should consider doing bone marrow examination. Okay, because this doesn't look like a clear-cut megaloblastic anemia. And this was actually diagnosed with aplastic anemia. There was a similar case, third case, which we have seen, 15-year-old female who presented with fatigue and weakness. She also did not have fever or organomegaly. This was the CBC. We have already seen this. Hemoglobin is on lower side. WBC count is on a lower side. Platelet count is on a lower side. RDW looks normal. Reticulocyte count is low. MCV is normal. And child had fever. So when you get fever, the child is looking sick. Child is not looking very well. There are other manifestations like organomegaly, lymphadenopathy, then definitely it doesn't look like case of megaloblastic anemia. In all such patients, you should consider doing bone marrow examination in these patients. So this third case was diagnosed with acute leukemia. These all blue cells, you can see they are blast cells. This is not so common, so I will skip this case. So what is the message? That if you get pancytopenia, it can be a simple megaloblastic anemia, it can be aplastic anemia, it can be acute leukemia, it can be some marrow failure in pediatric patients, it can be a rare HLH-like disorder, it can be some immunodeficiency. So in all such patients, whenever there is a pancytopenia, hemoglobin is low, Wbc count is low, neutropenia is there, platelet counts are low, child is not looking very stable, please consider doing bone marrow examination as early as possible. Coming to last case, a 16-year-old female who referred to us as a dengue with thrombocytopenia. This is important case because after 4 or 5 months you will see all such patients. Clinically, a child did not have bleeding manifestations, and serological tests for dengue and malaria were negative. Now, EDTA, whatever sample was sent for CBC, it revealed thrombocytopenia, but pathologist called a pediatrician again that I am seeing plenty of platelets on the peripheral smear, and they are adequate and they are good in clumps. Clumps means they are adequately doing their function as well. So there was a confusion that CBC is showing low platelets, but the peripheral smear is showing adequate platelets. So in all such cases, you should 110% rely on your pathologist. If your pathologist has shown normal platelets on the peripheral smear, that is the most reliable way. Even when you are in doubt, the best test to do for platelets is peripheral smear. So it was actually a case of EDTA-induced thrombocytopenia. It is a phenomenon where actually the patient has got normal platelet count, but because of the anticoagulant used, the platelets get clumped and they are measured falsely by the Coulter machine. But when you look at the peripheral smear, they are seen as normal. You can even send this CBC in a citrate bulb, and that will also show you the normal platelet count. So to summarize, always read CBC completely. Look at RBC count, MCV, MCH, MCHC, RDW, ANC, peripheral smear. Microcytic hyperchromic anemia, look at RDW. Investigate all the iron refractory anemias. Megaloblastic anemia, give total doses of B12. Pancytopenia, please consider doing bone marrow examination. EDTA-induced pseudothrombocytopenia is not so rare. So this is all I have to offer, and I will again thank organizers for giving me this opportunity. I hope that it was simple and relevant and will be useful for you for your daily practice. Thank you.
Thank you, Tushar. As usual, you spoke very nicely.
Thank you.
And you might be missing the interaction, but there are lots of questions here.
Actually, this presentation, you are right. This presentation is of no fun if audience is not interactive.
No, audience are there from chat box. They are putting questions. Now the list is increasing. So first question to you, Tushar. Any role of vitamin C with iron supplement? Any comment on Menger's index?
So Menger's index, first I will take. We have mentioned how to calculate it. It is a good index, definitely. You can use it routinely because the MCV is available to you. MCV and RBC count are available to you. It is a useful test, I feel. You can use Menger index when it is less than 13. It will suggest you of thalassemia minor, and if it is more than 13, it will indicate iron deficiency anemia. So Menger index along with RDW are good investigations which are available to you in your CBC only. Vitamin C, as I mentioned, again has been mentioned that it will increase the absorption of iron and B12, but not routinely used, not recommended.
Okay. Lotria ma'am, are you there? Lotria ma'am, are you there?
Yes.
Yeah, you can ask questions in chat box if you are able to see the chat box.
Okay, what are you listening?
Yeah, ma'am. We're audible.
Yeah. For how much days you have to give the supplementation of vitamin C?
Vitamin
days
C
average for
routinely not required, ma'am.
Okay.
Okay. There is one more question. MI index formula.
MCV upon RBC count.
Okay. Okay.
I can.
Is there any role of platelet indices and guide the role of platelet indices?
Yes, good question actually. Nowadays, many people are asking that what is the role of MPV? You know,
PDW.
I will quickly go to the high. This is Menzer index. Those who want to sort of write it down. So, mean platelet volume and IPVF sort of are the two immature platelet function. That these are the two sort of tools which are routinely now sort of used or discussed in many of the CMEs and conferences. MPV, just like MCV, MPV indicates the size of platelets. It is said that whenever there is a destruction, MPV, that is a mean platelet volume, just like sort of hemolytic anemia, this thing is increased. Similarly, in cases of destructive pathology of platelets, MPV is on a little bit on a higher side. Those disorders, even the congenital ones, there are many disorders which will present with larger platelet count, platelet volume. Okay. The another investigation which is actually little bit of more practical use, I feel, is IPF. It is like a reticulocyte count. Whenever you get hemolysis, reticulocyte count is increased. Similarly, IPF is increased when the bone marrow is producing platelets normal or excess to the normal. So where it is routinely recommended is in cases of dengue. This is a fancy test which is available in sort of corporate hospitals of Mumbai and Delhi. I don't feel that it will be available to Nanded or even Aurangabad. I have never tried to use it, but we'll just get to know that a dengue patient when presents, there is a marrow suppression and the IPF is on a lower side. And if you do repeat the test on the 5th or 7th or 8th day, when sort of expect that the bone marrow should show some rise in the platelet count, you can do IPF. If the IPF is increased, it means that the marrow will start functioning in within 24 to 48 hours. So that is a clue that marrow is functioning normally.
Thank you, Tushar. There are other questions also, but because of short in time, shall we proceed to other lecture?
Yes. Thank you for giving me the opportunity.
Thank you, Tushar. Thank you very much. Share screen karo
I apologize for the speakers that we are running half an hour late. Now let's move on to next speaker, Dr. Sandeep Patil sir, our organizing secretary. He is neonatologist at Care Hospital Nanded. He has many national and international publications, and he is editor of many neonatal books. Over to Sandeep Patil sir. He will explain us about what's new in neonatal resuscitation program. Sandeep Patil sir. It was a very nice lecture of Tushar Idhate sir about ABC of CBC. Really, we learned ABC of CBC.
My slide is not opening. Can we move ahead with another lecture? After that, I will do my lecture.
So, I request Dr. Pramod Jog sir. Sir, are you there? Dr. Pramod Jog sir. He is a professor at Dr. Pramod Jog sir.
Yes, I am there.
Yeah. Sir is a professor at D.Y. Patil Medical College, Pune. He was president IIT in 2016. He has lived a big life as pediatrician, and he can look back and point out what kind of practice we should have. Dr. Pramod Jog, sir.
आपला डॉक्टर पाटील तुमचा हे स्क्रीन थोडा स्टॉप शेअर करायला लागेल.
Yeah.
Sir.
Piyush.
Piyush, can you help?
Yes, ma'am.
Piyush?
Do you want me to share?
नाही आता हा आता आला. ओके.
Okay,
सुरू
sir.
करायचं? सुरू करायचं?
Yes. Yes, sir. Yes. Sir, your presentation.
हा आता दिसतंय का?
Yes, sir. Yes. Yes. हो, sir. दिसते, sir.
ओके. ते फुल स्क्रीन करतो. ओके. Very good.
Okay, sir.
So we'll start. No problem.
Yeah. Yes, sir.
So good morning to all the listeners, and we will have a discussion and as to where do we go wrong in pediatric practice. Okay, and I am working as a professor in a medical college, and you can see that I have written into bracket I am not the HOD. So HOD means the head of the department. So whenever you become HOD, it brings another HOD with you, and that is hypertension, obesity, and diabetes. So I want to keep away. So I am not becoming HOD. So I have not committed that mistake. Okay. Now, when I was thinking as to where I went wrong, then I spoke to one of my close friends, and he said, Pramod, the first mistake that you have done is that you have taken pediatrics as a subspecialty. And my children are not at all ready to take pediatrics because they don't want to get up at night for cesarean calls, and they don't want to attend the calls in the ICU. Jokes apart, pediatrics is a branch where you need to toil a lot, and particularly in the earlier days of your practice, you are likely to commit some mistakes because you are in the phase of learning. When I started my practice, actually, there was another pediatrician who was practicing by my side, and he had written a board, and the board said entrance to the clinic. Now remember that our right brain is connected with creativity, and you must be very creative. So don't only believe in the left brain. Left brain is connected with counting numbers and matching the pairs and filling the blanks, which we do in the school days. But right brain is connected with creativity. So when I saw the board saying entrance to the clinic, then I thought of putting down another board on which I wrote main entrance. Now, when patients came to the clinic and they saw another board with main entrance, they decided to go to the board where it was written main entrance. Okay, so they started slowly coming to my clinic. Obviously, this was the use of the right brain. And remember, the entrance to the clinic has to be very, very clean. Okay, of course, never commit a mistake of painting your board every year. The more rusted and more dirty the board is, it speaks of your more years of experience. त्यामुळे दरवर्षी तुमचा नेम बोर्ड नावाची पाटी जी लावली क्लिनिक असेल हॉस्पिटल असेल ती पेंटिंग करायची नाही. ओके, अदरवाइज पीपल फील हे सला एकदम नया डॉक्टर, ही इज अ न्यू डॉक्टर, and that's why they will not come to you. People always like that the doctor should be experienced, old. Okay, even if you find my hair black in color, remember, you don't commit the mistake of dyeing your hair. Always keep them gray and white, because patients also like gray colored hair. So never paint the hair and never paint the board. तेव्हा दोन गोष्टी लक्षात ठेवा. Okay, now when the patient comes up into your clinic, remember, you must enter in time. So take the entry into clinic on time. आता कसं आहे की पुण्यात काय किंवा नांदेडला काय कधी गेलं तरी चालतं, एक अर्धा तास एक तास उशीर झाला तर पेशंट बसून राहतो. बट इफ यू प्रॅक्टिस ॲट मेजर प्लेसेस, बेसिकली 9:01 झालं तरी सुद्धा पुण्यातले लोक इकडे तिकडे चुळबुळ करायला लागतात. काय डॉक्टर 9ची वेळ दिली आणि स्वतः तुम्ही 9:30ला येता. सो एंटरिंग ऑन टाइम reflects your personality. Okay, it tells patients that you are very, very careful about the patient also. काय आजकाल सगळेच लोक गडबडीत असतात. Everybody is in a great hurry. So you must respect the time of the patients also. Okay. And also it keeps your staff tight. तुमचा जो हॉस्पिटलमध्ये स्टाफ आहे तोही टाईट राहतो. सगळे जोक डॉक्टर क्लिनिकला एकदम टाइमवर येतात, म्हणजे आपणही टाइमवर जायला पाहिजे. बिकॉज इफ आय स्टार्ट गोइंग merrily at any time, the staff will also become loose. Okay. And remember, a very good administrator can never be loose. तुम्हाला जर चांगलं ऍडमिनिस्ट्रेशन करायचं असेल तर यू हॅव टू बी अ लिटल स्ट्रिक्ट. ओके. तुम्ही जर स्ट्रिक्ट राहिले नाही, तुम्ही जर लूज वागला तर हाताखालचे लोकही लूज वागायला लागतात. त्यामुळे थोडं स्ट्रिक्ट राहा. नेव्हर कमिट अ मिस्टेक ऑफ टॉकिंग लूजली विथ दी स्टाफ. थोडा लूज, थोडा ठीक आहे, पण एकदम जास्ती नाही. नाहीतर इफ यू बिकम व्हेरी लूज, दे ऑल्सो टेक यू व्हेरी लाईटली. सो थोडा दीज स्ट्रिक्ट ऍडमिनिस्ट्रेटर्स पीपल डोंट लाईक. जे ऍडमिनिस्ट्रेटर स्ट्रिक्ट असतात ते लोकांना आवडत नाहीत. बट नॉट बिंग लाईक्ड इज द सिक्रेट ऑफ युअर सक्सेस. तुम्ही तुमच्या हॉस्पिटलमधल्या लोकांना आवडत नसाल त्याचा अर्थ तुमचं काम बरोबर चालेल, लक्षात ठेवा. ओके. युअर अँबियन्स याचा अर्थ क्लिनिकमध्ये बाहेर रिसेप्शन रूम जर असेल तर तिथं सगळ्यात चांगले मेडल्स, तुमचे मेमेंटो, तुमच्या नोटिसेस, हे सगळं व्यवस्थित लावून ठेवा. आता नोटीस बोर्डवरती यू शुड हॅव गुड आर्टिकल्स रिटन बाय यू in the newspapers or in the magazines. You can also write some good thoughts of the day. Of course, when I told one of my friends to write something good about him, त्याचं नाव पेपर मध्ये छापून आलं होतं. बट ही हॅड वन केस गोइंग अगेन्स्ट हिम इन द कन्झ्युमर प्रोटेक्शन ऍक्ट. तर त्याने लिहून ठेवलं होतं, केस गोइंग ऑन अगेन्स्ट डॉक्टर जोशी इन द कोर्ट. अरे म्हटलं बाबा, तुझं नाव आलं याचा अर्थ ते क्लिपिंग लावायचं नाही, तर तेवढं डोकं आपल्याला वापरायला पाहिजे. ओके. ऑल्सो कीप गुड मेमेंटोज. हे तुम्हाला जे काय मेडल मिळतात ते सगळे तुमच्या डिस्प्ले मध्ये लावून ठेवा. बिकॉज दीज मेडल्स विल रिफ्लेक्ट युअर ऑथेंटिसिटी. ओके. बट कीप द वन्स विच आर रिलेटेड टू युअर मेडिकल करिअर. नाहीतर वन ऑफ माय फ्रेंड्स हॅड पुट अप दी मेडल्स which said first in dancing in the 4th standard and first in football match in the 7th standard. तसं करू नका. Always remember that you have to put the proper and the appropriate medals in the clinic. Okay. And remember, whenever you have the atmosphere in the waiting room very clean and quiet, it is always better. Of course, in pediatric practice, it is difficult to have a quiet atmosphere. Then you should also select right people. Not having right people will always create a problem. Right people as artha, you should have someone at the reception. It could be a boy or a girl, whatever it is, but they should be smart enough. Don't appoint people who are hypothyroid. त्याला 10 वेळा सांगितलं तरी त्याला काही समजत नाही, अशा लोकांना या एम्प्लॉय करू नका. बिकॉज दे विल इन्क्रीज युअर वर्क टू डबल, आणि तुम्हाला तेच काम 10 वेळा सांगेपर्यंत तुमचा जीव जाईल. सो तसं करू नका. सी दॅट दे आर स्मार्ट पीपल. अँड ऑल्सो रिमेंबर टू रिस्पेक्ट देम. You exist because your staff exists. Okay. तुमच्या स्टाफनी आणि तुमचं हॉस्पिटल असेल तर त्यांनी जर समजा काम करणं बंद केलं तर तुमची पंचायत होणार. सो रिमेंबर दॅट यू हॅव टू बी व्हेरी व्हेरी केअरफुल. सेलिब्रेट देअर बर्थडेज. ऑल्सो सँक्शन देम हॉलिडेज. बारीक सारीक करण्यासाठी त्यांचे खाडे कापू नका. अँड ऑलवेज whenever they have a birthday, cut a cake, distribute it to their family members and all in the hospital. And in my hospital, what I've done is I have put up the name of the best staff of that week. Okay. So notice board वर काय करायचं, लिहून ठेवायचं, द स्टाफ ऑफ द वीक. ओके. तुमचं जो कोणी चांगलं काम करणारा असेल, आलटून पालटून त्यांचं नाव लावत जा. इट एनकरेजेस द पीपल. द मिस्टेक दॅट वी कमिट इज नॉट टू गिव्ह रिस्पेक्ट टू आवर सबऑर्डिनेट्स. त्यांना आपण कधी ओरडतो, त्यांच्या अंगावरती खेक असतो, तसं करू नका. डोंट ट्रीट देम एज सबऑर्डिनेट्स. ओके. समजा जमिनीवरती काही कापूस पडला असेल, इन केस इफ देर इज समथिंग ऑन द फ्लोर, यू युअर सेल्फ पिक इट अप अँड पुट इट इन द डस्टबिन, बिकॉज यू आर अ पार्ट ऑफ द टीम. त्यांनाही वाटतं अरे चले काय खाली पडलं असेल तर लोक सर स्वतः उचलतात आणि डस्टबिन मध्ये टाकतात. सो रिमेंबर दॅट एंटायर वर्क इन द क्लिनिक अँड द हॉस्पिटल, particularly in pediatric practice, is a big teamwork. Okay. So तुम्हाला इंट्राकॅथ लावायला कोणीतरी मदतीला लागतंच प्रॅक्टिस मध्ये. सो युअर स्टाफ नर्स हू इज एन एक्सपर्ट इन पुटिंग इंट्राकॅथ, she is doing a great job for you. Okay. So remember all these points related to the people and select them properly. Okay. It may take little time, but pay them little extra as compared to the other pediatrician. Suppose he is paying them 10,000, then you can pay them 11,000, because people usually love higher salary. This is a very bitter truth in life, that people love money more than anything else. Okay. And over years I have learned that if you pay more, good people can be I should not say bought, but the good people can be employed in your clinic. But that is a bitter truth, but it's a truth. So in case if someone gets more money, he comes to you. And in case if you want right people, you have to be on search for good people. Okay. Also remember to have a very good rational clinical approach. Rational as अर्थ मराठीमध्ये ज्याला सद विवेक बुद्धी म्हणतात, म्हणजे बुद्धी वापरून चांगलं काय वाईट काय ज्याला कळतं त्याला रॅशनल शब्द आहे. ओके. So when you give a prescription, remember to write at the top of prescription that I treat. Treatment मी देतो, but who cures? He cures. ही म्हणजे गॉड, म्हणजे देव. म्हणजे मी ट्रीटमेंट देतो, पण ट्रीटमेंट दिली तरी बरा होईल असं नाही. त्याची पॉवर आहे म्हणून तुमचा पोरगा बरा होतोय. दॅट पेशंट्स मस्ट नो. सो दॅट थोडी रिस्पॉन्सिबिलिटी देवावरती टाकायला शिका. ओके. अँड दिस प्रिस्क्रिप्शन दॅट यू गिव्ह इज अ मिरर ऑफ युअर पर्सनॅलिटी. तुमची पर्सनॅलिटी कशी आहे ते तुमच्या हँडरायटिंग वरनं दिसतं. द मेथड यू राईट त्याच्यावरनं कळतं. काहीतरी आपल्याला कळत नाही असं काचकिरड्या अक्षरामध्ये लिहून तुम्ही जर देऊन टाकलं, the patients also don't like it, and there are others who also look at the prescription. So remember, at the top of the prescription you write allergic to. Suppose if the child is allergic to say ibuprofen or allergic to amoxicillin, please write it that after 2 or 3 days this child developed diarrhea. After 2 or 3 days he developed rash. Probably it was drug rash, because then the other pediatrician also will learn that. Not to write an allergy is a big mistake. Okay. And also note down seriousness, and the seriousness is implicated by 3 or 4 important things: the fontanelle, the throat, the respiratory rate, and the capillary fill time. हे 4 गोष्टी फक्त पेपरवर लिहून ठेवा. एवढ्या लिहिले तरी पेशंट सिरियस आहे की नाही कळून टाकतं. ओके. थ्रोट बेसिकली यू हॅव टू सी, because we know that say a condition like diphtheria, we know that because of DPT the condition is going down, but it is down, but it is not out totally. Diphtheria गेला नाही. Once in a while you can say that. तर नुसतं सर्दी खोकला ताप आहे घसा खवखवतो असं म्हटल्यानंतर लगेच काहीतरी अमॉक्सिसिलिन देऊन त्याला पाठवू नका. प्लीज से and write it down properly. Okay. And note down the diagnosis. काय diagnosis आहे? It is viral, bacterial. You know that viral infections involve more than one site at a time, like the same child has fever, rash, loose motions, and runny nose. More than one symptoms are present in that particular child when he is viral, while bacterial infections are localized. So that's the commonest problem in our practice is infections. So better write the diagnosis. तुम्ही म्हणाल डॉक्टर जो आम्हाला डायग्नोसिस पहिल्या दिवशी काय समजत नाही भाऊ, काय करायचं? समजत नसेल तरी तसं लिहा. सो राईट डाऊन IDK. IDK म्हणजे काय? आय डोंट नो. तुम्हाला पाहिजे तर GOK लिहा. GOK म्हणजे गॉड ओनली नोज. पण काहीतरी लिहून ठेवा. ओके. जस्ट सिम्पली डोंट लीव दॅट एरिया ब्लँक. ओके. When I used to write IDK and GOK in the beginning, many of my staff members, they came to know the full form. मग ते म्हणले अरे याला सरांना सगळं काय कशातच डायग्नोसिस कळत नाही का काय? तर then I changed the short form to DUR. DUR is diagnosis under revision. Okay, so I am still revising the diagnosis. पण हा शॉर्ट फॉर्म फक्त आपल्या नांदेडच्या मित्रांना सांगितलंय, पुण्यात नाही सांगितलं, नाही तर they will start saying that Dr. Zog has changed the short form. Okay, anyway, now at the bottom of the prescription you better write down SNDT. That is the details, that is the signature, name, date, and the time. हे प्रत्येक प्रिस्क्रिप्शन वर पाहिजे. I am trying to tell you because pediatricians and even the practitioners, they give prescriptions, but some of these things are usually not written. Okay, we will see some aspects of the therapy. Remember that paracetamol is the best antibiotic. Okay, ibuprofen is the next. Okay, combinations may be used, but they are not supposed to be rational. Okay, so you try with one antibiotic, and paracetamol देऊन समजा 2 तासात temperature नाही उतरलं, then the standard textbooks will recommend use of ibuprofen. Okay, mefenamic acid should not be used in pediatric practice because it is associated with gastritis and rash. Okay, and diclofenac is an analgesic more than an antibiotic. Naproxen also is given in conditions like rheumatological conditions. So don't use anything else apart from paracetamol and ibuprofen. As I have written here, paracetamol is an ideal antibiotic. Adarsh antibiotic paracetamol. The dose is 15 milligram per kg per dose. Commonest mistake is giving paracetamol in any dose. लोक आपल्या म्हणतात अरे कुठलाही डोस एक चमचा 3 वेळा चालून जाईल, तसं नाही. Paracetamol is 15 milligram per kg per dose every 6 hours. Okay. Remember, nimesulide is not safe because the time for which nimesulide keeps the fever down is almost 12 hours. त्यामुळे इन्फेक्शन चालू राहतं, पण fever मात्र दिसत नाही. Okay, so the sentence which is used is that the fire is burning under the ashes. म्हणजे वरती राख दिसते पण खाली विस्तव चालू आहे ना. So the child has the internal infection going on. पण चले बाहेर तर टेम्परेचर दिसत नाही बिकॉज निमेसोलाइड हॅज सप्रेस्ड द फीवर. तेव्हा निमेसोलाइड आता फॉर्च्युनेटली मिळत नाही सिरप फॉर्म मध्ये तर नाहीच आहे. अँड ॲस्पिरिन when it is given in conditions like flu, usually is known to precipitate one problem called Rye syndrome, REYE, Rye. Okay, so this syndrome was very common when we were residents, when children had liver failure and all. Fortunately, it is not seen now, but aspirin काय वापरू नका. Okay, use paracetamol. And remember, the pattern of fever is an important clue to diagnosis. Okay, म्हणजे तो दर 6 तासांनी येतो. In between the fever, the child is playful, means that the child is having viral fever. So all these good clues are suppressed by strong antipyretics. तर तेवढे strong antipyretics नका वापरू. For diarrhea, commonest cause is viral diarrhea, that is 90%, but it is one of the conditions where antibiotics are misused. आला पेशंट लूज मोशनचा की त्याला ठोक सेफिक्झिम किंवा काहीतरी. ओके, तसं करू नका. म्हणून तुम्हाला मुद्दाम साईबाबांचं चित्र दाखवलंय. दिस इज श्रद्धा और सबूर. प्लीज टेल द पेरेंट्स दॅट कीप फेथ इन मी and wait for 5 to 7 days. Okay, never say that the diarrhea will be covered in the next 1 or 2 days. In the beginning of my practice, I used to say, doctor, अरे patient काळजी करू नको बाबा, 1-2 दिवसात सगळं ठीक होईल. And that was a mistake, because I realized that every child in our country is malnourished, whether he is a poor child or whether he is a son of Tata Birla. He is malnourished because some children don't get anything to eat and others eat what they should not eat. नाही का? So that's why त्यांना सांगायचं की पोरग बरं व्हायला 7 दिवस लागतील. आणि माझा एक मित्र आहे, तो काय करतो, आज रविवारी जर पेशंट आला तर त्याला सांगतो रविवारी बरा होईल, किंवा शनिवारी आला तर सांगतो पुढच्या शनिवारी बरा होईल. 7 दिवस सांगून टाकायचे. ओके, दॅट इज बिकॉज 7 days are required. The intestinal villus atrophy takes that much time to recover. And do not discontinue any diet during diarrhea, including the top milk. लोकांना बऱ्याच वेळा सवय असते अंगावरचं दूध बंद करा, वरचं दूध बंद करा, काही खायला देऊ नका. लंघन हा जो कन्सेप्ट आहे आयुर्वेदामध्ये, तो मेनली ऍडल्ट साठी आहे. ओके, तुम्हाला डायरिया झाला आणि तुम्ही 1-2-3 दिवस काही खाल्लं नाही तर काय जग इकडचं तिकडे जात नाही. पण लहान पोरांनी खाल्लं नाही तर त्यांचं न्यूट्रिशन मार खातं, डिहायड्रेशन होतं. सो प्लीज कंटिन्यू टू गिव्ह ओरल रिहायड्रेशन थेरपी and also keep away from antibiotics. I will speak about antibiotics in a short while. Cough mixtures आपल्याला खूप आवडतात. Remember that combination of expectorant and suppressant is a mistake. Okay, एक तर तुम्ही डेक्स्ट्रोमेथर्फन द्या, which is a suppressant, किंवा नाहीतर एक्सपेक्टोरंट वापरा, ग्वाफेनेसिन किंवा एम्ब्रॉक्झल सारखं. ते दोन्हीचं मिक्सचर असेल तर काहीच अर्थ नाही. ओके, बट इन लाईफ यू ऑलवेज गेट द कॉम्बिनेशन्स ओनली. तुम्हाला प्रॅक्टिस मध्ये सगळे असेच विचित्र कॉम्बिनेशन मिळतात. ओके, सो कीप अवे फ्रॉम कॉफ मिक्सचर्स विच आर कॉम्बिनेशन्स. These are irrational. Then more than one expectorant also should not be used. And cough medication with nasal decongestants, okay, they are of no proven benefit. त्यामुळे एक कॉम्पोनंट असलेलं मेडिकेशन शक्यतो शोधून ठेवा आणि वापरा. तशी मार्केटमध्ये आहेत पण तुम्हाला शोधायला लागतील. ओके, समटाइम्स वी फाइंड that cough medications are with antihistaminics like CPM. Okay, now many times these could be rational in some situations. Current this child has additional cold, he is irritable, and many times it sedates the child. त्यामुळे practically these could be rational in some situations. म्हणजे ते पोराला सर्दी झाली, खोकला आणि ते झोपत नाही, त्रास होतोय, नाक चोलतंय, तर these particular combination may be used. Okay, but it is better to prescribe individually. And the combinations of cough syrups with antihistaminics with antipyretics, हे जे ते अजिबात वापरू नका. त्याचं काय होतं की एक तुम्ही वापरायला गेला की दुसऱ्याचा डोसेज आहे तो एकदम मार खातो. आय टोल्ड यू दॅट द डोसेज ऑफ पॅरासिटामॉल इज 15 mg per kg per dose. पण तुम्ही असं कॉम्बिनेशन वापरलं की पॅरासिटामॉलचा डोस कमी पडतो, बिकॉज इन पीडियाट्रिक्स द डोसेजेस गो अकॉर्डिंग टू द वेट ऑफ द चाइल्ड. As I told you, as regards the use of antibiotics, we are all infected with HIV. HIV म्हणजे आपला खरा HIV व्हायरस नाही. HIV means habit, ignorance and variety of other factors. Once Khushwant Singh was asked as to when does he drink, and he said, I drink only on 2 occasions. One when it is raining and one when it is not raining, meaning thereby I drink on all occasions. Similarly, when people use antibiotics, when child has fever and when child doesn't have fever, म्हणजे आला की दे antibiotic, अशी बऱ्याच लोकांना सवय आहे, तर तसं करू नका. ओके, there are some doctors who are ignorant. ते अशी आपली IMA नांदेडची CME वगैरे अटेंड करत नाहीत. एकदा पास झाले की नंतर कधी वाचत नाहीत. So ignorance is another factor which leads to antibiotics. Then त्यामुळे मेडिकल रिप्रेझेंटेटिव्ह जे सांगतो ते अँटीबायोटिक ठोकून देतात, तर तसंही करू नका. अँड लास्टली देर आर व्हेरियस अदर फॅक्टर्स. आता आमच्याकडे इकडे पुण्याला कसं आहे, इन्फॉर्मेशन टेक्नॉलॉजी म्हणून एक मोठा सेक्टर आहे. कॉम्प्युटर इंजिनियर्स हे येतात सकाळी 9ला आणि म्हणतात 8:30ला ताप आला, लगेच त्याला बरं करा. तर असं काय जमत नाही. आपले ऑब्स्टेट्रिशियन्स, this also immediately after cesarean they want us to start some antibiotic. तर तसं काय करायची गरज नसते. So there are many other factors. So don't fall prey to the pressures of the parents. पेरेंट्स म्हणतात याची आता उद्या परीक्षा लगेच बरा व्हायला पाहिजे, अँटीबायोटिक द्या. पण गरज असेल तरच अँटीबायोटिक द्या. अँड प्रिस्क्राईब द राईट अँटीमायक्रोबियल. मेनी ऑफ अस डोंट थिंक बिफोर वी इंक द प्रिस्क्रिप्शन. ओके, फॉर एक्झाम्पल, right drug, right dose, right route, and right duration. For example, you are using amoxicillin for respiratory bacterial infections, then right drug is amoxicillin, correct? So here there is no need to use amoxicillin plus clavulanic acid. Okay, but market मध्ये amoxiclav ची इतकी प्रिपरेशन झाली आणि इतका प्रचार आहे त्याचा की people feel that they should give amoxicillin with clavulanic acid. तसं करू नका, कारण बऱ्याच वेळेला all these organisms which infect the throat and which are bacterial, basically they respond very well to amoxicillin. Okay, amoxiclav साठी खूप limited indications आहेत. Okay, particularly in children who have otitis media which does not respond to amoxicillin, or cases of serious sinusitis, they are the ones where we require amoxicillin. And remember that in neonatal age, of course, as general practitioners, many of you may not be treating neonates, but the route has to be intravenous in case of sepsis, meningitis. Okay, and conditions like meningitis, the duration has to be 21 days. Empyema, osteomyelitis, the duration has to be long. So you should know the duration of treatment for each and every condition. Okay, also you should select the antibiotics properly. Not selecting the right antimicrobial is a very big mistake. For example, we always tell our colleagues that if you have infection above the diaphragm, okay, use the ones which are amoxicillin group medications. Practice मध्ये तुम्हाला फक्त 3 किंवा 4 अँटीबायोटिक लक्षात ठेवायचे. One is amoxicillin, another one is cefixime. Cefixime is the one which is used for infections below the diaphragm, म्हणजे GI tract मध्ये diarrhea, bacillus dysentery, and urinary tract infection, and maybe enteric fever. Okay, so remember that above the diaphragm usually infections are gram positive, below the diaphragm usually they are gram negative. In medicine nothing is 100%, but as a rule you should know. त्यामुळे respiratory infection आला आणि तुम्ही ठोकलं cefixime, त्याला काय अर्थ नाही. It means that you are not thinking properly. Okay, you should also have governance, that is the audit of what you are writing. So maybe I will suggest you can form your groups of about 10 or 15 in a city and discuss it every month as to what you are writing, and also try to search for the organism. दोनच कल्चर करायला लागतात महत्वाची पीडियाट्रिक प्रॅक्टिस मध्ये, पण ती पण लोक करत नाहीत. वन इज ब्लड कल्चर फॉर एंटेरिक फीवर अँड अदर इज युरिन कल्चर फॉर युरिनरी इन्फेक्शन. बिफोर यू डू द कल्चर, ऍक्च्युअली इट इज नॉट राईट टू स्टार्ट अन अँटीबायोटिक. पण लोक म्हणतात अरे कसलं कल्चर डॉक्टर सांगताय, काय आमच्याकडे पॉझिटिव्हच येत नाही. सो स्टार्ट डेव्हलपिंग अ हॅबिट ऑफ ऍटलीस्ट इन्व्हॉल्विंग सम गुड पॅथॉलॉजिस्ट इन युअर एरिया who will guide you properly, and it should also include training of the mind. Okay, I will come to the training of the mind in a minute. Before that, I will just tell you something about this beta-lactamase inhibitor combinations. म्हणजे काय? Amoxicillin is a beta-lactam antibiotic, okay, and clavulanic acid is a beta-lactamase inhibitor. So some of these combinations are approved, like amoxiclav, ampicillin, piperacillin, tazobactam, वगैरे. Okay, but there are some other nonsense combinations like cefpodoxime clavulinate, cefotaxime sulbactam. यांची काय गरज नसते. If you see, the resistance of the organisms depends on various factors. I will just tell you an example. तुम्ही एंटेरिक फीवर म्हणजे टायफॉइडचे पेशंट बघता, त्याच्यामध्ये सेफिक्झिम विल ऍक्ट व्हेरी वेल इन डबल द डोस इन ट्रीटिंग अ चाइल्ड विथ टायफॉइड. ओके, पण त्याच्यामध्ये क्लॅव्हलिनिक ऍसिड घालून काहींनी प्रॉडक्ट तयार केलाय. आता क्लॅव्हलिनिक ऍसिड इज रिक्वायर्ड फॉर दिस बीटा लॅक्टमेज इनिबिशन. ओके, तर बीटा लॅक्टमेज प्रोड्यूसच करत नाही टायफॉइड ऑर्गॅनिझम साल्मोनेला, त्यामुळे त्याची काही गरजच नाही. सो देर इज नो नीड ऑफ दॅट कॉम्बिनेशन. You can take a picture of this photograph if you want, so that you know that which are the combinations which are approved and which are the nonsense combinations. Nonsense याचा अर्थ त्याला काय अर्थ नाही. Okay, because they are not compatible with each other. Okay, ही जोडी एकमेकाला जुळत नाही. Okay, because of various academic factors, and you can discuss it amongst yourself after this lecture also. And as I was trying to tell you about training of mind, त्यामुळे कुठलाही feverचा पेशंट आला की just try to think whether it is infection or not infection. Of course, most commonly fever is because of infection in our practice. Okay, if it is because of infection, मग विचार करायचा, मी मग सांगितलं असं व्हायरल आहे का बॅक्टेरियल आहे. ओके, इफ इट इज बॅक्टेरियल, मी तुम्हाला सांगितलं बॅक्टेरियल इन्फेक्शन्स आर लोकलाइज्ड. फॉलिक्युलर टॉन्सिलायटिस असेल तर फक्त फॉलिक्युलर टॉन्सिलायटिस, त्या पोराला न्यूमोनिया नसतो. न्यूमोनिया असेल तर फक्त न्यूमोनिया, ही डझंट हॅव अदर इन्फेक्शन ऑफ द टॉन्सिल्स अँड ऑल. सो इफ इट इज बॅक्टेरियल देन थिंक ऑफ व्हॉट इज द ऑर्गॅनिझम. ते मी तुम्हाला सांगितलं. अबाव द डायफ्रॅम युजली ग्रॅम पॉझिटिव्ह, पण त्याच्यामध्ये ग्रॅम पॉझिटिव्ह मध्ये कुठला आहे, न्यूमोकॉकस आहे का स्टॅफिलोकॉकस आहे, तर हे थोडंसं जरा अजून ऍडिशनल लेक्चर झालं की वाचा. आणखीन त्याच्यानंतर तुम्ही कुठला चॉईस आहे अँटीबायोटिकचा तो डिसाइड करा. सो यू हॅव टू ट्रेन द माइंड. ओके, तर ट्रेनिंग ऑफ द माइंड इज व्हेरी इम्पॉर्टंट. आपण जसं 31 मार्च जवळ आली की पैसे इन्व्हेस्ट करायला विचार करतो, अरे चले आता टोटल पैसे एवढे मिळाले, त्यातले 1.5 लाख पीपीएफ ला चालतात, अच्छा उरलेले आम्ही या स्कीम मध्ये घातले. आपण टॅक्स जसा वाचवायला बघतो, दॅट इज हाऊ अवर माइंड इज ट्रेन्ड फॉर इन्व्हेस्टमेंट. सिमिलरली for choice of antibiotic, you should train your mind. Okay, it will not be a difficult process, but you try to do that. And there are some situations where your hands must shake. म्हणजे तुम्ही प्रिस्क्रिप्शन जेव्हा लिहिता तेव्हा अँटीबायोटिक जर लिहायला लागले तर तुमचा हात थरथरला पाहिजे. युअर हँड शुड हॅव शेक्स. कोणत्या कंडिशन्स? 2-3च कंडिशन्स आहेत. घसा लाल दिसला की लगेच दे अमॉक्सिसिलिन, असं करू नका. रेड थ्रोट डज नॉट मीन इट इज बॅक्टेरियल. नंबर 2, त्या पोराला डायरिया झाला, वॉटरी डायरिया असेल तर डोंट राईट अँटीबायोटिक्स. इट इज ऑलमोस्ट 90% इट इज व्हायरल. ओके, आणि ब्रॉन्किओलायटिस, आता थंडीचे दिवस आहेत, सध्या कोविडनी सगळीकडे थैमान घातलंय, पण कोविड नसताना ब्रॉन्किओलायटिस वगैरे गोष्टी चालूच असतात. सो दिस ब्रॉन्किओलायटिस इज अ व्हायरल डिझीज कॉज्ड बाय RSV, त्याला पण अँटीबायोटिक लागत नाही. तर अशा अजून काही 3-4 कंडिशन्स आहेत, पण ऍटलीस्ट कॉमनली GI ट्रॅक्ट, रेस्पिरेटरी ट्रॅक्ट, ऑल दीज आर ऑलमोस्ट व्हायरल. त्यामुळे अँटीबायोटिक उगाच लिहू नका. रेजिस्टन्स कम्युनिटीमध्ये अँटीबायोटिकच्या विरुद्ध आधीच वाढलाय, तो अजून वाढत जातो. ओके, अँड व्हेन यू गिव्ह इन्स्ट्रक्शन्स, ORS कसं करायचं ते सांगा. अमॉक्सिसिलिन त्या बाटलीमध्ये पाणी घालून तयार कसं करून ठेवायचं ते सांगा. नाही तर लोक आपलं घमेल्यामध्ये सिमेंट घेऊन त्यात पाणी घालतात, तसं सबंध ओततात वाटीमध्ये पावडर, त्याच्यात पाणी घालतात, तसं नाही. सो यू हॅव टू टेल देम क्लिअरली. डोस सांगा. अमॉक्सिलिनचा 40 mg per kg आहे, आणि 0.1 mg कसं लिहायचं तर 0.1 mg. 1 mg कसं लिहायचं तर 1 mg. 1.0 नाही लिहायचं, कारण बऱ्याच वेळा तो पॉईंट दिसत नाही आणि मग डोस चुकतो. ओके, परमेथ्रिन आपण स्केबिस साठी लावतो, ते कसं लावायचं? आफ्टर गिव्हिंग अ बाथ टू द बेबी, मेकिंग द स्किन ड्राय, सबंध बॉडीला मानेच्या खाली लावायचं, 12 तासानंतर पुन्हा लावायचं, हे सगळं व्यवस्थित सांगायला पाहिजे. ओके, अँड इफ यू हॅव नो टाइम, आस्क समवन हू इज हेल्पिंग यू in your practice. Okay, and counseling is very important in certain areas, particularly when the child is developmentally delayed or he has some cardiac problem or some chronic kidney disease or neurological disease. तिचे काउन्सिलिंग लागतं. तेव्हा नुसतं डॉक्टर जो कन्सल्टंट असून चालत नाही, बिकॉज अ कन्सल्टंट डझंट हॅव टाइम. तो म्हणतो जा चला ह्याच्याकडे रिफर नाही करून टाकायचं, बिकॉज ही हॅज कम टू यू. त्यामुळे एक 5 मिनिटं घालवा. तुम्हाला वेळ नसेल सकाळी तर दुपारी बोलवा, मे बी आठवड्यातनं एकदा बोलवा, बट डोंट कमिट अ मिस्टेक ऑफ नॉट काउन्सिलिंग. ओके, अँड whenever you get any prescription of your colleague, त्याच्यावर कॉमेंट नाही करायचा. पीपल ऑलवेज वॉन्ट यू टू स्पीक समथिंग अगेन्स्ट अदर डॉक्टर्स. दिस इज अगेन अ व्हेरी बिटर ट्रूथ. पण तुम्ही बोलू नका, कारण आवर फ्रॅटर्निटी, मेडिकल फ्रॅटर्निटी इज अ व्हेरी स्मॉल फ्रॅटर्निटी. वी हॅव टू रिस्पेक्ट आवर ओन पीपल. ऐन वेळेला तेच आपल्या मदतीला धावून येतात, आणि त्यामुळे व्हर्बली काय बोलायचं नाही. अरे काय बंडल प्रिस्क्रिप्शन दिलंय, काय अर्थ नाही, डॉक्टरला काय कळत नाही. नॉन व्हर्बली सुद्धा चेहऱ्याच्या हालचाली करून काहीतरी असं चेहरा वेडा वाकडा करून चुकीचं प्रिस्क्रिप्शन आहे असंही बोलू नका. फिजिकली काही वेळेला लोक हातातलं प्रिस्क्रिप्शन असतं, कागद घेतात, चुरगळून फेकून देतात की या डॉक्टरला काय कळत नाही. तर तसं करू नका. प्लीज रिस्पेक्ट युअर कलिग्स अँड ऑल्सो हॅव अ लुक ॲट द कॉस्ट ऑफ प्रिस्क्रिप्शन. बाजारात बरेच ब्रँड्स असतात. पेशंट जर गरीब असेल आणि त्याच्या मंगळसूत्रामध्ये बाळाच्या आईच्या जर सोनं नसेल, इफ देर इज ओनली ब्लॅक थ्रेड इन दी नेक ऑफ दी मदर. तुम्ही माहितलंय की सगळ्या बायकांना सोनं फार आवडतं. जरा का सोनं मिळालं की त्या गळ्यात घालणारच ना. तर त्यामुळे जर सोनं नसेल त्याचा ऑब्व्हियसली अर्थ असा आहे की ती बाई गरीब आहे. त्यामुळे तिला उगाच महागडी औषधं देऊ नका. ओके, फॉर एक्झाम्पल अमॉक्सिक्लॅव्हची कॉस्ट तुम्ही बघितली तर 100 रुपयाच्या घरात आहे. तेच अमॉक्सिलिन 30-40 रुपयाच्या घरात आहे, आणि अमॉक्सिक्लॅव्ह लागतही नाही. तेव्हा उद्यापासून तुम्ही उगाच अमॉक्सिक्लॅव्ह लिहायच्या मागे लागू नका. गिव्ह सिम्पल अमॉक्सिसिलिन अँड ट्राय टू फाइंड आउट विच इज द बेस्ट चॉईस. मी सांगितलं तसं आपलं अमॉक्सिसिलिन, सेफिक्झिम, एक 2-3 अँटीबायोटिक लक्षात ठेवा आणि तेवढी व्यवस्थित वापरा. ओके, अँड वेन यू गिव्ह प्रिस्क्रिप्शन, गिव्ह देम 3 थिंग्स फ्री. आपल्याला जसं 1+1 फ्रीची सवय लागली, तसं 1+3 थिंग्स यू हॅव टू गिव्ह फ्री to the patient. One is a smile on the face, other is sugar on the tongue. व्यवस्थित गोड बोलून सांगायचं, चिडायचं नाही पेशंटवर. अँड सॅन्डलवूड ऑन द हेड, डोकं शांत ठेवा, डोक्यावरती चंदन ठेवा. Okay, so that you will never fail in your practice. Okay, and as regards investigations, CT scan, MRI, हे उगाच गरज नसताना काय पाठवू नका. Many of our colleagues use it as something to get something in return. Okay, so I say it is a mutually rewarding investigation. पण तसं काय करायची गरज नाही. आपल्याला बाकी इतर अनेक गोष्टींमधनं खूप काही गोष्टी मिळत असतात. तर पेशंटला उगाच सीटी स्कॅनला पाठवून रेडिएशनला एक्सपोज करू नका. गरज असेल तर ठीक आहे. ओके, बट डू इट एथिकली and protect the child from radiation and expenditure both. Okay, and there are some communication errors in practice. Try to use all the 5 senses. Whenever you get a patient who has an alphabet starting from P, like a police or a pleader means a lawyer, then people like public leaders. Okay, then some people from press. So all these people, you have to handle them properly, because many of them are likely to create some mischief. May not be, but then you have to be very, very clear. Okay, also listen to the patients properly. Not listening is a very big mistake. If you take the word listen, there are 6 alphabets, LISTEN. तुम्ही जरा का अल्फाबेट्स बदलली तर त्याच्यातनं नवीन शब्द तयार होतो, विच इज हॅव्हिंग अल्फाबेट्स SILENT. ओके, दॅट इज सायलेंट. तर तुम्ही मनाच्या मागे शांत राहा. घरामध्ये भांडण झालं, बाहेर पेशंटची भांडाभांडी झाली, बिलावरनं वाद झाला, हे काही डोक्यात ठेवू नका. वेन यू सिट इन द क्लिनिक, that is the purpose in life for which you are here, isn't it? So keep your mind cool, be silent, and always remember to speak. Use all these important 5 alphabets when you speak. And when you speak, समोरच्या माणसाला तुमची सिन्सिरिटी, दॅट इज S. P म्हणजे पर्सनॅलिटी, E म्हणजे तुमचा एक्सपिरियन्स, A म्हणजे तुमची ऑथेंटिसिटी, आणि K म्हणजे नॉलेज. या सगळ्या गोष्टी कळल्या पाहिजेत. अरे डॉक्टर जोक बोलते म्हणजे ही इज ऑथेंटिक, ही इज डेफिनेटली अ गुड अकॅडमिशियन, ही इज एक्सपिरियन्स्ड. हे सगळं त्या समोरच्या पेशंटला कळलं पाहिजे, तसं बोलायचं. तर त्यामुळे ऑलवेज बी सिरियस इन युअर क्लिनिक. आपण इथं जरी गप्पा मारत असलो तरी क्लिनिकमध्ये एकदम शांत राहायला पाहिजे, बिकॉज पीपल डोंट लाईक डॉक्टर्स हू आर व्हेरी कॅज्युअल अँड जुव्हियल. आपण आपल्या ग्रुपमध्ये गप्पा मारतो, विनोद करतो, पण चले पेशंटला ते एवढं कळत नाही. अँड दॅट्स वाय यू हॅव टू बी व्हेरी सिरियस. दे ऑलवेज वॉन्ट दॅट डॉक्टर जोक शुड स्पीक ओनली अबाउट देअर चाइल्ड अँड देअर चाइल्ड. ओके, अँड रेग्युलरली अपडेट व्हॉट एव्हर यू आर रीडिंग. तुमच्या ब्रँचमध्ये जे काय तुम्हाला समजत नसेल ते तुमच्या मित्रांबरोबर डिस्कस करा. हल्ली ऑडिओज असतात, व्हिडिओ बुक्स असतात, ती वाचा. मी इकडून तिकडे जाताना बऱ्याच वेळा 1-1.5 तासाचा वेळ असतो, त्या वेळेला ऑडिओ कॅसेट्स ऐकतो. I update myself regularly while I am traveling in my own car. Okay, and lastly, my dear friends, have a very good lifestyle. Don't have a wrong lifestyle. म्हणजे काय नाही, दिवस रात्र कामच नका करत राहू. टाइमावर जा. सकाळी मी सांगितलं, यू गो ऑन टाइम, बट ऑल्सो शट डाऊन युअर क्लिनिक इन टाइम. ओके, रात्री 8-9 बंद करायचं म्हणजे बंद करा. आपले कितीतरी कलिग्स 10, 11, 12 दे टेक प्राईड इन दॅट. अरे चले रात्री 2 पर्यंत माझी ओपीडी चालू असते. अरे पण घरामध्ये बायका पोरं तुझी वाट पाहत आहेत, त्यांच्यासाठी वेळ द्यायला पाहिजे ना. किती कमावणार, आणि अल्टिमेटली कमावलं तरी समबडी इज गोइंग टू टेक इट अवे आफ्टर सम टाइम. ओके, so be moderate in all the lifestyle activities. There are many things which I can say, but I will not take more time about lifestyle today. But remember to have balance in everything and take a right decision to control and stop your practice in time. 60, 62, 65, 70 झाल्यानंतर hand it over either to your son, daughter, or some good friend, and then you slowly try to retire. This is an extremely difficult decision for many of us to stop the practice. कारण पेशंट्स येत आहेत आणि तरी सुद्धा प्रॅक्टिस बंद करायची म्हणजे काय. सो स्लोली स्लो डाऊन करा. That is of course for those who are senior in the audience, but those of you who are young, you continue to practice in full swing, but at the same time see that you manage your family and finances properly with a proper balance. With that, I will just tell you that the biggest mistake in life is not to learn from the mistake. Okay, so whatever wrong you do, please try to learn tomorrow. During this process you may commit mistakes which are quite rather grave, but anyway you have to learn from that. So these are called pitfalls. Pitfalls mean major mistakes, but even if you fall, you get up again, continue, have the same patients. Some patients may leave you because of your mistakes, but doesn't matter, you continue your own journey, and I wish you a very happy journey. Thank you.
Sir, I have a question for you. First of all, I'd like to thank you, sir. It's an honor for us that you're here. You're one of the few on the Indian Academic Forum who managed to be light and witty in their presentations and, hit the nail on the head also at the same time. My question is a little controversial, sir. With practice becoming more and more competitive, you have big corporate hospitals going all the way, in publicizing. They have celebrities like Amitabh Bachchan coming on billboards. Then you have pathies, alternative treatments boasting of 100% treatment. So to what extent is it still justified and ethical for a doctor with a small practice to not to advertise? He's the one who's always judged the most by, society as well as, colleagues also.
I personally, I feel that we have to be ethical. There is no way out, because a doctor who is small in stature, practice in the community, particularly maybe at your place like Nanded, or even, whether it is Nanded or whether it is Pune, the word of mouth is the only way by which the doctor is judged. Okay, I have hardly seen patients coming to me after reading about me somewhere or listening to me somewhere. Okay, majority of the patients come because, sir, the जाधव पेशंट आहे ना, त्यांनी आम्हाला सांगितलं की जोबकडे जा, त्यांनी चांगलं तपासलं. ओके, सो दे कम बाय वर्ड ऑफ माउथ. मेजॉरिटी हे आपले गुगल आणि याचे रिपोर्ट आणि ते बघून येतात, बट दे आर लाईक नॉट अ व्हेरी मेजर पर्सेंटेज. आणि आय एम शुअर तर नांदेडमध्ये तर लोक एकाच एकाला सांगूनच येणार. तिथे कोण गुगल ओपन करते आणि कोण तुमच्या याच्यावरचे रिव्ह्यूज बघते. ओके, बट पीपल इन मुंबई अँड दिल्ली अँड ऑल, दे टेक प्राईड in having very good reviews about their practice and all. Okay, everybody will have their own opinion, but then for corporate hospitals it is necessary, कारण त्यांना त्यांचं सगळं रोजचं काम चालवायचं आहे ना, तर त्यामुळे तेवढे त्यांच्या बेड फुल पाहिजे, तेवढं सगळंच पाहिजे. अँड दॅट्स वाय there is different lookout of these corporate hospitals. पण मला वाटतं आपण as an individual practitioner, लेट अस बी एथिकल. आणि काय होतं ना, एथिकली वागलं की रात्री झोप चांगली लागते. ओके, यू गेट अ गुड स्लीप. नाहीतर झाले काहीतरी डोक्यावरती राहिलंय, काहीतरी यू आर नेव्हर सॅटिस्फाईड. अँड सॅटिस्फॅक्शन इज समथिंग विच इज व्हेरी इम्पॉर्टंट. ओके, त्यामुळे कुठं सॅटिस्फाय व्हायचं ना, ते मी सांगितलं तसं, दॅट्स अ व्हेरी 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 डिफिकल्ट डिसिजन इन एव्हरीबडीज लाईफ. मच वॉन्ट्स मोर, अजून येऊ द्या, चले 100 रुपये नाही, अजून 200, 200 नाही 300. शेवटी अल्टिमेटली द प्रायोरिटीज इन लाईफ डिफर. For some, academics may be the priority. Some of them, family may be the priority. Some of them, social work may be the priority. And some of them, money might be the priority. Unfortunately, in our community, एवढी maturity नाही विचार करायची की माझ्या आयुष्यात मी कशाला प्रायोरिटी देतोय. Okay, so as sensible doctors in the community, let us decide that our priority is basically to be academic and rational. Okay, money is a byproduct of that, and let us earn money ethically. I don't think की आपल्याला एथिकली वागून काय फार कमी पैसे मिळतील असं नाही वाटत. आणि ड्युरिंग पॅन्डेमिक वी हॅव लर्न दॅट आवर नीड्स आर सो मिनिमम. त्याला कपड्यामधले मी 10 कपडे सुद्धा वापरले नाही 2 वर्षामध्ये, तेच आलटून पालटून वापरले. ओके, द पॉइंट इज दॅट आवर नीड्स आर व्हेरी मिनिमम, अँड अननेसेसरी पीपल गो फॉर 4 cars आणि हे आणि ते पीपल, बट अल्टिमेटली इट मे बी ऑफ लिटल हेल्प. सो कंटिन्यू एथिकली, लेट अदर्स व्हॉट दे वॉन्ट टू डू, लेट देम डू इट. आवर पेशंट्स आर वाईज इनफ. निवडणुकीत जसं बरोबर योग्य माणसाला निवडून देतात, तसेच आपले पेशंट सुद्धा योग्य माणसाकडेच जातात. तुम्ही जरी सांगितलं की मी न्यूरोलॉजिकल केस हँडल करतो, तरी तुमच्याकडे नाही येणार. तो चौकशी करून पीडियाट्रिक न्यूरोलॉजिस्ट कडेच जाईल ऍट सम टाइम ऑर दी अदर. ओके, सो पीपल आर वाईज इनफ. तुम्ही किती ऍडव्हर्टाईज केलं तरी एकदा दोनदा ते इकडे तिकडे जातील, पण अल्टिमेटली दे विल कम टू नो. ओके, दॅट्स वाय आय सेड यू कंटिन्यू युअर जर्नी. ओके, some patients may come with you, some may leave you, but at the end you have to continue that. Okay, so these are some truths in life we have to understand and follow. Okay,
Thank you, sir, for such a nice presentation. Now we move on to our next speaker, Dr. Sandeep Patil, sir.
Thank you, Mayura ma'am. First of all, before going to my lecture, I want to thank Jog sir for very enlightening lecture, sir. And without wasting time, we'll go ahead. What I am going to discuss today is about what is new in neonatal resuscitation. See, neonatal resuscitation program, that is NRP, has been updated in 2021 June. And from June, we are taking multiple newer NRP updates physically also and online also. So I will try to put that in a short, what new things are there. We are not going to discuss about which were there in the older versions of NRP, that is the 7th edition. The newest version is now 8th edition, which is published in June 2021. So basically, I will be putting a tag of new arrival or new in a point where it is changed over the previous guidelines. So it will be made you easy to understand what is the thing which has been introduced in a new NRP. Basically, many changes has happened in dosing schedules. Many changes has been happened when to stop neonatal resuscitation for a non-beating heart. So which is very important clinically also, for baby's outcome also, and for medico-legal issues also. So you should be knowing about what are the changes in neonatal resuscitation. So we'll move ahead. It's down for me. Yeah, so this is a new arrival. Previously, NRP Basic and NRP Advanced were 2 courses. Now NRP Basic has been changed to NRP Essential. So NRP Essential is a program where we train to the people whoever comes in contact with the delivery of the baby. And NRP Advanced is a course where we train to the people beyond positive pressure ventilation. So these are the 2 separate courses, but everybody who is taking care of a child, that might be Dai, that might be a sister, or that might be a doctor, should be basically trained about NRP Essentials. And for advanced NRP, all doctors should be trained. So we'll move ahead. So just I put this slide in front of you to show that each and every delivery should be attended by pediatrician. To show the importance, I have made this triangle. So which is showing that 100% of the deliveries need assessment of the baby at birth, and routine care should be advised to 100% of the babies. And that's why all the deliveries before birth of the child should be informed to a pediatrician, and pediatrician should attend that delivery sincerely before delivery of the child. To give importance to you, you can understand, first point, as I told you, all babies need assessment as well as routine care. So see, if a baby is not attended at the time of delivery, and if the baby is having anal atresia, where we have a habit, or where we have a routine teaching of putting orotracheal tube as well as orogastric tube, as well as and we check patency of the anus. So if we have not checked the patency of anus, parents are going to feed the child, then will lead to distension of abdomen and intestinal perforation. To avoid the complications of not seeing the child, as well as assessment and proper care of the child, 100% of the deliveries should be attended by the pediatrician. So we will go in question and answer format type, so it will make you more comfortable, as well as you will remember also.
Sorry, your
So how
slides
many
are
trained
not moving
persons should be
actually.
present at the time of birth? So we need at least 1 trained person for initial steps, and for initial steps as well as essential
Dr.
NRP.
Sandeep?
And we need, if mother is having any risk factor, or if we suspect that it is going to be high risk delivery, then 2 qualified persons should be there. So what are qualified persons? Qualified persons should be trained beyond positive pressure ventilation, and positive pressure ventilation beyond should be trained to people who are trained in advanced NRP.
Full screen exit.
Slide more than that. 1 second. My slides are moving or no? No. Exit. Now it's moving. Yeah. So, so qualified person is a person who is qualified beyond positive pressure ventilation, and that makes to attend them for high risk delivery. Then when and how to anticipate resuscitation and what risk factor will alert you. So there is a list of risk factors which I had put in front of you as a antepartum risk factors and intrapartum risk factors. So we will not discuss in detail each and everything. Just antepartum risk factor wise, you should know, you take one example of polyhydramnios. If you go before delivery of the child and if you find that mother is having polyhydramnios, your mind will tell you that baby is going to have some problems, such as baby is going to have tracheophysial fistula, baby might be having some neural tube defect, open neural tube defect, or baby is going to have some patent urachus or different syndromes in which there is opening, bladder is open from the front and associated kidney malformations are there. As well, if all things are fine on structural sonography, then you may think of mother is having diabetes or some placentomegaly or something is there. So such point of time, if you are investing before delivery of the child, then you can find what risk factors or what things you have to see in the baby. So you will not miss putting a orogastric tube in the child. You will not miss to see the back of the child if you know and beforehand only mother is having polyhydramnios. So risk factor assessment as well as taking the history of mother before delivery of the child is very important point. So keep in mind before going for delivery. Then pre-birth history wise, previously 3 questions were there. New thing to be added is what is umbilical cord management plan. So umbilical cord management plan is nothing but before delivery, if there are no risk factors, we are anyway going to delay the cord clamping. But if there are risk factors, then we should plan that whether we are going to delay till the initial steps or whether we are not going to delay at all. So your team, including obstetrician, should know what is the umbilical cord management of that particular child. So when you will understand that, before that, if you know the history of mother as well as any risk factors are there, then only you are going to defer that. Otherwise, you are not going to defer umbilical cord delayed clamping. Then how you are going to prepare for birth. So we had been teaching since long many years that we have to prepare in the labor room. You have to switch on the warmer and multiple things have been taught. So I have tabulated them. I have grouped them into forming of a team, forming or preparation of a room and neonatal corner, preparation of self and preparation of equipments. Equipments needed are, this is the list. So list also it has been tabulated in such a form that if you are preparing for birth, if you are preparing a medication, only 2 medications are needed that you have to keep in mind. You need normal saline, then you need adrenaline. So adrenaline should be pre-diluted from 1:1:1000 to 1:10,000, and you know the expected fetal weight of the child by sonographic measures. So if it is a 3 kilo, then you should pre-fill the syringe with of 0.3 ml to 0.6 ml. So in dose section, again, we are going to discuss what ranges has been mentioned or whether any fixed dose had been given to adrenaline. Normal saline wise, you should keep 100 ml of normal saline. And for giving medication, you need some utensils such as you need umbilical venous catheter and other things for intraosseous insertion of fluids. So like that, you should be prepared, you should tabulate, you should form what intervention you are going to do, and like that you have to prepare yourself so that you are not going to miss anything. Then there are certain practical problems. See, we read multiple times that the baby should be delivered on the mother's abdomen. So I am going to ask you on open forum, how many of you in a normal delivery are requesting your obstetrician that deliver the baby on mother's abdomen? I think there are only few centers that might be doing that, but you make a habit of doing that. Request your obstetrician to do skin to skin contact of the baby after delivery normally and put on mother's abdomen, which is having multiple advantages. Initially, you will feel a lot of obstacles. You will have a lot of resistance from obstetrician staff as well as from your other pediatric colleagues also. But first, you have to self-motivate yourself for having the advantages of having skin to skin contact, and try to encourage and insist your obstetrician to do that. Then See, multiple NRP programs. You might have seen the multiple programs in which few times these 3 questions has been asked as term gestation, good muscle tone, breathing or crying, or you might have seen such kind of basic neonatal resuscitation program as essential NRP, or HBB means how to help the baby to breathe, and basic NRP where only one question is asked, is the baby crying? So ultimately, whatever course you are doing, you should know that most important question here is the baby crying? If the baby is not crying, then you should consider for further initial steps of the child, which we are going to see one by one. So in a routine care, just I had put this slide in front of you to tell you that in routine care, multiple these points are there where 90% of the babies need that only. Why I had put, or just I am focusing on routine care, because almost all 10 babies, if they are delivered, 9 babies will need that. So you should know that you should keep the baby in skin to skin contact, position and suction only, dry and remove wet linen, cover the baby with warm sheet, put head cap, identity tag, delay cord clamping for at least 1 minute, initiate breastfeeding and ongoing monitoring. The rest of the discussion is for only 10% of the babies, which we are going to discuss in further lecture. So as you know, we have told our obstetricians that we have to do delayed cord clamping. So we'll not go much in detail of that, but new thing you should know that if we can consider for delayed cord clamping in the babies in whom the baby is having a lot of risk factors, but for initial steps till you are going to consider for giving positive pressure ventilation, you can consider for doing delayed cord clamping in that babies also, where you have to prepare a separate station for receiving the child, cleaning, drying the child, clearing the mouth and nose of the child, where obstetrician can still wait for at least 30 seconds for clamping the cord, where the baby is going to get the advantage of delayed cord clamping. This is the new arrival in a new NRP. Other things are same, which we are not going to discuss in detail. So as I told, what do we do if the baby doesn't cry? First and most important thing is don't be panic at all and try to go algorithmically. So initial stepwise, this is also a new arrival in that. So if we don't want to miss anything, we should remember the short form of DSPS. Warm the child and do DSPS is in initial step. DSPS is nothing but dry, stimulate the child, remove wet linen. S means for stimulating the child, position the child, and suctioning of the mouth, followed by nose if needed only. So the new arrival in that is this short form of DSPS, and you can see that in stimulation, only rubbing of the back has been mentioned. Previously, there was flickering of the soles, hitting of the back, like that it has been mentioned. So it has been removed. Only rubbing of the back 2 times is considered only a proper stimulation of the child in initial steps. Then after initial steps, how we are going to assess the child. So here also one thing is there. The babies who are having labored breathing, you can consider for use of pulse oximetry. So this is a new addition in that. The use of pulse oximetry is must in all labor rooms. And why it is must? Because oxygen is not a simple thing. It is a drug. If you are giving it is in an overdose, it is going to cause problems in the child. So it has been mentioned also. So 1 minute baby is not going to have a normal saturation. Normally baby is going to have saturation from 60 to 65 at 1 minute. That's why you are able to find baby as cyanose at birth. So need not to start oxygen till 10 minutes if you are going to get only cyanosis in the child, if other things are fine, because you can find that your eyes are going to see cyanosis when the saturation is less than 80%. So targeted saturation related approach is needed if you are going to titrate use or no use of oxygen. So use these charts, use SpO2 monitors in labor room, and try to limit use of oxygen. So see, I had put it for term and preterm babies. Why? Because in preterm babies, they are more prone for oxygen related toxicity. And there are also, if we are giving in less dose oxygen, it is going to have problems in the baby. So that's why For 1 minute, if the term baby is having 60 to 65 saturation, at 2 minutes, preterm babies are going to have 55 to 75% of saturation. But after 10 minutes, they are going to have a normal saturation range as that of adults. So if the baby is having labored breathing, so there are different techniques where we can inflate the chest of the child, help the child to breathe. So one technique is using CPAP. So in labor room, CPAP availability is also main. In newer edition, they have mentioned it as a mandatory. So in meconium stained baby status quo, if people have underwent 7th edition course, they know that there is no need of routine suctioning of endotracheal by putting endotracheal tube and taking out the meconium. And there is no routine indication of giving bag to tube ventilation only to them. You can consider giving bag and mask ventilation. So there is no contraindication of giving bag and mask ventilation to a child who needs ventilation for meconium aspiration syndrome. So there is no change in 8th edition, but in 7th edition only it got changed. So in the initial steps, if baby is having apnea, after doing initial steps, if baby is having gasping respiration or baby's heart rate is less than 100, at this point you should consider for connecting positive pressure ventilation to child, and use of pulse oximetry comes here. So the devices used for positive pressure ventilation are these different. On top, the self-inflating bag is there, where we are well versed with. And down right side, we can see that it is a flow inflating bag where anesthetists are well versed with. But few of the people who frequently go in operating room where they can find such kind of flow inflating bag. So you can also be well versed with that. Third thing is T-piece resuscitator, where T-piece resuscitator can give PWP also to the child. Why there is no need of intubation to all kids? Because intubation is not the final solution. Your primary aim is to give ventilation, effective ventilation to the child. Not only ventilation, it should be effective, and effective ventilation can be given by alternative airways also. That is alternative techniques such as bag and mask ventilation, LMA, and finally, if it is not improving, then you can consider intubation as the final intervention. One more thing is coming up is the new thing is that heart rate assessment doesn't depend, or heart rate assessment is should not be done by palpating the base of the cord. So pulse, as we have been taught previously, that you have to put your fingers at the base of the umbilical cord, count for 6 seconds and multiply like that. So it is considered lower in the standard. Another better in that is auscultation directly over the chest and auscultate over the heart. And better than that is ECG. Putting ECG electrodes is practically difficult, but if you try to do that, it is also easy. So previously putting use of pulse oximeter also was considered a very difficult or unachievable task by pediatricians. So we got convinced to use pulse oximetry as well as CPAP in labor room. So we will get convinced to use ECG also, which is considered gold standard. When you are using oxygen, as I told, you should use targeted approach for using saturation targeted approach for using oxygen. Simple point you should keep in mind: if the baby is less than 35 weeks, titrate oxygen. For that you need blender. So start with 21 to 30%. The babies who are more than 35 weeks, start with 21% and then act accordingly. See, positive pressure ventilation effectiveness is assessed not by the end of 30 seconds as previously had been taught. After 15 seconds only, you should assess the child whether it is effective that you are giving positive pressure ventilation. If your positive pressure ventilation is not effective, then you should use MR SOPA, which we used to use that. So MR SOPA was previously used as continuous. Mask means continuously we used to correct that. Mask readjustment, repositioning of the head and neck, suctioning of mouth and nose, then opening of the mouth, then pressure increase and alternative airway. We used to do at the end of 30 seconds. It's not like that. After 15 seconds or so, you should start using that. And in between the two, like mask readjustment and reposition the head and neck, give 5 breaths. If there is no improvement or no chest rise, then do another 2 intervention as suctioning of the mouth, nose, and followed by opening of the mouth. With these interventions, again give 2 breaths, 5 breaths to the child, and do increase in pressure, increase in that. Like that, you have to use MR SOPA. Yeah. Just I need 5 minutes. So another thing is chest compressions. As we have discussed previously, we should use 2 finger. We will not go detail in that. And the phrase used is 1 and 2 and 3 and breath. That is also same. LMA use and ETCO2 monitor use also has been encouraged. It is not mandatory, but desirable from few units. Then we should consider for chest compression, means all things we have done for 30 seconds. But for chest compression, you should consider for doing chest compression for 60 seconds. This is also a new thing. Then comes medication part. Medication part wise, there are not many changes. The role of adrenaline route, the flush volume, and that. So which I had put it here. So preferred route is always IV, not endotracheal route. Preferred flush volume is 3 ml only. It is not 1 ml or 2 ml. This is for convenience only. We had put it forward, or newer edition had put it forward. Intraosseous route is an alternative for if you are not able to put umbilical catheter. Dose is also fixed now. Previously, dose was 0.1 to 0.3 ml. Now it is 0.2 ml per kilos, 1:10,000. When IV access has been assessed, you can put endotracheal adrenaline, and dose is 1 ml per kilo. If 3 kilo baby is there, 3 ml of that you have to put. And when you are able to put the line, then at that time you should disregard the dose which you have given through endotracheal. So after immediately putting umbilical venous catheter, you IV dose. So lot many changes in the dose and lot many changes in the route also. So with that also, if heart rate is not increasing, you should continue for 60 seconds, and positive pressure ventilation should be considered, and volume expanders should be considered in the babies in whom they are not responding to medications. Then another important change is in resuscitation stoppage. So resuscitation stoppage should be considered if heart rate is 0 for more than 20 minutes, then only it is should be considered. Previously it was 10 minutes. So it is medico-legally also useful when you are going to consider to stop a resuscitation, that is 20 minutes. This is the newer chart which we have discussed one by one in the previous slides. So in short, this is the summary of what I have told. It has been tabulated here. So umbilical cord management plan is added as a fourth question, where you have to beforehand only delivery of the child, you should make an umbilical cord plan. Then initial steps wise, the DSPS is the short form added, where you will not forget what to do. Then electronic cardiac monitors such as ECG monitors should be considered when alternative airway or chest compression. If advanced ventilation or advanced NRP you have to do, you can consider for that. About adrenaline, dosing is increased to 0.2 ml per kilo. Flush volume is 3 ml after that. IV umbilical venous line is the preferred route for giving adrenaline. If you are giving adrenaline through endotracheal tube, use 1 ml per kilo of adrenaline. Then disregard this dose if you are able to put a umbilical line after that. Then another thing is when to stop resuscitation is after 20 minutes of 0 heart rate of the child. So while putting on notes also and performing that, you should consider. And NRP is not a single person's job. It is a teamwork. So we should work together as a team. Thank you. Thank you very much. Any questions are there, you can ask. You can unmute and ask.
Very nice
There
talk,
are no
Dr.
questions,
Sandeep.
I think so.
I just have a
So,
small question, Dr.
if there are
Sandeep.
no questions, we'll move on to another lecture. Over to Mayura ma'am.
Thank you, sir. Such a wonderful for the wonderful lecture and updating us about the new in neonatal resuscitation program. Now let us move on to our next speaker, Dr. Sachin sir. Are you there?
Yes.
He is a cardiologist at Bajaj Hospital. He has 12 publication in national and international journal. Let us move to Dr. Sachin sir.
Good afternoon, everybody. Am I audible?
Sir.
Am I audible?
Yes, sir. Yes, sir.
Good afternoon, everybody. It's nostalgic to be with all of you, my seniors, many of my friends and juniors. They are practicing in Nanded. So let's discuss about congenital heart diseases and how we should approach in diagnosing a congenital heart disease. So the problem is huge. Like 1 in 100 newborns in India are suffering from congenital heart disease. So these are the figures per 1,000 live births. You get so many congenital heart diseases. Nearly 1/3 of they account for nearly 1/3 of the congenital defects at birth. Nearly 2.5 lakh babies are born in India every year with congenital heart disease. It's 1/5 of the total global burden of congenital heart disease. 35% die before 2 years of age and is a major contributor to the under 5-year mortality. So there is a lack of facilities for diagnosis and treatment for these huge number of patients. The problem is huge, probably related to the nutritional status of the mothers or probably related to exposure of unknown teratogens. And there is issue with the consanguineous marriages in many of the communities in India. That's why the problem is huge. We need to address that. Many centers, dedicated pediatric centers are coming all over the country. And if we diagnose the congenital heart disease at an early stage, the inoperable stage can be avoided and we can give justice to the child. So the congenital heart diseases are classified based on the saturation level like cyanotic and acyanotic. Among the acyanotic, we have 2 groups, that is left to right stents and the obstructive lesions. The left to right stents, as we know, ASD, VSDs and PDAs, obstructive lesions, pulmonary stenosis, aortic stenosis and coarctation of aorta. Among the cyanotic, the classification is of pulmonary stenosis with right to left shunt, with shunting at the atrial level. It consists of critical pulmonary stenosis. Then because of opening of the foramina OL, there is desaturation or right to left shunting because of high pressure in the right side heart chambers. Then we have Epstein's anomaly, in which there is functional pulmonary stenosis. The second group is pulmonary stenosis with VSD, which is we know commonly refer as Fallott's physiology. Then we have admixture physiology, that is the increased pulmonary blood flow situation, consists of transposition of great arteries, total anomalous pulmonary venous drainage, DORV, truncus arteriosus, and then rare ones. And then we have the decreased pulmonary blood flow physiology like Eisenmenger syndrome. So a cyanotic group, this is the classification of congenital heart disease. So we'll discuss how we approach the congenital heart diseases. So for suspecting presence of congenital heart disease in a child, we need to develop a clinical acumen, which comes through discipline, and it takes a long time to master. And the mysteries in clinical cardiology can be solved just like a puzzle if we use a logical and algorithmic analytic approach. It is similar to the adventures of Sherlock Holmes, and it requires a great observational power and an analytic process. If we follow a sequential approach to differential diagnosis with some sound theoretical comparison in our mind, then the clinical cardiology is just like mathematics. Definitely, I will tell technology cannot replace the clinical skills because technology has some limitations in terms of availability, safety of the many of the investigations, then cost efficacy, which is a major issue in developing countries like ours. And there is misinterpretation in many of the diagnostic tests. Many times we may be carried in a different direction if the diagnostic tests tell us something different. So my late teacher, Dr. D.V. Mule sir, used to use a simple stethoscope of 250 or 300 rupees, and he used to listen and diagnose all the congenital and adult heart diseases with great accuracy. And we used to use Littmann, this and that version. But it is the brain in between the 2 years that has to develop the clinical acumen rather than some high-end stetho or some high-end equipment. So at the end of clinical examination, we should have something in mind so that we can at least advise what investigations or what further tests the patient needs to undergo. So this is these are the physiological changes and pressures comparing the fetal and the adult circulation. Expansion of the lungs at birth, clamping of the cord, closure of the ductus arteriosus and venosus transform the fetal circulation to the adult. So we have a very high pulmonary vascular resistance that of 250 Wood units in pulmonary circulation before birth, and at the adult it falls to 1 Wood unit. The pressures in heart chambers and right and left are 60 systolic and 40 diastolic in the fetal life, whereas the systemic pressures in adult life are around 120 by 75, and in the right sided chambers it is by 25 by 10. So the pulmonary vascular resistance falls drastically after birth. That's why these pressure changes happen. These have implications when we consider our clinical examination. This we should have in our mind before we approach to diagnose congenital heart diseases. So it takes 2 to 3 weeks for PVR to fall in normal babies, and the right ventricular thickness regresses by 6 months. Hence, PDA and VSD murmurs are not clinically audible till 6 to 10 weeks of life. And similar is the reason for large VSDs and PDAs to manifest as CCF. It takes at least 6 to 2 weeks. So they are not clinically detected, and even CCF will not develop at birth. Similarly, ASD murmur cannot be appreciated in first 6 months of life. So this is a pitfall of clinical examination because RV thickness regresses at 6 months. But definitely a murmur of aortic stenosis or pulmonary stenosis, a mitral wall prolapse with significant MR, or a dysplastic tricuspid wall with severe TR murmurs, they will be recognized at birth. So as is relevant in all fields of medicine, history is most important. If we find that baby is not able to feed properly, baby is feeding, then baby is resting for some time, again feeding, this is a sign of congestive heart failure in baby. You should suspect left to right shunts. If baby is getting repeated respiratory tract infections, or there is history of admission for lower respiratory tract infection, we again suspect left to right shunts. Because of increased pulmonary blood flow, there is increased susceptibility to develop respiratory infections. Forehead sign is a sign of Cyanocunin for CCF. Then CCF added with the repeated respiratory tract infection leads to failure to thrive, and the weight gain is not there. This is common with left to right shunts. Whereas the cyanotic congenital heart diseases, they present with cyanotic spells. We broadly label them as top physiology. So in infants, the cyanotic spells, they are present with a fussy, insoluble cry. They develop deep cyanosis. Then they, to compensate for the low saturation levels, they hyperventilate or hyperapnea. Whereas in older children, the cyanosis, because of cyanosis, they get adapted, they try to increase the peripheral vascular resistance by squatting, and the presentation is of a squatting. So after history, even in history, we should ask about the antenatal sonography, whether it is done or not, because many times the defects these days are detected antenatally. So that is one part of history. On general examination, whenever the child enters the clinic, you can judge whether the child is well developed, well nourished, or it's not there. Activity of the child, whether child is irritable or it's dull. Then growth and development, all the cyanotic congenital heart diseases, the stunt, there is weight is less for age, but height is normal. Whereas for cyanotic congenital heart diseases, both weight as well as height, they are less than the normal standards. So that is important when we examine the patient. Cyanosis with widespread availability of saturation probes. Nowadays, it's not missed, and cyanosis, if we clinically notice, definitely it will have its companions in the form of clubbing and polycythemia. Uniform cyanosis all over the body indicates right to left shunts, whereas cyanosis in the lower limbs and no cyanosis in upper limbs indicates differential cyanosis, that is indicator of a PDA with reversal of the shunt. Very high blood pressure in pediatric or pediatric patients, we should suspect coarctation of aorta and non-specific aortoarteritis, that is previously it was labeled as Takayasu arteritis. We should also look for extracardiac abnormalities such as syndactyly, polydactyly. These are common association with VSD. Then absence of a digit is common with ASD. Moon phases and hypertaylorism is common with peripheral pulmonary stenosis. We should also look whether the child is able to hear properly. Many times parents miss it, and many times this happens. We diagnose the patient as having PDA, and later on these children are diagnosed to have hearing defect. So that happens quite often. So we should assess the hearing ability of the child. Then we should look whether there is any syndromic look in the child. Most commonly Down syndrome. It is most commonly associated with AV canal defects, VSD and TOF. Then Marfan syndrome. It is associated with autoannular ectasia, and which later on develops into aortic regurgitation. So Marfan's will have a very long stature, long upper limbs. So short stature is seen in Turner syndrome and Noonan syndrome. So these are the NADA's criteria. Does the child have the heart disease? We need to have one major or two minor criteria to diagnose the heart disease. These are based on clinical parameters and ECG and X-ray. So major criteria include systolic murmur of grade 3 or more, diastolic murmur, cyanosis, and presence of congestive heart failure. Minor criteria: systolic murmur of grade 3 or less, abnormal second heart sound, which is a slightly subjective finding. You need to master the clinical acumen. Abnormal ECG, abnormal X-ray, and abnormal blood pressure. So these are the minor criteria, because in children the X-ray has some fallacies. So on cardiovascular examination, if we find a precordial bulge, then we suspect left to right shunts. If apical impulse is displaced and localized, you suspect aortic regurgitation or mitral regurgitation. If the apical impulse is not displaced and heaving, we suspect pulmonary stenosis or aortic stenosis. Look for presence of parasternal scars if they are found in post Blalock toxic shunts or coarctation repair or PDA ligation. Most of the murmurs in congenital heart diseases, they are heard in the parasternal area. If we hear a murmur in apical area in a child, most likely we are dealing with ostium primum ASD with a significant MR, or rarely ostium secundum ASD with MVP with MR. So in auscultation, the more importance is given to the heart sounds rather than murmur. second heart sound is the key to the auscultation of the heart. It has two components, aortic and pulmonary. During inspiration, there is delay in the P2 because of increased blood coming into the RV. There is increase in the right ventricular ejection time. That's why P2 is delayed. Whereas in expiration, the A2 is because of inspiration, the split widens. The major contribution is by P2. But first 3 months of life, the P2 is louder than A2 because the RV pressures are higher. Multiple heart sounds are heard in Epstein's anomaly. Nearly 5 to 6 heart sounds are heard. The two components of the first heart sound, two components of the second heart sound, then systolic click is heard, and S3, S4 is also heard. So this is the diagram showing the normal split. Within expiration, there is no split or minimal split in the second heart sound, whereas with inspiration, there is wide split. The others are wide and variable split, wide and fixed split, which is commonly seen in ASD. Then there is something called as paradoxical split. So split is heard in expiration and there is no split in inspiration. This is seen in aortic stenosis patients. So this is the diagram showing the intensity of the A2 component is increased in systemic hypertension patients or AR. Intensity of P2 component is increased in severe pulmonary hypertension patients. Then second component are absent in aortic stenosis and pulmonary stenosis, respective components. Then we have the paradoxical splitting in aortic stenosis and LBBB. So these are the so loud P2 is mainly seen in pulmonary, severe pulmonary hypertension, then idiopathic dilatation of pulmonary artery and ASD. The intensity of the P2 is judged by intensity of the P2 relative to the A2. If P2 is louder than A2, probably there is presence of pulmonary hypertension. And the area of pericardium over which it is audible. Normally P2 is audible only in the first, second, third left intercostal space by the side of the sternum. If it is audible at fifth intercostal space or at the apex, we say that it is loud. So this is the diagram showing the various valvular heart diseases and the timing of the murmur. So normally, so there is no murmur. In aortic stenosis, we have an ejection diamond-shaped ejection systolic murmur. Then in mitral regurgitation, we have a pan-systolic murmur. Then in aortic regurgitation, there is an early diastolic murmur, whereas in mitral stenosis, we have a mid-diastolic murmur. And at the last, at the bottom of the diagram, we can see PDA murmur, which is a continuous murmur throughout the systole and as well as diastole. So the pan-systolic murmurs, they are generally organic. Most common causes are mitral regurgitation, tricuspid regurgitation, and ventricular septal defect. They start with first heart sound and they end at or beyond the second heart sound with the same intensity throughout the systole. If we have a thrill in presence of a pan-systolic murmur, then you are dealing with VSD. Then ejection systolic murmur, this is a diamond-shaped murmur starting with S2 and ends before the corresponding component of the second heart sound. It can be organic or functional and mostly commonly seen in right or left ventricular outflow obstruction lesions like pulmonary stenosis or aortic stenosis. The murmur is generally of grade 3 or more, and if thrill is present, we are more likely dealing with an organic illness. Presence of ejection click again favors the organic nature of the valvular stenosis. Functional murmur, the murmur is of grade 2 or less intensity. 50% of children less than 5 years of age have ejection systolic murmur, which disappears as the child grows. The most common cause is hyperkinetic state due to anemia. With practice, you can master or judge the musical murmur. Generally, they are functional murmurs. Then diastolic murmurs, as we have discussed, early diastolic murmurs we see in AR. AR in congenital heart diseases most commonly is seen with bicuspid aortic wall, then coarctation of aorta, pulmonary subpulmonic VSD, then ruptured sinus of Valsalva, PDA patients, and adult TOP patients. PR in congenital heart disease is rare, and TOF with absent pulmonary wall syndrome is common cause. Then mid-diastolic murmur in congenital heart diseases is also rare. Mostly they are flow-related, seen in ASD and VSD patients. They don't have late diastolic component. In continuous murmurs, they can be with cyanosis and they can be without cyanosis. So the PDA, the classical description is the machinery murmur, as if you feel that as if you are in some factory or around some heavy machine. The presence of machinery murmur indicates there is no significant pulmonary hypertension or severe pulmonary hypertension. Then second cause for continuous murmur is ruptured sinus of Valsalva. Then rarely we can encounter continuous murmur in coronary fistulas or coarctation of aorta because of collaterals or peripheral pulmonary stenosis. Venous hum is a normal or physiological finding in 40 to 50% of children less than 5 years. It's heard in the first and second intercostal space by the sides of the sternum, and it is abolished by the pressure over the medial end of the clavicle. So if we see carefully, then we may not overdiagnose about having a congenital heart disease. Because of the aortic runoff into either LV or into the pulmonary arteries, all of these above conditions, except for pulmonary stenosis, have a LV enlargement with signs of wide pulse pressure. With cyanosis, the continuous murmur, the diagnosis is the presence of collaterals in presence of TOF, mainly TOF with pulmonary atresia. Then in obstructive TAPOC, we get continuous murmur with cyanosis. Then pulmonary fistula is another cause. Post BT shunts also we can get continuous murmur with cyanosis. So at the end of the clinical examination, we should come to some conclusion, and then this can be supplemented by X-ray and ECG. Among these two modalities, X-ray is more helpful as compared to the ECGs. This is a normal chest X-ray. The heart occupies the thoracic cavity. 1/3 of it lies to the right of the midline, and 2/3 lies to the left of the midline. The right heart border is formed from above by SVC, ascending aorta, and right atrium. Then left heart border from above is formed by arch of aorta, pulmonary arteries, left atrial appendage, and the LV proper. This we should know because proper chamber enlargement will manifest X-ray wise with that abnormality. Normally, the cardiothoracic ratio, which is the ratio of a maximum width of the cardiac silhouette divided by maximum internal transverse diameter of the thoracic cavity, is normally less than 0.55. In children, the fallacy is the cardiac size varies considerably with the respiration. If we take an X-ray during expiration, this is the most common cause, will get cardiomegaly, and that's why it's a major cause for referral for evaluation of congenital heart disease. So a proper X-ray is that is taken at the inspiration. So inspiratory film is must for diagnosis of cardiomegaly. Less than 2 years of age, the superior mediastinum will be widened because of thymus, and we can wrongly interpret it as a presence of cardiomegaly. So this is a spotter X-ray. If we see such a type of huge cardiomegaly, there are only two diagnoses. One is the child is having pericardial effusion or pericardial collection, or second is it's Epstein's anomaly. So you can ask for an ECG. If we get Himalayan P waves are very prominent P waves, then with RBBB, which is a splintered RBB complex, then probably we are dealing with Epstein's. And if you get a low voltage ECG, then it's an pericardial collection. Definitely echo will be the final answer to the question. So such type of X-ray is a spotter many times asked in exam. So congenital heart diseases, if we are dealing with, we get such an X-ray, it's Epstein's anomaly. Then there ventricular enlargement on X-ray. So this is a classical X-ray of a right ventricular enlargement. There is no much cardiomegaly, but the apex is turned upwards. So this is the common finding seen in TOF patients, tetralogy of Fallot patients. Whereas this is the LV type of enlargement on X-ray. So the apex is not upturned. It is a broad-based apex with the lung shadows being flooded with bronchial or bronchial vascular markings. That is called as plethora. This is classically seen in VSD, left ventricular type of hypertrophy. So third point on X-ray, we should note, apart from cardiomegaly and type of ventricular enlargement, is you should look for the pulmonary vascular markings. Normally, if we divide each lung field into 3 parts, the middle third will have some vascular markings, and outer third will have no or very few markings. So that is a normal thing. But if we are getting markings restricted to the only medial 1/3, then this is called as pulmonary oligemia. In association with, if there is an dilated main pulmonary artery, then the diagnosis is pulmonary stenosis. Opposite to this, as we can see, the even outer 1/3 of the lung fields, there are prominent vascular markings. So this is called as pulmonary plethora. This is classical of left to right shunts, mainly VSD, classical left ventricular type of environment. Then after this is the classical X-ray of an Eisenmenger syndrome, in which we get prominent central markings because of severely dilated proximal pulmonary arteries, but there are no vascular markings in the middle or outer thirds. That is called as peripheral pruning. This is the classical X-ray of an Eisenmenger syndrome. Then on X-ray, we should look for the presence. Yes.
Sir, you are running out of time. Can you please?
I'll do it fast. Okay.
Yes. Thank you.
At the inferior margins of the rib, we should look for the notching, presence of notching, which is seen in coarctation of aorta. So this is a rare X-ray of Schmitter syndrome. That is partial anomalous pulmonary venous drainage. These are, I will skip these slides. Then in ECG, we should look for 3 things: mean QRS axis, the atrial enlargement, and the ventricular enlargement. This is the normal ECG with positive complexes in one AVL. Then there is a transition, predominantly negative complexes in V1 and predominantly positive QRS complex in V6. This is the normal pattern. This is the juvenile ECG pattern. This can be seen in up to 16 years of age with prominent QRS in V1, V2. Then this is the ECG where the AVR and interchange of 1 and AVR. So this is classical ECG of dextrocardia. Then this is the diagram showing how to determine the axis. If 1 and AVF, we should look. If 1 and AVF both are positive, then the axis is normal. If 1 is negative and AVF is positive, then axis is right axis. So based on axis, we can diagnose presence of this is the right axis deviation beyond 120 degrees, and after 6 months of age, it is abnormal. And this is the classical ECG of an right ventricular hypertrophy with strain pattern, is commonly seen in pulmonary stenosis. This is a classical ECG of right atrial enlargement with Himalayan P waves. This is seen in Epstein's anomaly. Then this is the classical ECG called as KW phenomenon. Is biventricular hypertrophy, isoelectric complexes in mid-precordial leads, that is V2 to V4. Same amplitude of QRS complex above the baseline and below the baseline, that is seen in VSD. Then if we get such an ECG in congenital heart disease, suspect congenitally corrected transposition of great arteries. Then if we get SVT or AF in congenital heart diseases, then suspect Epstein's mitral valve prolapse or HOCM. This is classical ECG of ASD with RS-R' pattern in V1. This is rare one. I will skip this. This ostium secundum ASD, most commonly the type of ASD we see. It accounts for 75% of the congenital heart diseases. Most of them are asymptomatic, and majority of them can be treated with percutaneous device closure. This therapy is valid for only for ostium secundum ASDs if adequate rims are there. Other option of surgical closure is there. Most common type of ventricular septal defect is perimembranous VSDs. They account for 80% of the VSDs. They again are amenable to percutaneous device closure. And PDAs is very common. X-ray will be, echo will be diagnostic for PDA. We can see the continuous flow from aorta to the pulmonary arteries. Then this is figure showing coarctation of aorta. These are the components of tetralogy of Fallot. I have tried to cover the individual congenital heart diseases. I will skip these slides. Just to end, we should, the left to right stance, if the pulmonary circulation is very high at early stages, then there is increased pulmonary pressures, which ultimately lead to obliterative changes in the pulmonary circulation, and this ultimately results in reversal of the shunt, that is right to left shunt. In such cases, we say that it is development of Eisenmenger syndrome. So we should diagnose congenital heart diseases early so as to avoid the development of Eisenmenger syndrome, because it has a complications of coagulopathy, development of brain abscess, then hemoptysis because of the right to left shunting. So if after clinical examination and ECG and X-ray, if we come to conclusion, then we should do an echo. It is a first line investigation in patients suspected to have congenital heart disease. It is widely used in imaging for heart anatomy and for evaluation of the cardiac function. It's non-invasive and very useful tool for diagnosis of congenital heart diseases. So in summary, we should diagnose congenital heart disease well before the time or in time. It's very common. 1 in 100 newborns has congenital heart disease. Vast developments in percutaneous surgical techniques, modern anesthesia and critical care have resulted in near normal survival of congenital heart disease. After top repair, now we have data of nearly 86% event-free survival at 30 years. All we need to have the suspicion of congenital heart diseases in our mind and its diagnosis at right time. Clinical skills do matter, at least to suspect presence of congenital heart diseases. ECG and X-ray are complementary to the clinical examination. Echocardiography is gold standard to diagnose large majority of congenital heart diseases. Minority of patients may need advanced investigations like cardiac cath, CT or MRI. Thank you. Thank you for inviting me for this talk. And sorry if I have taken much time beyond my allotted time limit. So
it's okay, sir. It was a wonderful lecture. Now, before moving on to the next lecture, there is announcement for the delegates that you are requested to WhatsApp your details to the given number on the flyer. Because without that, it is not possible to credit MMC points. Sir, we will skip question answer session.
Okay.
Yes, sir. Now, I will request Dr. Ritesh Bishan, sir, for his talk on the dengue.
Thank you, madam.
Yes, sir.
Am I audible?
Yes, sir. Yes, sir. Yes.
Okay. Good afternoon, everybody. First of all, my sincere thanks to IMA President Dr. Manish Deshpande, sir, Dr. Kotkar, sir, and special thanks to Dr. Sandeep Patil, sir, for giving me the opportunity for presenting a talk on dengue, a change approach. So let's start. As we know now, under a current pandemic, most of our resources has been diverted in the management of COVID-19. One should not forget the toll of common infections such as dengue. Dengue already has its global footprint throughout the world and is a major public health concern, causing morbidity as well as mortality. So let's start my presentation with a small positive note. You are not given a problem without the power to solve it. Since the dengue appeared to the world from 1996, there are no specific drugs till now to manage dengue. There are no vaccines. Till now, we are not able to control the vector efficiently. Still, we are able to come down on the dengue mortality to less than 1%. How did this happen? This was because of guideline-based management, which was introduced by WHO. Also, special thanks to PALS as well as IAP, APLS, who are always just hammering us to follow the guideline-based management in shock and other illnesses, as well as early identification of signs and symptoms and early management that we are able to reduce the dengue mortality to less than 1%. So this is the outline of my talk. I will not go or bore you with all the flow diagrams of management of dengue. Just we will discuss about how dengue is unique compared to other infections. We will just discuss small cases and understand the management and pathophysiology of dengue. In short, I will go through some troublemaker and mimickers of dengue, especially MISC, and in short about the early predictors as well as targeted intervention in critically ill children. How dengue is unique? Dengue is the only disease where critical illness develops after the resolution. Only illness where child may remain conscious till late stages. It is also known as walking shock. Only illness which can kill an older child within 5 to 7 days of onset of fever. Dengue is the disease where pre-existing immunity leads to serious illness and mortality. And this is the disease where we practices moderation in the IV fluid management. Nowadays, septic shock, also there are newer guidelines where we practice moderation in the fluids, and where we target or we are happy with the urine output of only 0.5 or 1 ml per kg per hour. And the most important thing, this is the disease which forces us to fall at the feet of the child and begin the clinical examination. So dengue can had a very varied presentation. A child can come with you, a febrile child can come with you severe abdominal pain. Dengue can present with common co-infection like scrub typhus, rickettsia, enteric and nosocomial infection, MISC. Dengue can have acute liver failure or present like a race syndrome. Dengue, now we are seeing dengue encephalitis, deaths of encephalitis with dengue are increasing. Dengue can have AKI or nowadays HLH, secondary HLH along with dengue is on a rising trend. So how and why do I pick up a case of dengue in my busy OPD? It's very important. Most early that you diagnose the dengue in a febrile phase, you can have an approach or just predict the future course of illness and manage and monitor accordingly. So dengue most of the time is presented as an undifferentiated fever. Any fever that comes to our OPD, we just generally divide it into a dengue with focus, a fever with focus or a fever without focus, which is called as undifferentiated fever. So any undifferentiated fever, what we have to do is just observe for day 1 and day 2 and give only paracetamol, and always have a relook for localization on day 3 or day 4. Most of the fever, undifferentiated fever, produces localization in the form of cough, cold on day 3 or day 4. And just once we get a localization, you can rule out the dengue. But there are certain tropical fevers which can present like an undifferentiated fever. The common is dengue, malaria, which is less common nowadays, rickettsial sepsis, typhus. I think Maharashtra as well as South India is now an endemic area of typhus, and less uncommon is typhoid. One should always remember acute UTI as well as pneumonia in infants and toddlers also present as an undifferentiated fever. So how do you approach? See, CBC is very basic screening test. If you get a CBC, always try to do a CBC on day 3 or day 4. It's a very inexpensive test and give a lot of information. If a child with fever without focus having leukocytosis and neutrophilia, think of occult UTI and pneumonia. So, and most of these patients present with leukopenia and thrombocytopenia. So malaria, as I told, uncommon. Typhus, how will you differentiate with dengue? Typhus generally present with leukopenia and thrombocytopenia by day 5. And enteric fever generally have leukopenia and thrombocytopenia in the second week of illness. So any child who is presenting with fever of 3 or 4 days and having leukopenia, thrombocytopenia with rising hematocrit, always suspect dengue and go for confirmatory tests. One most important thing, what is pattern recognition? See, we all pediatricians are, I think, expert in pattern recognition. For a simple example is dengue. You see a child, a face of a dengue, you can identify. Similarly, day by day, as you are seeing more and more cases of dengue, one can just, by seeing the face, you can recognize. The typical dengue faces is a puffy child without running nose, without running eyes, and flushed face is a characteristic of dengue fever. Next is the child having rash. Dengue, most of the patients have rash. You can see there are 3 rashes. First picture here, this is the dengue rash in febrile phase. You can see when there is a flushing. If you put a stethoscope also, that can produce blanching on the skin. This is a typical blanching with erythroderma seen in a febrile phase. Next is a petechial rash, which is found in critical phase. This can also be elicited by a simple tourniquet test. And the last one is a typical rash of recovery phase, which is called as white islands in a Red Sea. This is a typical of dengue recovery phase. So whenever a child with high fever without focus in an epidemic situation with flushed palms and sole, body aches, hepatomegaly, ensure you are dealing with a dengue. Always search for an alternate differential diagnosis. Instruct the parent for warning signs. If child is not having the warning signs, always look for warning sign. Most important thing is paracetamol in right dose. WHO has recommended paracetamol not to be given more than 15 mg per kg, not more than 6 hourly. Avoid NSAIDs. And the second area where ORS after diarrhea, ORS being used is dengue. Always motivate the patient to have oral liquids in the form ORS or in the form of ORS or other liquid types. So, see, dengue typically is a disease of timetable. It has 3 phases. Always remember first 72 hours, second 72 hours, and last 72 hours. So these are the important phases. These can be changes depending on the patient. But what I mean to say is most of the patient start with the febrile phase and directly go to recovery phase without manifesting as a critical phase. These are non-severe dengue. But what role of pediatrician during OPD is we have to pick up these 2 cases because some of the cases have some warning signs and they will directly recover. But only 1% cases are there which present as a severe dengue and which is the area of our concern so that we can manage efficiently and reduce the mortality. So how to recognize dengue shock early? See, clinically, a cardiogenic shock, a septic shock or diarrhea with severe dehydration can be picked up very early. But dengue shock is a very silent disease. See, many older children are walkable. It's also called as walking shock. You can see before the crash also the child is quite alert and walking and it can be very dangerous. So always make a habit to touch and assess the peripheral perfusion. Only trained humans can perform this vital function. No machine can do it. It takes less than a minute to assess these 5 parameters. Always check for pulse volume. Always check for pulse rate, capillary refill time, color, temperature of extremities, respiratory rate, and the CNS examination. So this is very important and basic clinical examination so that we can pick up many patients. So I am showing a child with compensated shock seen in our OPD. This was the girl. She came to us only with one complaint, excessive sleepiness. She was febrile. When we examined her, she was tachycardic. Heart rate was 150. The peripheral perfusion was poor. Pulses were low volume. There was ecchymotic patch. Mother was not saying anything. Then when we digged out the history, we found that she had one episode of melena also. You can see in this video, she's arousable. If we just, she's responding to verbal stimuli, also to tactile stimuli. So what I want to say, you have to pick up these cases early so that it can be managed properly. Second most important thing one should ask whenever assessing a dengue patient is urine output. It's also known as poor man's CV. See, whenever the urine output is more than 1 ml per kg per hour, or if mother says that she is passing adequately like daily, you can just rule out shock, provided there is no hyperglycemia or you have not given any diuretics. So always identify dengue in OPD, treat dengue without warning signs as a OPD patient, keep monitoring, explain them the warning signs. If you find warning sign, admit the patient, start treatment of warning signs. If patient failed to respond in few hours, I will suggest refer early to a center where there is a PICU facility. Ensure a safe transport. Late and unsafe referral has increased the mortality in many diseases. So let's start with some clinical case scenarios. These were two children. 4 years of age, which were brought to the OPD with history of 3 days of fever. They landed in the OPD on day 3. Both were advised CBC. The case 1 was having HB of 11, PCV 33, total count was 4,000 and platelet was 20. This child was admitted. Other child was having hemoglobin of 39, PCV of 39, total count were normal, platelet was slightly on lower side. So this was actually the pediatrician went for a section call. This report was seen by an RMO and patient was sent back to home. What happened? Next day, the second case was brought in shock. So where did we go wrong? Could we have predicted the progression? What does a CBC in first 3 days really mean? And what to look in a CBC? To see any child presenting with fever on day 3 and day 6, there are two most important things. First, febrile phase can progress, you can have a febrile phase till day 6 of the fever in a dengue child. Secondly, one has to differentiate whenever you are seeing a child on day 3 or day 6, you always differentiate whether the child is in a capillary leaking phase or not. That can be just, we can just divide the child into a child with a warning sign or without one. The warning sign is one of the indication of critical phase. So what we have to do, we have to pick up just this 10 or 1% of cases, because as I told, 90% of cases are asymptomatic or directly go to recovery phase. Our focus should be on this 1% of cases. So how to know that child is in leaky phase or started leaking? So most important thing, as we all know, dengue, it's like what we heard in COVID, it's like a cytokine storm, and cytokine induced, virus induced, or antibody dependent enhancement induced and capillary endothelial damage, which is causing leak of fluid as well as protein from intravascular space to interstitium. So how do we pick up? So see, whenever child is day in 3, we always look for warning signs. Why this warning sign has been made? Each and every warning sign is an indication of capillary leak as well as hypoperfusion. Why there is abdominal pain? It's because of splanchnic hypoperfusion. The fluid accumulation in the whenever there is a capillary leak, there is a fluid accumulation in the form of ascites and pleural effusion. Ascites itself can produce a dragging pain in the abdomen in the epigastrium region. Persisting vomiting is one of the reason behind persistent vomiting is capillary leak in the brain as well as hepatitis. Cerebral hypoperfusion manifests as lethargy and restlessness, and you will get a hepatomegaly in most of the each and every patient of dengue with warning sign. The reason is hepatitis, or maybe liver may be pushed down because of pleural effusion. These all clinical parameters should be interpreted along with progressive increase in hematocrit. So understanding this case, back to this case, the child was 4 years with hemoglobin of 13, which is very unusual in an Indian scenario, that from a child from a rural area. So always have a clinical correlation of PCV with your clinical symptoms. If there are reports CBC done previously to the child, always look for trend of the hematocrit. What about platelet count? Can platelet count in isolation give you an idea of capillary leak? No, platelet count never, falling platelet count never give an idea of capillary leak. But the most important thing is, whenever the thrombocytopenia is progressive, one must always think that the disease is progressing, and any time child can go into leaking phase. If you have a child who's there is no warning signs, but there is progressive thrombocytopenia, always try to watch and monitor that child for warning signs or other symptoms of severe dengue. So this is in short about what is the lab evidence of capillary leak. We all know any rise on PCV, here it is 20%, but I will suggest more than 5% or 10%, you should be alert. albumin can be low, cholesterol can be low, chest X-ray just to rule out effusion. And most important finding we all see is gallbladder wall edema and effusion on point of care sonography. So going to next case, this is a child with 6 years old with fever of 5 days. He is lethargic, having persistent vomiting. The urine output is low. The extremities are cold. He is tachycardic. His BP is 86/64. See, what does this suggest? This child is having tachycardia with compensated of BP. His BP is maintained, trying to what is happening in the hemodynamics. Because of tachycardia and as well as vasoconstriction, BP is being maintained. So if you are sitting in a periphery and if you get this type of case, I would want to ask whether will you refer this child directly to a other center, or would you like to manage? So for that, I want to explain this child. Imagine if we just saw this child and we immediately referred this child, and if we think if the next center is around 1 to 2 hours away from your center, your taluka place, what will happen? This child will be having tachycardia. The next 1 to 2 hours there will be leaking through the capillaries, and this will lead to further exaggerate hypoperfusion, and one of the important factor for organ damage, organ dysfunction. But if the capillary leak progresses continuously, there will be endothelial damage, which this endothelial damage act as a nidus for microthrombi formation. And this hypovolumia, intravascular hypovolumia, as well as microthrombia, ultimately leads to end organ damage with multi-organ failure and death. You may refer this child, might that child be reach the tertiary center after 1 to 2 hours alive. But what will happen? The outcome what we will get, we will not be happy about that outcome. So what I suggest is, whenever you see a child with warning signs, always give IV fluid 6 ml per kg with fluid and refer the child with fluid on flow. And always have a look at blood glucose, because many childs the intake is poor in the critical phase and they can have hypoglycemia, which can further exaggerate or shock. And whenever you find a child with a compensated shock with narrow pulse pressure, always start 10 ml per kg of on-flow IV fluid and start him on oxygen by non-breathing mask, and then only refer the child. So going to a next case, this was a 10-year-old child, obese child, who presented on day 4 with fever, with cold extremities, abdominal pain, petty chest, some gum bleeds. He was in hypotension. The single practicing pediatrician immediately identified him as a dengue shock syndrome. He arranged an ambulance and he referred that patient. It took around 2 hours to reach the hospital. On admission, his extremities were cold. There were no palpable pulse. BP was unrecordable. Immediately 2 IV lines were secured. He was started on non-breathing mask, oxygen, 100% oxygen. His baseline investigation was sent. He was bolus on flow, but the child ultimately worsened, and we intubated the child and connected to the ventilator. But what happened? He immediately started bleeding, and bleeding was so profuse. From every orifices there was bleeding. We have to change the suction bottle twice. So when we analyze his reports, his investigation suggestive of HB of 12, his total count was 16,700 with PCV of 16. What does this total count indicate? See, I want to focus here that any bleeding child in dengue will have a higher total count. There was a study, retrospective study done in a center, which showed 20% only death. Dengue children died due to bleeding. Only 20% children have leukopenia, and most of the patients were having leukocytosis. So leukocytosis in a critical phase, we are treating the child. So always predict a critical illness. Second thing, his platelet count was 86,000 and S1 was positive. So we all know that 86,000 of platelet count will not lead to bleeding. But then what was the cause of the bleeding in this child? So when we analyze his ABG his pH was only 6.9 and bicarbonate was 6. So there was mild transaminitis and there was mild coagulopathy. So why does the dengue child bleed? The most important cause of bleeding in a dengue child is an uncorrected shock. So one has to treat shock as early as identify and treat the shock as early as possible. Other factors which lead to bleeding in dengue child are, second most common is DIC. Other add-on factors are liver dysfunction, severe thrombocytopenia, and also heparin-like substances which are released from the endothelium. This was the study done in South India about the why the child were they also did the study what was the common in a severe bleeding dengue child. They found that median platelet count was 68,000. All presented with profound shock, and none of them received pre-referral IV fluid. So what I say this, and they have found that it is probably a preventable cause. We can proper management, we can prevent severe bleeds in dengue. So how can we do this? We can do this by early identification, as I told, early identification of shock, fluid resuscitation before and during transport of the child. And the most important thing is do not use push-pull method to deliver fluid in profound shock. So already there is a severe capillary fragility, and they have found that if you start using push-pull technique, these children bleed very faster compared to the children who are given on-flow fluid boluses. So the most important thing is whenever you are managing in a critical early recognition and treatment of hemorrhage is very important, and along with that you should priorities of management in critical phase should be early recognition and treatment of hemorrhage and prevention of fluid overload. So what we are doing is actually whenever we are managing a child with dengue, severe dengue, we are walking on a tight rope. At the same time, we have to balance. We have to early recognize and start fluid management for the reversal shock, and at the same time we have to avoid fluid overload and consequent need of ventilation. So how can this be achieved? The solution for this is a aim for a minimal acceptable circulating volume and have these targets. These targets are somewhat different from septic shock management. In the dengue, always have a systolic BP. We will be happy with the systolic BP of 5th percentile. Have a pulse pressure of up to 30 mm of mercury or more. Target your urine output, or be happy with the urine output of 0.5 to 1 ml per kg per hour, and along with gradual reduction in elevated hemoglobin. So these are the common errors. Don't chase the BP when other parameters are maintained. Don't chase the urine output more than 1 ml per kg per hour. And whenever during management you find a urine output of more than 1 ml per kg per hour, just stop IV fluids and monitor the child. So these are the challenges in a resource limited settings where there is a poor primary care, late referrals, and intensive care facilities are unavailable. The most important thing is getting the fluid just right. So if we follow this simple, inexpensive intervention, successful outcomes with mortality of less than 10% can be achieved, provided we are early, appropriate, and commensurate with the disease process. We are using our highest level of clinical judgment, and we are using meticulous continuous monitoring with simple investigations. Next this is always a hard topic of debate, crystalloid and versus colloids. There are different studies that have been done, but the bottom line is crystalloids are equally effective and adequate for most children. NS versus RL, NS is a preferred choice of fluid. RL we can use, but should be avoided when you are suspecting a liver failure, because it can produce lactic acidosis. Colloids, yes, we should use in severe dengue or fluid refractory shock where NS is not responding, but it should be individualized according to your experience. So what we are doing in the management, we are monitoring the hematocrit, hemodynamics, and just deciding about the fluids. So whenever there is a high hematocrit, unstable hemodynamics, increase the fluids. If hematocrit is high or normal, or there are stable, your patient's hemodynamics are stable, just titrate the fluid and monitor. But if there is a falling hematocrit with an unstable hemodynamics, always think of bleeding, occult bleeding, and go for blood transfusion and other component therapies. And whenever you find a child with normal hematocrit or falling hematocrit with a stable hemodynamics, just stop IV fluids. So in a refractory shock, always look for ABCs, use non-rebreathing mask oxygen so that it provides 100% of oxygen. As I told, NSRL colloids can be used. If hypotension persists, go for blood transfusion. Consider inotropes or pressure based on systolic BP, your clinical response, and serial echo. See, the choice of inotrope in dengue is mostly what is recommended is a low dose epinephrine. And if still the BP is low, and if you find that you can go for a noradrenaline infusion, but most of the children respond with low dose epinephrine. Consider early nasal CPAP or high, if you have a high flow nasal cannula or ventilation when indicated. CVP, if needed, and if expertise available, go for that. Most important thing is intra-abdominal pressure monitoring if available, or if it's increasing, go for a cautious ascitic tap. So this is the checklist when you are dealing with a refractory shock. Always look for uncorrected hypovolemia. As I told, look for abdominal compartment syndrome. Look for whether you are using very high pressures. If you have a facility of echo, always rule out myocardial dysfunction. Always rule out coexisting bacterial septic shock or malaria. Or you might be dealing with a widespread hypoxemic ischemic injury with terminal vasoplegic shock with multi-organ failure. So coming, you have managed everything, you have ventilated the child, started inotropes, given transfusion. Next question arises, what is the role of steroids in dengue? See, for prevention of shock or in routine treatment of dengue, there is no role of steroids. It has been proved by, there is evidence. But what, according, if as we are following PALS guideline, any child with a refractory, fluid refractory shock, and with the background of adrenal insufficiency, we can use stress dose of steroid. It is in that protocol. We can go for a stress dose of hydrocort in any child with refractory fluid refractory shock. Next, platelet transfusion. There are few RCTs, one from Pakistan. There is prophylactic platelet did not prevent severe bleeding, and there were significant side effects. This is another study where they have prophylactically used plasma, platelets, and some other therapeutic intervention in this form of anti-globulin, D-globulin, immunoglobulin, interleukin 11, activated factor 7. So there is no any strong evidence or benefit after using. Tranexamic, still some higher centers are using tranexamic acid infusion. Though there are no trials, but with the benefit of doubt, many centers try for tranexamic acid infusion in case of refractory bleeding. So going to a next short case, this was a 3-year-old child on day 1 with high fever seen in OPD. Day 2 fever persistent, CBC was normal, parents were quite worried, so the child was admitted. IV fluids were started in the form of isolate P, the full maintenance of 100 ml per kg. On day 3 evening, fever persisted, child had 2 episodes of vomiting, IV fluid continued, his NS1 came positive. Immediately within a few hours, the child went in hypotensive shock, resuscitated with 2 boluses of 20 ml per kg and referred to with BP of 90 by 70. This was managed. He was in leaky phase with compensated shock. Maintenance IV fluid were given. His urine output was 0.8 ml per kg per hour. Started on non-rebreathing mask, monitored and titrated IV fluid. Next 48 hours, child was stable with stable hemodynamics, urine output between 0.5 to 1 ml per kg per hour. But suddenly after 48 hours, this child developed respiratory distress with falling saturation. This was his X-ray. What we did, just see, if you see the timetable, this child was in last 72 hours and he was hemodynamics were stable. If you see the history, the child received hypotonic fluids, plus we have given 220 ml boluses, and in the recovery phase, suddenly this child developed respiratory distress with this kind of X-ray. We started him on furosemide infusion and high flow nasal cannula, and the respiratory distress settled in next 12 hours. So what I want to mean to say that we will not reach the shore just because we started early. Though we admitted them on day 2 of the illness, given him IV fluid, dengue complication cannot be prevented preemptively by putting the child on fluids. I meant to say IV fluids. See what happens. It's in any case of dengue, it's like life is a boomerang. What you get, you get it. Same thing. Whatever fluid you are giving in dengue, that fluid will be hit back to you in the critical phase in the form of bloating edematous child or it will hit back to you in a recovery or resorptive phase in the form of pulmonary edema or respiratory distress. So in a dengue in a febrile phase, always encourage oral fluids. If you want to use IV fluid, use judiciously. What are the recommendations? It should be used just 1.5 ml per kg per hour, or depending upon the assessment of your dehydration. Always, as I told, target the urine output of less than 1 ml per kg per hour with stable, vital stable. One most important thing is do not use hypotonic fluids. I think it's out of the pediatric hospital nowadays. Always avoid. There are a lot of studies showing mortality has been increased when you use IV hypotonic fluids in any hospitalized child. So what I want to say, if this diagram, just if you have a child with hypotensive shock, if you gave 20 ml per kg, if you see a response, just de-escalate, go down to 10 ml per kg. If you are treating a child with compensated shock, and if the child respond in one bolus, just come down to 6 ml per kg. And as if the child is having maintenance stable vitals, just come down to with urine output of 0.5 or 1 ml per kg hour, just come down to 3 ml per kg and 1.5 ml per kg according to your monitoring data. So let's in short about the expanded dengue syndrome. As I told, dengue can have variable presentation. Every system of the body can get involved. Not going in detail. Just I want to show you the myocarditis is one of the common manifestation of dengue. It can present with shock, or child can have arrhythmias or left ventricular dysfunction. It can be easily diagnosed by if you have an echo done early. AKI, this was the study in Indian study where they have found 20% of children with severe dengue had AKI. So what were the risk factors? Colloid infusion, inotropic support, ventilatory requirement, presence of secondary HLH were the risk factors for AKI. So whenever you have a suspicion, oliguria, anuria, just if the hemodynamics are stable, always give a trial of furosemide infusion. No consensus guidelines for timing or biochemical cutoff for initiation of RRT, renal replacement therapy. But in children, always consider PD in a small children. If the hemodynamic is unstable, you can go for CRRT SLED. Dengue can present with acute liver failure. It's very common. Degree of elevation of transaminases never correlates with severity of illness. These are the study where we have to manage liver failure with what we manage in other viral illnesses. But one thing is that they are not found N-acetylcysteine useful in dengue virus induced acute liver failure. But still we are using, many centers are using, because large randomized control trial are still awaited to confirm the efficacy of N-acetylcysteine in liver failure. Next common presentation of dengue we see is dengue with seizures or status epilepticus. Mostly the patient present with dengue with febrile seizures with posturing. Tonic posturing is very common when the patient presents with status epilepticus. So first thing is the febrile seizure with status. Second, the main thing I want to focus here is cerebral hypoperfusion because of this hypotension can also present in a child with tonic posturing. So this is also an important. And third and most dangerous is dengue encephalitis, which is having a highest mortality. So whenever you find a child with dengue encephalitis, encephalopathy, monitor vitals. If he is hypotensive, go for fluid resuscitation. Immediately control the seizures with appropriate anti-epileptics. As I told, avoid hypotonic fluids. If you have lower level of also suspicion of raised ICP, don't hesitate to go for 3% saline. Always secure airway. Any child with depressed airway, as you know, hypercarbia is very dangerous for neurological outcome. So one should always go for securing airway if you find any respiratory depression. This was a study from South India. They just retrospectively analyzed the encephalitis death. See, 31% children were not having warming signs. The median platelet count was 68,800. Not an even single patient they found of a child with CNS bleed with coning in dengue. all patients had seizures or posturing. 86% of patients were comatose within 4 hours, and 57% developed diabetes insipidus. What it indicates that our urinary output monitoring will not be workful in this kind of patient. So always be early in the management of encephalitis. In short, most of the things I have covered already. These are the 10 targeted.
Sorry to interrupt here.
Yes.
How much time is left?
5 minutes.
Okay, please continue.
So these were the targeted intervention that improved the outcomes in severe dengue. As most of the thing I have already told to you. Just I want to emphasize that respiratory support, always try for non-invasive ventilation first, and then if indicated, then only intubate the child. Always be smart about invasive lines and tube, because there is big risk of bleeding and hemorrhage. Whenever you feel it is very essential, then only go for it. As I told, there is a dengue severe dengue child, there is a very high risk of peri-intubation arrest. And it is really a nightmare for any pediatrician to intubate a dengue child. What I want to emphasize here is just selectively select drugs, use minimal possible dose of sedation, and if possible, try to use anotropes earlier before the intubation and resuscitate the child, intubation of the child. So last, what are the causes of a fever on a day 8 in a child with severe dengue who is apparently recovering? See, this is a common scenario nowadays we are getting. Okay, a child who is recovering from dengue and suddenly have high grade fever, he has a hepatomegaly or splenomegaly develops with cytopenias. So these are the common causes. One of the most common is secondary HLH. Nosocomial infection should be ruled out. Suspect co-infections like rickettsial enteric malaria, and one should always think of simple thrombophlebitis in a child who is recovering and having fever. So as I told, always think of HLH is very common and treatable, and can be, if not identified early, can be very dangerous. So dengue is the most common cause of secondary HLH in children. Just in short about hyperferritinemia, it's also one of the, because recently a lot of research is going on increasing ferritin level. So as I told, high ferritin is expected. It's an acute phase marker. It is a biomarker of cellular damage as well as uncontrolled inflammation. But any child who is in a recovery phase with having persistent or recurrent fever with cytopenias, with multi-organ dysfunction, with high ferritin, one should consider for giving steroid and IVG in the management of HLH. Last slide, just I'm finishing it. See, one of the last epidemic in July, August, we were just lot of cases were there with severe dengue and MIC post-COVID. So there are very common overlapping signs and symptoms, very biochemical similarities. And if you get a child with dengue positive IgM with persistent fever, one should always think of COVID-19 or MIC. So what things suggest MIC? Oral and mucosal findings, rising very high CRP, anemia, and also coronary abnormalities, very specific of MIC, and one should not hesitate doing echo and evaluate coronaries. So in short, about what are the early predictors, how we can, this was the study. Any severe disease at presentation, high lactate admission, need of multiple vasoactive drug, and positive fluid balance were early predictors of mortality in children with severe dengue. So the take-home message is dengue is very deadly if not identified early or treated early and appropriately. Remember the close mimics, as I tell, scrub, typhus, MIC. Analyze, treat in the backdrop of pathogenesis and clinical course. Identify and refer if the facility is not available. All the high-risk children, especially infants, obese, immunodeficient, or diabetes. Watch out for the signs of capillary leak. Always make a habit all admitted patients to categorize as dengue without warning sign, with warning sign, or severe dengue. Any patient with warning sign or severe dengue should be resuscitated before transfer. In February phase, encourage electrolyte-rich oral fluid. Outcome depends upon how you titrate fluids with meticulous monitoring of hematocrit and urine output. Prophylactic transfusion have no role. Always remember do's and don'ts. And the most important thing is overdoing in a dengue can kill the patient. Thank you.
Thank you, Ritesh. It was a very good, crystal clear presentation about dengue. Being we are short of time, we will not take question and answers. We'll move on to our next speaker, who is Dr. Chetan Videkar. He is ophthalmologist, and he has done fellowship in vitreoretinal surgery. Basically, he takes care of our babies who are preterm and who needs ROP screening and laser. So after Chetan got trained in LV Prasad Institute, he helped Nanded people as well as surrounding many districts as Hingoli, Kusad, and multiple other districts. He helped in such a way that previously when we started practice in Nanded, we used to send the patients to higher centers for laser as well as vitreoretinal surgeries. Being a pediatric ophthalmologist as well as vitreoretinal surgeon, as Chetan had come, we could tide over that situation. Over to you, Chetan. You can share your screen, please. You are visible now. You share your screen.
Sir, I think Dr. Ritesh sir have to stop the sharing first.
Ritesh, you stop sharing the screen. Your screen. Piyush, you can do that.
Yes, sir.
Yeah.
Is it visible, sir?
Yeah. It's visible now. You can go ahead.
Thank you, Sandeep sir, for such a kind introduction. And thank you all the esteemed panelists for giving me the opportunity for sharing my experience of ROP with you all. And thank you all of the speakers for taking time from your precious Sunday to listen to such an excellent talks. I am going to talk today about retinopathy of prematurity, which is a needless, preventable, lifelong blinding disease of newborn. Actually, this photo is little old, but I took it because of two reasons. Number one, the baby is very cute, but more importantly, the message is very important. The message says that ROP is the single largest cause of needless blindness in pediatric population. So all of us are dealing with so many young neonates in our clinics day in, day out. We see their oxygen levels, we check their temperature is normal or not, we check whether their pulse is normal or not. But what about eyesight? So why we have to bother about ROP? Most importantly, because there is no disease at birth. This is sort of an iatrogenic disease, and the child will become blind before 6 months of age. The incidence of blindness is as high as 4 to 18% in some studies. And the other children who do not become blind, if they get affected, they have severe and progressive visual impairment. And the child remains blind for his entire life, and he is a burden for society and family. So all this then, when there is an effective and safe prophylactic treatment is easily available. So according to the current studies, we all know that ROP is related to prematurity as well as it is related to low birth weight. Now, very easily, screening and treatment can be done in the NICU itself. But if we miss it, and if the disease progresses to worse stages, even with the surgery, advanced ROP has very poor outcomes. So with this, I will take you all through my talk, and these are the highlights of my talk. We will go through epidemiology, a very brief pathogenesis, mainly stages and zones, how to describe the disease, then most important part of screening and management. So coming to ROP, it was first described as early as 1940s. A researcher called Terry found out that so many babies suddenly started becoming blind. And he saw that there was fibrotic retinal detachment behind their natural lenses. It happened because at that time, suddenly oxygen was being used more commonly for serious babies. And then Terry related that phenomenon to premature birth. And the term ROP was coined by Heath et al. So basically, it is a vasoproliferative disease of retina, which is seen in preterm neonates. And as we have seen, it is the leading cause of potentially avoidable childhood blindness. This is a progressive dynamic disease. It is a very time-bound disease, and it is a predictable disease. And as we have discussed, it is not present at birth. So if I want to tell you a situation in 2010, which you all may be knowing better than me, if we estimate a survival rate of around 30% of preterm babies, at that time, around 16,000 neonates in a year would have developed ROP, and around 3,000 of them would have gone blind. Just divided by a year, it becomes around 10 babies per day. So because of that, what happened is Ministry of Health took over and they started taking strengthening efforts to reduce the neonatal mortality rate. And it was a part of their Millennium Development Goals and Sustainable Development Goals. And as a result, there was improved survival of premature babies. But not only this, there was also increased number of babies at risk of blindness from ROP. So if we see the epidemiology of the disease, worldwide incidence in the literature of prematurity or preterm babies is said to be around 10%. However, in Western countries, the incidence of other stages of ROP as well as severe stages of ROP is quite variable, as we can see the figures in the brown color. It ranges from 10 to 15 to 30 to 35%. This is mainly because of the differences in criteria of screening. Some people screen at 26 weeks, some at 30 weeks, some at 34 weeks. Some people screen at 1.5 kg, some people screen at 2 kg. But it is an important figure. It is a very big figure. When we come to India, as we have seen, the incidence of ROP is rising because of improved neonatal survival. And out of 26 annual live births in India, 26 million, around 2 million are less than 2 kgs. And they are at the risk of developing ROP. So the disease of ROP has an incidence between huge 40 to 52% in India. About 5 to 10% of them are having vision-threatening ROP, which can go blind. This is a very important study which was done in L.V. Prasad Eye Institute. It was an Indian Twin City ROP study in 1998. So they also demonstrated the same thing. If you see these graphs, the premature deaths are coming down and the births are rising at around 1998 or 1999. And see what happens to ROP. From 1997, 1998, there is a boom in the incidence. Before that, it was very less. The pathogenesis of the disease is very simple and interesting. See, inside the mother's womb, everything is fine. Normal vascular growth of the retina is going on. When the baby delivers prematurely, these important chemical growth factors and nutrients like IGF, VEGF, and erythropoietin and PUFAs, which are freely available in the feto-maternal interface, they become stopped. They are no more available. And at that same time comes oxygen, because the babies have to survive. So because of these two things, the vessel growth stops because of hyperoxia, because of decreased VEGF, which is vascular endothelial growth factor, which is the stimulating molecule for the growth of the vessels. It goes down because of the decrease in source from mother's blood as well as excess of the oxygen. So we have seen that the blood vessels are not growing as they should grow. To add to this is increased metabolism of the retinal tissue because baby is growing. So there is resultant hypoxia. Now, because of this hypoxia, what happens is, again, the VEGF starts rising now. The vascular endothelial growth factors starts rising inside the eye. And because of that, new vessels are formed, which is called retinal neovascularization. And these new vessels are abnormal and they lead to all the complications of ROP. So now how to treat this? There are two options. Either you correct the deformity, supplement the things which are missing like IGF and etc. Or you control the O2 exposure. Use it very judiciously to prevent the decrease of VEGF. Other option is you correct what is going wrong. You decrease the VEGF by the treatment like laser and injection. So this was the pathogenesis. Now I will show you how the disease appears to us. because for understanding any disease, we have to describe it. The disease is classified into stages and zones. It is we have seen that it is a very dynamic and predictable disease. So why do we have to classify the disease? Because we have to note down the documentation so as to judge the progression of the disease. And we have to plan when to plan the next follow-up, and we have to decide when to do the intervention. For that, it is important to understand the classification of the disease. See, this is a very stark difference in the photograph of an adult retina versus photograph of a newborn retina. The vessels are very thin, the shade is very hypopigmented. So now, because you will be seeing many pictures of the newborn retina now. Now, there was a group which met in 1984 and they formulated an international classification of ROP so as to get uniformity in the documentation of ROP babies overall world. They described the disease according to the area of the retina involved. So they described the disease according to the location of the disease in relation with the optic disc. Here you can see the pictorial representation of both the retinas. The central circle is optic disc, and there are different zones, zone 1 to zone 3, which I will describe later. The second thing they described was extent in the clock hour. Extent means circumferential extent, how many clock hours were involved. Then they described severity of the disease. There are different signs of the disease, which I will describe later. And very important part was described, which was a plus disease. So I will tell you what is a zone now. This is a picture of the retina described divided into 3 zones. We all know that the central retina is the most important part of the vision. So that was named as zone 1. It is the important zone. Zone 2 was little less important. So it was middle zone, and zone 3 was the last one. So look what nature does. When the baby is growing inside the mother's womb, the first zone to form is zone 2. That's zone 1. Next, the vessels grow into zone 2, and then they go into zone 3. So zone 1 is more important. Any disease in zone 1 is more serious and more harmful. Disease in zone 3 is less harmful and less likely to damage vision. Now, you have to remember that the disease can be there in different areas in different zones. Here it can be in zone 1, here it can be in zone 3. So while describing the disease or while writing the diagnosis, we have to write which is the severe most zone, that is posterior most zone or innermost zone. So zone 1 will be the part of the diagnosis, even if the disease has gone into zone 3 in some areas. Now, this is a three-dimensional picture of the same thing. The posterior or innermost is zone 1, middle is zone 2, and the next is zone 3. Now coming to extent of the clock hours, why this is important? Because the disease may be contiguous or non-contiguous. So we have to document that also. So when you are seeing our reports, if you are aware of these things, then you will understand better what is the disease severity. So this picture you can see that the retina has grown up to a certain extent and it is not grown beyond this. So if we compare it to a clock, we can easily say that the disease is there from 4 o'clock to 8 o'clock. So we will write that the ROP disease in this baby is in 4 clock hours, 4 o'clock to 8 o'clock. Now coming to the most important part, that is stages. There are 5 stages, and staging also we have to describe correctly. The most severe stage of the retinal area we have to mention in the diagnosis. Now staging also we have to write by clock hours because different areas can have different stages. I will show you some pictures also. Now this is a most common finding which we see while screening the ROP babies is immature retina. Basically immature retina means there is no ROP. There is no sign of ROP, there is no stage of ROP. The blood vessels are growing and there is just a junction of vascular and avascular retina. At different blood vessels are ending at different levels. You will understand this better when you will compare this immature retina with the first stage of ROP. This is the beginning. There is presence of a line. You see a line in the retinal picture that separates vascular and avascular retina. It is a flat line. The line is in the plane of the retina. See, here you can see that vessels are ending at a specific level. So we can see a line. So this is first stage of the ROP, first sign of the ROP. If we will just enlarge, you can see that the branching is abnormal. Here the branching is dichotomous. Here the branching is very close. We call this as palisading. So this is first stage. Here also you can see that line is formed. In this right diagram also you can see here a wedge-shaped line is there. Here also you can see that there is a line in temporal area or the lateral area. Now, when the disease worsens, it goes into the next stage, that is ridge. Ridge, as we understand from its name, has width, height. It is basically thicker than a line. It has a volume. So it's a three-dimensional thing, and it extends out of the plane of the retina and it forms a ridge. Here you can see that line has become thick now. It has width also, it has height also. So when we examine the babies, we can appreciate it three-dimensionally that it is bigger than a line. So now it is stage 2. It is a more worse stage.
Chetan sir, you have to log in again. Chetan sir, you are not audible as well as visible. You have to log in again. Piyush, can you help him?
Sir, he is not online.
Okay. Should I call him?
Yes, please ask him what happened.
Dr. Chetan is apparently on a visit in a rural area, apparently.
Yeah.
And because of that, I think there might be some problem in the reception. We'll just check in 2 minutes.
Yeah, just I'm calling him.
Sandeep. Hello, Sandeep.
Hi, sir.
I think we can move on to the next lecture if the speaker is online. Chetan, he can finish later because we are already running quite late.
Yeah, just for 30 seconds we'll wait. Vishal sir, can you, are you on online, sir?
Yes, I am.
Vishal sir, can you take over, please?
Yeah, we can.
Just for 30 seconds we'll wait.
Sure.
If he is able to join, it's okay. After that, we'll start.
No issue. Yeah.
The technical errors make a problem. He is on a visit actually. It was since last 3 weeks he could not visit. That's why he has to go there, and in between he was doing the presentation. Chetan, can you hear? Chetan sir, unmute.
He had joined back.
Yeah.
Can I start, sir?
Yeah, please. We are short of time. You have to run fast. Huh?
Yes, sir. Yes. Yeah, I'm very sorry for the network disconnection. So I was telling you that this stage 3 is proliferation of fibrotic and vascular lesions of the retina. Here you can see this is the ridge and this is the fibrotic proliferation. Here also you can see that this is a fibrotic proliferation. These photographs show it. Now coming to more worse areas, there is a retinal detachment which can happen if the disease is not treated. 4A stage will have peripheral retinal detachment, which is not involving the central macula, and 4B will involve the central macula, which has a poorer prognosis. Here you can see that the area which is detached in the periphery, here it is involving the retina which is up to the optic disc. So these up to 4A we can salvage the vision. From 4B it is very difficult to save the vision. Next slide is actually not a very good slide to see. I hope that I never have to see such thing in my life. This is the total retinal detachment. You can see that behind the lens, there is retinal vasculature can be seen. This is called retrolental fibroplasia. Here also you can appreciate it. Now, I will very briefly take you through treatable and observable forms of ROP. Any threshold is the threshold to treat. So if you have 5 clock hours, means half of the retinal surface, severe stages like stage 3, important zones like zone 1, we have to treat it urgently because retinal detachment can occur in 50% of the patients. Other things which are pre-threshold can be observed. Here we can see that it's a plus disease. It is in the zone 2. There is ridge. So this is a threshold disease. So we have to treat it. Now, what is a plus disease? Here you can see the retinal vessels are normal, dichotomously branching and straight vessels. But if you compare with this, the vessels are tortuous, the veins are engorged. So this happens because of excessive VEGF, which keeps on accumulating due to the pathogenesis that we discussed. Compare with the normal routine ROP, plus this disease is a very aggressive form. See, when the veins are dilated and enlarged and arterioles are tortuous. So this is the definition of the plus disease. There are some other features which we see. The pupil does not dilate even after putting the drops. There are dilated and engorged iris vessels which we can see. Media is hazy and there are hemorrhages in the retina. Now, this is the most dangerous form of the ROP, aggressive posterior ROP. Posterior means it is in the central or inner areas and in the most important visually areas. We have to be aware because they are different from the normal stage-wise ROP because of their appearance, because their progression, their speed, and the treatment is different. Now, there are no particular stages in this. There is only dilatation and tortuosity, but it is in the central area, zone 1, zone 2. Very rapidly, between 2 to 3 weeks, it will directly go to retinal detachment. It will not go to stage 1, 2, 3, 4. So, these are some more pictures of APROP. So, if we do not treat it properly, directly the baby will come with stage 5 retinal detachment. So we have to screen these babies earlier within 20 days, treat them aggressively, treat the systemic comorbidities and keep them under close follow for recurrences. Basically, we have to run with the disease if we want to catch the disease. See, if we treat it in time, like in this baby, the baby worsened and the baby went into APROP, but if the laser was done, the tortuosity and dilatation disappeared and the retina was a normal and healthy retina after the laser treatment. Now, coming to the most important part, the ROP screening. We have to discuss whom to screen, when to screen, who should screen, where to screen, and how to screen. So, this is the recent most National Neonatology Forum guidelines of India released in January 2020. These were released by a few of the eminent people who are working in the field of ROP. Now the guidelines say that we have to screen which babies, whom to screen. The babies who are born less than 34 weeks or below 2000 grams. They have to be screened. Now other babies which are born after 34 weeks, if they have stormy neonatal course or other risk factors like respiratory support, O2 more than 6 hours, sepsis, apneas, blood transfusions, or any other unstable clinical course as will be determined by you people. Even if there is no record available, if the parents only say that the baby was admitted in NICU or SNCU, it can also be taken as a surrogate risk factor and the baby will have to be screened. That is also enough. Now, when to screen? Screening has to be done before 4 weeks of postnatal age. But if the baby is extremely low birth weight or more preterm, that is born less than 28 weeks or less than 1200 grams, then the screening has to be preponed to 2 to 3 weeks. So it is not a bad idea to screen all the babies at around 3 weeks or 20 to 22 days, so as we should not miss even the other extremely low birth weight or more preterm babies. Who should screen? Any medical professional with any formal exposure or training to examine the retina of a newborn baby by our indirect ophthalmoscopy instrument, he can screen. It is not required that he has to be a retina surgeon or he has to be even an ophthalmologist. Even non-ophthalmic people also are screening. Like nowadays, telescreening is keeping a lot of areas covered. Optometrists or ophthalmic technicians are taking a fundus camera and they are going in remote areas where medical professional cannot go himself. They are taking the photographs, and telescreening is done by an ophthalmologist who is sitting inside his office. Where to screen? If the baby is admitted in NICU, it is always better to screen in NICU itself, because when the baby is gone from NICU, nobody can assure that the baby will come for screening again. Already if the baby is discharged, there is no indication to keep the baby admitted, then obviously we can see the baby in the clinic of the examiner. Now, a few important logistical points which we can keep in mind is we can fix 1 day of a week for screening. That will be easy for patients also. For one person contact in the NICU should be kept so that he can coordinate and manage the things properly. The contact person will be easily trained about the dilution and the dilatation strategy of the dilating drops. We have to dilate the babies 30 to 45 minutes before screening, and also we should maintain a register of babies which are supposed to be screened and the babies which are actually screened. Then only we will come to know if there is any dropouts. Most importantly, the baby should be comfortable at the time of screening. Which drops should be used? It is very important to understand the dilating drops which have phenylephrine concentration in a higher amount, 5 to 10%, are better to be avoided at the time of ROP screening, because this concentration is excess for a fragile neonate. So, how to dilate? The concentration that is used is 2.5% phenylephrine plus 1% tropicamide or purely tropicamide. Now it is very easy to prepare this. We have to just dilute 1:1 normal adult dilating drops. So automatically the phenylephrine will drop down to 2.5%. You can use any normal lubricating drops to dilute the phenylephrine. We have to put the drops every 10 to 15 minutes apart, 3 to 4 times into both of the eyes. Always wipe the eyelids after instillation to prevent the absorption from the baby's skin, and keep a watch on baby's pulse and respiration for any apneas or SpO2 dropout. It is very easy for anybody to check whether the baby's eyelids are dilated or baby's eyes are dilated or not.
Chetan sir,
Yes, sir.
sorry to interrupt. Can you go fast, please? Because
Yeah,
there are
no
2
problem,
more
sir.
lectures in line are there.
Yeah, no problem, sir. I will speed up, no problem. So we have to keep a watch that the baby is not hungry, the baby is not going into hypothermia or hypoglycemia, and we have to use correct drops. It is important that an examiner needs this data at the time of screening: date of birth, birth weight, gestational age, post-menstrual age, and other systemic comorbidities and details of the NICU stay. Now coming to management protocols, follow-up is very important and it depends upon the severity of the disease. Also whether there is severe form of plus disease or not. Actually the schedule is very complicated, but I usually break it down like this. Zone 1 we can see after 1 week. Zone 2 usually after 2 weeks, but if serious form is there, severe form is there, after 1 week. Zone 3 usually after 3 weeks, but if severe stage is there, then after 1 to 2 weeks. Now, like screening also, we have to keep the same points in mind. No hypothermia, no hypoglycemia, no excess of phenylephrine. And always during the treatment has to be always in NICU, and the staff, suction apparatus, intubation, instrumentation, and O2, etc. should be ready. So the treatment as of now, gold standard is laser treatment only. It has to be done at appropriate time. I will just share a few pictures with you. These are the laser scars which are done. Here the retina was immature and the laser is done. The fresh laser scars will appear whitish, and after scarring, they will appear like this, and the disease is regressed here. Here also you can see this disease is regressed after the laser treatment. You can see the change in the vascular pattern. Here it is abnormal and here it is normal. So what happens is after laser, we will destroy the hypoxic avascular retina, which will reduce the VEGF and which will reverse the pathology of the disease. It is indicated only for the high risk pre-threshold or threshold disease, as we discussed, and for APRO. We have to always keep a watch on the other systemic comorbidities and correct them as and when required. The normal material that we need for laser is instrumentation like speculum, wire vectis, the medicines, monitoring equipments, the laser machine and its parts. Patient has to be well dilated. There has to be some at least 2 to 3 hours of NBM time. We should always keep a watch on SpO2 and pulse. So after completion, we have to check whether there is any corneal erosion or no, or if there is any bleeding or if there is any lid edema. If the baby is comfortable and stable, and routinely we give topical steroids after the laser treatment. Usually we see after 3 to 7 days and after 1 week or 2 weeks again, and retreat if required. The disease regresses and we come to know by dilating pupillary dilatation, which becomes better, the vascular dilatation tortuosity decreases, and the traction and proliferation reduces. So follow-up schedule is usually 1 week, 1 month for checking whether disease has regressed or not. After 3 months for checking vision. After 6 months for any squint is there or not. And after 1 month, for 1 year for refraction and glasses. So if the ROP is treated early, as we can see here, the ROP resolves and the vision is preserved. But if it is missed, see, the retina will undergo detachment. It will fold and there will be white pupil. Now, this is a newer treatment modality, anti-VEGF antibody injections, monoclonal antibodies. They are given in a very small dose. It is usually a reserve treatment when laser is not possible because of pupil not dilating or the baby is not stable. Usually, nowadays, it is given for aggressive disease also as a primary treatment. But the only problem is you have to keep the baby under follow-up for around 1 to 2 years. Now, surgery is required when the disease is not under control after laser and injection. Here you can see that this area was undergoing detachment, and now after surgery, it is stable. After surgery, patient's vision can be salvaged, and even with this bad retina, see, the baby is having such a nice...
Chetan.
Yes, sir.
We have to please wind up.
Yes, sir. Yes, sir. So okay, only this last slide I will share with you.
Yeah.
This is a very important study done in LV Prasad. They actually traced 75 stage 5 ROP blind babies and found out what went wrong. The screening was not advised in 34. It was actually advised in 37. Out of the 37, 9 came too late for screening. 28 also came in time. Out of the 28, 2 did not understand the instructions. In 19 patients, the parents came late. And in 7 patients, they came in time also, but the eye care was not proper. The patients who came late, 8 patients did not come for screening in time, and 11 even came for screening but did not come for follow-up. And in eye care, 6 patients were not diagnosed properly and 1 was not.
Chetan sir, sorry to interrupt. Can you tell only 2 words and stop, please?
Yes, sir. Yes, sir.
Take home message, please.
Take home message is just a second, sir. So, my take-home message is our dream for ROP is no premature baby should escape the screening, and we should stress the parents about importance of screening in time and you should tell them about irreversible blindness. And always important to document that you are telling. You should take their signature in their own language and keep it filed into the baby's file. So we all know that do boon zindagi ki. According to that, I would like to give this slogan to you: 30 din roshni ke, and we should try to screen as many babies as possible. I want to thank all my mentors, all the neonatologists and pediatricians, and all premature babies. And thank you for your attention.
Thank you, Chetan sir. Sorry, we could not give much time to you.
No problem.
We will move on to our next speaker, who is Dr. Vishal Chandak sir. He is pediatric orthopedician who is working in Cape Town Hospital, Aurangabad, and he visits to Nanded as well as Parbhani on regular basis, and we get a lot of help to manage pediatric orthopedic patients from him. Over to you, Vishal sir, please.
Yeah. Thank you, Deshpande sir and Sandeep sir, for giving me this opportunity. I thank IMA Nanded for organizing such a nice event. So I'll try to wrap up as early as possible. My topic is when to involve pediatric orthopedic surgeon and dilemmas and decision making. So many a times there is a dilemma when to refer the patient to pediatric orthopedic surgeon and when not to refer. What to do in conditions like bow legs, reactive synovitis, abnormal gait patterns, and many physiological conditions. Many times mimic pathological conditions, or pathological conditions are undertreated as a physiological conditions. So there can be undertreatment or overtreatment. So the focus is to convey when is the proper time to refer and what needs, when it needs just reassurance of the parents. Most common condition is CTV or clubfoot. Unfortunately, all of the foot deformities are being referred as CTV. Patientला CTV आहे sir. Between CTV or clubfoot and what other deformities are there apart from CTV or clubfoot, I will just show you few slides on that. CTV is congenital talipes equinovirus, and clubfoot is usually reserved entity for syndromic kids. So we don't use clubfoot term for the idiopathic kids. Then there are positional forefoot virus, then congenital peroneal spastic foot, and congenital vertical talasis. So to explain the CTV and clubfoot in detail, CTV is usually congenital and idiopathic, but clubfoot is syndromic. CTV is less rigid and has a better prognosis. And usually we can get away with a small surgery, but in syndromic clubfoot, they have poor prognosis as they are very rigid. Maybe repeated surgeries are required. And of course, splintage protocol is altogether different in both the conditions. As in clubfoot, they require prolonged splintage. These are the images. First image is of idiopathic CTEV, and second is of syndromic clubfoot. You can see a clubfoot on the right side, and left side, you can see dislocated knee, calcaneal foot, as well as thumb in palm deformities, and hip joints are dislocated. So in nutshell, clubfoot is usually a syndromic entity. Then comes the positional forefoot virus. Many times in NICU, we get a child with foot in which toes are pointing inwards and rest all things are normal. But again, they are confused with clubfoot or CTV. So positional forefoot virus is because of prolonged position of the kid in the uterus of a mother. And just it's a positional supple deformity, which can be corrected with stretching. Usually it corrects by its own by the age of 6 to 8 weeks. And they don't require any splintage or aggressive treatment. Peroneal spastic foot or congenital calcaneovalgus foot are exact opposite of the clubfoot. The calcaneus is more prominent. Foot is in dorsiflexion. It is again a positional problem. In utero position, persistent position causes this deformity. Passive stretching is sufficient and it corrects it by the age of 2 months. Sometimes there are the mimics which can present like this, which are congenital problems like fibular hemimelias or posteromedial going of the tibia or fibula. Then many times we see that there are kids who don't have the palmar plantar arches. They don't have arches on the plantar aspect. Rather, they have reverse of that, and there is rocker bottoming of the foot. Again, this is opposite of clubfoot. It needs treatment. Initially, we can treat it with plasters, serial cast, but if it is rigid or ignored, then they need surgical treatments. And I won't go elaborative in the surgical part, since I am restricting this topic only for the clinical judgments and when to intervene and how to intervene. Again, common problem is in-towing gait. So usually we get some kids around the age of 4 to 6 years who walk with the in-towing gait. Parents have concern. Rather than parents, the elderly people who are in the family are more concerned for that, and they come to us. Many a times, in-towing can be physiological, but there are times when it can be pathological. So what we need to see, whether it is physiological or pathological, are there any bone or joints involved? Is W sitting associated with that? And what are the red flag signs? Then we need to intervene. Physiological in-towing is usually up to the age of 8 years. By 8 years, it should get corrected. In-towing can be accentuated more in the between age of 6 months to 5 years. And over the period of time, it spontaneously resolves. W sitting is more common in these kids, but treatment part is just reassurance, gait training. There is no rule of any shoes or splints. But if the in-towing persists beyond the age of 8 years, or it is exaggerated, then we need to look it as a pathological problem. Then we have to analyze the gait. We have to see how the child is walking. What are the fixed deformities, if there are any? If there is really a problem, then when to intervene? Again, the intervention is done only after 8 years of age, and only after if the child is not getting, the problem is not getting resolved of even after gait trainings and all other modalities. What are the, how do we intervene in that? In that, the corrective osteotomies are done and the prognosis is really good. But if we leave it untreated, then there are multiple problems. Child develops valgus deformities in the knee. There are sores on the foot. There can be early arthritis of the hip joints. Another common condition in your busy OPD practice, evening time, a suddenly painful upper flail extremity comes to your consulting room. Parents are concerned ki atta tari khelat hota, child was all well few minutes back and suddenly has stopped using his upper extremity. He is pointing towards his shoulder or wrist. What is this? Why it happened? So this can be a pulled elbow. The etiology is that when a child is pulled by holding at his wrist or suspended by holding at his wrist, the radial head get subluxated or dislocated from the radiohumeral joint, and it is a extremely painful condition. The child stops using the arm. Usually they show pain towards shoulder or wrist, but it is a referred pain. We need to diagnose it properly, and this is reduced by hyperpronation and supination of the elbow in a OPD on a OPD basis. The moment the radial head is reduced, child becomes so happy, and you will get such kind of a beautiful laugh there only. And it is actually that rewarding procedure. Then many times we get patient with swollen joints, painful gait, they are limping, they are febrile, they have fevers. So we need to differentiate whether it is a reactive arthritis or septic arthritis. The conditions mimic to each other in early stages. So it is very important to have an elaborated history that how it started, when it started, is it associated with the fever, were there any prodromal symptoms, was child having some diarrhea, dysentery like symptoms before starting joint pains, was he having any symptoms of viral infections before having joint pain, how long the symptoms are there, how severe are they, and of course we need to do clinical examinations to prove our diagnosis. Reactive arthritis, it is usually a reactionary arthropathy to some viral infection or some underlying infection. They have low-grade fever. Child is not that toxic. They tolerate the pain. Just the problem is antalgic gait or having terminal painful range of movements. It improves over the period of time as the day passes. Usually it should get resolved in a week or 2 weeks. It is a self-limiting condition. We don't need any antibiotics for that. We just treat with the analgesics. But septic arthritis, they have high-grade fever, ambulation, they can't walk on that leg or that extremity. The condition deteriorates as the day pass, and they need intervention at the earliest. So we used to learn that how to diagnose septic arthritis. There is a Kocher's criteria. But is it still valid? Does it give a clear guideline to differentiate between transient synovitis or reactive synovitis? Again, there are dilemmas. Is septic arthritis a medical condition or surgical condition? Why not to treat the infection with antibiotics? We can have good antibiotics. There are many good antibiotics available nowadays. And what are the long-term complications of the septic arthritis? Kocher's criteria, many of us we know the criteria. I don't elaborate it much, but this is a recent paper published in 2021, which has shown some drawback of the Kocher's criteria, and they have found that Kocher's criteria insist on ESR, but CRP is a better predictor for the infection. Risk of septic arthritis was only 71% when it is correlated with Kocher's criteria. CRP and weight-bearing status are rather better markers to mark it as a septic arthritis, and they have given a chart in which you can differentiate between whether it is a septic arthritis or reactive arthritis. Does septic arthritis need medical treatment or surgical treatment? There were papers which were always confusing, and with good antibiotics, sometimes we feel that it should be treated conservatively. But nowadays, there is a dictum. You overdiagnose the septic arthritis, but don't undertreat it, because the collection is in the joint and antibiotics can't reach the joints that effectively. This is again a recent paper of 2016, which has insisted that surgical drainage is very important in early diagnosis of septic arthritis, so that you can avoid the complications like septicemia and joint destruction. Conservative approach can be tried if the patient is diagnosed late. Antibiotics should be given IV for the 2 weeks and orally for another 2 weeks. First generation cephalosporin and clindamycins are usually sufficient, but it is very important to get the culture done from the sample and then only start the proper antibiotics. Long-term complications, there can be destruction of the joints, that is Tom Smith arthritis, or joint can be stiff, it can dislocate, joint can become painful, it can go into avascular necrosis, or if ignored for the long time, the infection goes into the bone and ultimately the child lands up into osteomyelitis, which is very difficult to treat. She was a child, Sania, 1 year old, presented us with fever, local warmth in the hip, not moving her lower limb, WBC counts were raised, CRP raised, and she was advised hip arthrotomy. But parents felt it is too aggressive for a small child, so they went to some pediatrician, took IV antibiotics for 2 weeks, fever settled. But over the period, gradually the joint became stiff and the limb was getting shorter. This is the X-ray at presentation. There is just subtle joint space widening and slight subluxation of the femoral head, which is not that easily pick up. But after 3 months, if you can see, the hip has completely dislocated and joint space widening is still there. But hopes don't end there. Ultimately, we operated her. We took out the infectious tissue. We reduced the joint, but of course, it was very aggressive surgery. This is her X-ray at the age of 6 years, and now she is walking well. But she could have prevented such an aggressive surgery if had been treated at a proper time. So I'm just sharing an unusual case of infection. Recently, we had a male child, second born of the twins. He was 1 year old, came to us with irritability, weight loss, and on and off fever with a progressive hump over his back. He had reduced power in his lower limbs, reflexes were sluggish, and there was a progressive hump with local tenderness. X-ray showed collapse of D7 and 6th and 7 vertebrae. MRI was done. It again proved there is a collapse of D6-7 with some collection anterior to the spine. It can be infectious or malignant. So this was his X-ray with a big hump. this was CT, which was showing lysis of the vertebrae. And you can see there is a cord compression. This is MRI. Cord was completely getting compressed, and he was having neurological weakness in both lower limbs. So how to deal with this condition? Whether should we go with conservative, empirical some treatment, or should we go surgically? Is biopsy needed? Whether biopsy with fixation needed? And what about the neurological recovery? So much of compression on the spinal cord, it will take a long time to treat with just medications. And again, we don't have any conclusive diagnosis, whether it is a malignancy or it is some infection. So it was, he was needing some biopsy, but just biopsy was not sufficient as the spine was collapsing and the deformity was progressing. So we went ahead with surgery, but surgical challenges were there, whether to do only posterior or go anterior or posterior. As it was a mid-thoracic region, there were high chances of getting paraplegia if neurological complication happens. Again, for 1 year child, we don't have instrumentation, spinal instrumentation available in India. There are problems like intraoperative neurological monitoring, how to monitor nerves. So we went ahead with the surgery. Intraoperatively, we had neuromonitoring system. We specially imported the customized implants for the kid by doing his proper measurements of the vertebrae and laminae and pedicles. He was operated at the age of 1 year with neuromonitoring, but unfortunately, intra-op, at some stage, all the signals in the lower limb disappeared. That was indicating that child went into paraplegia. We decompressed the spine. We traced the nerve roots. All roots were intact. There was no spinal cord injury, dural injury, but child was in spinal shock because of handling. With the steroids, nerve root decompression, he recovered in 48 hours. After 48 hours, we went anteriorly, took out the collection. It was sent short course of steroid as he was in a spinal shock. Now he has completely recovered, walking well, running around. He has gained, done good weight gain. This is his recent X-ray. So this is the timely intervention which helps to regain someone's life and someone's mobility. Common problems around the knees, genu varus, genu valgus. They can be physiological, they can be pathological because of rickets, bony dysplasias, growth arrest, maybe due to post-trauma or post-septic. There can be bone tumors, metabolic problems, collagen vascular disorders. They can cause genu varus. But most of the genu varus are physiological. So what is physiological genu varus? The genu varus, which is visible till the age of 4 years and which is a minimal, when the intercondylar distance is measured, it should be less than 5 centimeters. Then we can say it as a physiological. Physiological genu varus starts appearing around the age of 6 to 12 months, and it usually resolves by the age of 4 years. It is self-limiting. Again, no splintage required. There is no need of splintage. Just it is for the psychological satisfaction of parents we give splintage. Otherwise, we don't encourage any splintage. But how to diagnose it? It is physiological or pathological in day-to-day OPD practice, since we are focusing on OPD practice and dilemmas. So the simple test, ask for the age of the child. As I told you, remember those criteria. What is the age? And second thing, get X-rays done. Normal X-ray looks like this. There are no any changes in the bone. Just you will see a good physial lines. But in rickets, you will have metaphyseal winding, other rickets signs, stippling. And in dysplasia, you will have some bone affection, growth arrest, physial injuries. So this is a quick test. If you have any doubt, get knee X-rays done. Treatment options. In physiological, just reassurance and counseling of the parents. In pathological, we can go with growth modulation or corrective osteotomies. What is the difference? In growth modulation, as the term itself indicates, we modulate the growth. We don't cut any bone. We just stop growth of one part of the bone and stimulate other part to grow properly so that the deformity gets corrected over the period of time. In osteotomies, we have to cut the bone, we have to put the plates, and patient is immobilized for a long time. Growth modulation is a beautiful surgery which is being done nowadays. It is done with a small implant. Child doesn't need any rest. Second, a child is mobilized. After 10 days, child can resume all sporting activities. The only drawback, the deformity correction takes longer time, from 6 months to 1.5 years. What we do, we put a plate. This is called 8-shape plate across the physis. Physis is spared. We have put one screw above and one screw below. This is elastic plate. We have halted growth on medial side of the physis and stimulated the lateral physeal growth. As the lateral physis start growing, you can see the deformity is getting corrected and the deformity is completely corrected. So this is the beauty of this implant. Small surgery, cosmetic surgery. She was a child, presented at 5 years of age, bilateral significant genu-varus. After 6 months of the surgery, some correction is there, more on left, less on right. And after a few years, it was completely corrected without any ugly scar. And this is her X-ray at the age of 6 years. Clinical photograph at the age of 6 years. But what are the prerequisites for growth modulation? There has to be some growth potential. Physis should be a normal, healthy physis, and physis should be open. And near puberty, we cannot go ahead with the growth modulation because the growth potential is about to halt. Similarly, genu valgus, it can be physiological or pathological. Valgus deformity starts appearing somewhere around the age of 3 to 4 years. It reaches to the normal or physiological stage by the age of 7 years. In male, we can have 8 degrees of valgus, and in female, in female there is 8 degrees of valgus, and male there is slight lesser degree of valgus, 7 degrees. But in female with wider pelvis, you can have more valgus deformity. The quick clinical test to diagnose whether it is pathological or physiological is just measure the distance between two malleoli, intermalleolar distance. I can show you. Measure the distance between two malleoli. If it is less than 5 centimeters in any child around age of 8 years, then it is physiological. If it is more than that, then it has to be pathological. Pathological can be congenital or IT band contractures, soft tissue contractures, dysplasias, and many causes are there. Treatment options, again, growth modulation. We do exact reverse of the growth modulation, what we do in genu varus. It is exact bilateral genu valgus. He was treated with 8 plate. He corrected completely after 1 year and was planned for removal of the implant. If we don't remove the implant, the deformity goes into the opposite direction. So valgus can go into varus. So it is very important to take out the implants at a proper time, correct time. So we need to have good follow-up of the patients. Then some other congenital common problems which we come across in day-to-day OPD practices are DDH or developmental dysplastic hip, congenital dysplastic hip, brachial plexus injuries, limb length discrepancies, congenitally dislocated knees, spinal deformities like kyphoscoliosis. So nowadays, congenital dislocated hip has been replaced with the term developmental dysplastic hip or developmental hip dysplasia, because this is not a congenital condition which occurs overnight. It is a developmental problem and progresses as the day passes. So more comprehensive term will be developmental dysplasia of hip or DDH. They present with asymmetric thigh creases. They have short lower limb or shortening of that affected limb. There can be increased lumbar lordosis, lurch while walking, and in early neonatal stage, you can have positive Barlow's or Ortolani test. USG and X-ray are very important to diagnose. So if you see clinically, there can be asymmetrical thigh folds and the limb is shortened. Child can have hyperlordotic spine, and this is how we do Barlow's and Ortolani test. What are the treatment options for that? In early stages, this can be managed with Paulik harness. This is a harness in which we keep hips flexed and abducted so that the femoral head get relocated in the joint, and it can be used in the low grade dysplasia. I didn't go with the grading of the dysplasia because again it is a long topic, but we do grading by Graf's index on USG. There are 4 grades, grade 1, 2, 3, 4, and each grade is again divided into A and B. So low grade dysplasia is grade 1A, 1B, 2A, 2B. And after that, we call it as high grade dysplasia. So in low grade dysplasia, they can be managed with just Paulik harness. It has to be kept 24 hours a day. It is very easy to put. Hygiene can be managed very well with this harness and good compliance.
Vishal sir, sorry to interrupt.
Yeah, just few slides.
Vishal sir, sorry to interrupt. How much time you will take, sir?
Not more than 5 minutes.
Okay. Thank you, sir.
In high-grade dysplasia, what we do, we give a trial of close reduction. This is how we do arthrogram. We inject special dyes in the joint and we reduce the hip and we put in a spica cast. When patient present us late or the joint is not reducible with these modalities, then patient needs open reduction surgeries like this, and we open the joints, reduce it, fix with screw and plates. Congenital dislocated knees, again there is grading. Grade 1, 2, 3. Grade 1 and 2 are just hyperlax knees, and this is because of maternal hormones which the child gets across the placenta, but it reduces over the period of time. It is self-limiting. If it is grade 3, then we need to intervene with serial plasters, serial cast, or sometime open reduction, and we can have such kind of knee. Then upper limb deformities, radial club hand is very common, in which we have palm deformity along with a rudimentary or absent thumb. It is very important to rule out Vater anomaly in this, and they require stage-wise surgeries. In first stage, we do centralization of ulna, second stage policization, and third stage is lengthening. So she was a girl presented around age 1 year of age. She had club hand with rudimentary thumb. First, she underwent the centralization of ulna. We corrected the forearm deformity. Later on, she went ahead with the policization surgery, in which we converted first digit into thumb. This is very rewarding surgery. You can see now she is of around 2 years of age and she has started writing with her thumb, which was made up of first or index finger. Brachial plexus injuries are common in shoulder dystocia or overweight babies in diabetic mothers. This is due to stretch on the brachial plexus. They can be transient or partial or complete. Spontaneous recovery is seen in 80% of cases, provided that it should be restricted to C5 to C6. In extended up palsy, 60% recovery is spontaneously seen. In 30% cases, there is total palsy with Horner syndrome, and Horner syndrome itself is a bad prognostic marker. Clinical examination, monitoring every 4 to 6 weeks till the age of 3 months is important to see whether it is spontaneously resolving or improving. If not, then we go ahead with EMGs and surgeries. Surgeries can be nerve repair, nerve exploration, or nerve transfers, or tendon transfers. He was a 4-year-old child, presented late with a palsy. He was not having any shoulder movements, but at this stage, nerve repair was not possible. So we did tendon transfers, and this is how he has a good working hand where he can do his day-to-day activities with the hand. Scoliosis then can be congenital, idiopathic, neuromuscular. They can be progressive or static. We need to see whether progressive or static, and then accordingly we need to intervene. And very important to see whether any neurological involvement is there. He was a 10 years old child with progressive idiopathic scoliosis. He underwent with the surgery, and we got such a wonderful collection in that. Just a small interesting case I will discuss with you, and then I'll wrap up my talk. Why good skin and light exposure is important. He was a 13-year-old guy with congenital ichthyosis, scaly dry skin. Came to the emergency room with altered sensorium, malpositions lower limb, foul-smelling infectious pustule all over the body, deranged electrolyte. He was, in fact, in the encephalopathy. And X-rays were showing pathological fractures of both femori. He was not being exposed to sunlight for last 2 years because of his scaly skin, and he was considered it as a social taboo. So when he came, he had such rotated bad limbs. He was in altered sensorium. So we stabilized him with just skin traction. And when we took X-ray, he had a pathological femoral fracture bilateral. It was just because of vitamin D deficiency and bad skin condition. So we settled him medically, allowed the pustules to heal, gave him skeletal traction. Once the infection first time that we use this implant in any pediatric patient. This was implant meant for adult patient, but he was not fit for any pediatric implant which are available. So now the patient is walking well, doing all his activities. Now his skin condition has improved, and this is his happy photo when he came to me yesterday only. So our aim is to make all disabled, enabled. We are working on that aim. Thank you for your patience listening and giving me this opportunity to present my work in front of you.
Thank you, Vishal. It was a good talk, and it is regarding the when should a pediatrician refer proper cases to the surgeon, because as a surgeon we always remain on the back foot. I mean, on the backstage actually. As all this talk, you were in the guy in the disguise. We never able to see you. It was only slides we could see. There are three things. One thing is like, thanks for your talk. Second things is all the delegates who have registered and attended for the MMC points, please SMS your details to the concern number given in the flyer. So this is very important announcement before we conclude and before we go to the last lecture. The last lecture is an important lecture regarding it is a plastic surgeon. I am privileged to introduce him. He is Dr. Rajendra Nehte from Nasik. He is a versatile person. He works in plastic surgery. He works in mountaineering. He works in cycling. He is a proud completer of, he's a cyclist of who has completed the RAM. In plastic surgery, he has been on a various post national and international faculty. May I introduce Dr. Rajendra Nehte, please? Dr. Rajendra?
Should I start?
Yes, sir.
Yeah,
please, sir.
Can I share my screen?
Yes, sir. I'm really sorry, sir. We are quite late. We were almost 40 minutes late because of some technical snag at the Dr. Videkar and later even.
Okay. Yeah. Can you see my screen now?
Yes, sir.
Okay. Thank you, Manish, for nice introduction. And thank you as a president of Nanded IMA and inviting me for this talk. As well, I would like to thank Dr. Kotkar and Dr. Sandeep and Dr. Rajesh for inviting me. Unfortunately, I couldn't join for the previous lectures, but then I was busy with something else. But it is an important topic, as Manish said, it really matters when we send patients to any super specialty person for the surgeries. And otherwise, there are problems. Look at these patients, the patient of a cleft lip on the left side and patient who has got external angular dermoid on the right side. Both of them, they deserved earlier treatment. And the ideal time will come to it. But then this is the cleft lip repaired. And this is the external angular dermoid, which was repaired because it was pressing on the eyeball, and then it was necessary because he was getting amblyopia in the lateral field of vision on the left side. So it was essential to operate, and this is the result. The problems are whenever we have a pediatric patient, the child has no problems or no ideas what is going to face in life. The parents decide everything, and some of the parents, they consider it as a God's gift, and they don't want to operate few of the congenital anomalies. And otherwise, many families have a concept that the child is too small and they are afraid of general anesthesia, so they would not like to do any surgery. And doctors, sometimes it happens because of lack of knowledge or because of some social reasons. And many times, can you hear me? Hello?
Yes, sir, we can hear you.
Okay. Many times we get patients in the later age group when we ask the relatives that why didn't you bring him earlier? And the relatives say that our doctor told us that let him grow. But how much to grow? It is very essential for us to give them exact guidelines. So when to operate? Within 3 months, there is sudden infant death syndrome. So any surgery which is not the condition which is not life-threatening or limb-threatening can be postponed at a later date. Then when to operate? In pediatric age group, especially in congenital anomalies, it is better to operate. It is better to operate before they go to school, because at early age, when the body image is not formed and when the children grow, they get the inferiority complex. So before that, we should operate. It is usually presumed that if you operate before 4 years, the children don't have a self body image of that congenital anomaly. So they should be operated preferably before 4 years of age. The second criteria is whenever the reconstructive surgeon is confident and comfortable. For example, what Dr. Vishal showed as a polycization, somebody is not comfortable to operate them early, but somebody is very comfortable to operate early. So it depends on the reconstructive surgeon also. That is when the child grows to the adequate size so that the affected organ has grown to the adequate size and the surgeon is comfortable to operate. We will see few conditions. For example, cleft lip surgery. The rule of 10 was established by the Western world as age of 10 weeks, weight of 10 pounds and hemoglobin of 10 and WBC count less than 10,000. However, it was modified for India in the era when I got trained 30 years back, that age of 10 months, weight of 10 kg, hemoglobin of 10 and WBC obviously below 10,000. But now we can operate them early, and even 10 to 12 weeks, around 3 months is a good time to operate a cleft lip. This is a patient of unilateral cleft lip and palate. He was operated. You can see a beautiful result if you operate them in time. This is another patient of bilateral cleft lip and palate, a very wide cleft and very wide cleft palate also is doing very fine. So if we talk about cleft palate, it should be operated beyond 9 months because we achieve our oral competence by the cleft lip repair. But two further functions are the deglutition and the speech. And before child starts speaking, because around 9 months of age, they start speaking monosyllables and then they go to bisyllables and multisyllables. And there are two types of words when what we speak, the consonants and vowels. Now vowels, that is A, E, I, O, U. What we say I, for that, the velopharyngeal competence is not required. But when you talk about consonants like T, Th, D, D, for these, the velopharyngeal competence is required. And before around 9 months of age, you should repair so that their speech develops to a normal level. The second reason is the types of the words. So there are labial words like mom, mama, baba. They will be able to speak well. But if you ask them to speak the alveolar words like ta, tha, the, tatya, dada, they will not able to. Then tata, lo, they will not be able to pronounce. So it is important to restore the palate to normal when the child starts speaking so that their speech develops normally. Because children, whatever they hear, it gets established into their memory. So if they are speaking in a wrong manner, they will learn it in a wrong manner, and it is very, very difficult to correct at the later age. So it is important to operate early. This is the patient of isolated cleft of the secondary palate. He doesn't have a cleft lip. Such patient should be operated around 9 to 10 months of age. Another patient, he was previously operated for a lip repair, and then he came very late for the palate repair. Obviously, he will have problem. Many of these patients, they will have small residual speech abnormalities because he is being operated very late. Now, about the congenital hand anomalies, when to operate? Ideally, when the child starts using hand. So when the children start using hand, initially they have a single hand grasp or a grip, and later on they develop a bimanual grasp. And after that, they start achieving around 9 months of age, the dexterity, the hand dominance, and the prehensile fine functions of the hand. So the children ideally should be operated around 9 to 10 months of age. But depending on the size of the baby and size of the organs you are operating, it may vary. A very, very simple common abnormality is syndactyly. The commonest is the third wave involvement. Next is fourth, second, and first. and they are to be operated in a reverse manner. That first web should be operated, the thumb and the index finger. The first web is important because it will hamper the growth of the index finger, because the height discrepancy, the length discrepancy in the thumb and the index finger is highest. After that, we need to operate the fourth web, then the second web, and then last the third web. So third web can be operated later. In fact, we get many patients who are operated for third web because they have practically no disability. But if it is the first and the fourth, they need to be operated very early. And this is the flaps what we take, the planning, and this is the ultimate result. So it should be a completely released. It should not creep again into the web space. This is the bilateral web. You can see this is a child has grown, and you can see a deformity and the space between the index, the middle finger and ring finger, and deviation because he was operated late. So it is very, very important to operate them around 9 to 10 months of age so that they get a better result. Then acrosyndactyly, where all the fingers, they are joined together at the tips, and it is very important to operate them early. So in fact, when they are very small, around 1 to 2 months of age, I plan to operate them and release these adhesions in between the two fingers. There are simple adhesions sometimes where the fingers will be released, and after release, they are very comfortable, and then the fingers will start developing in the length. Otherwise, there can be a length discrepancy. This is one of the common problems, the congenital trigger thumb, where there is inability to extend the IP joint of the thumb, and you need to release it under anesthesia, and after release, you get excellent result, a complete extension of the thumb. But then many times the parents are very anxious about general anesthesia, and they don't want to come early. Hypoplastic thumb, you need to do a polycization because this thumb cannot be converted into functional thumb. It is very difficult. And you can see as the child grows, the distance between the first web goes on increasing. So this index finger, because the thumb is non-functional, this index finger will start achieving a function of the thumb. It's a very natural tendency. And in such patients, it is very easy to do polycization and give them the good result. So these are the incisions. These are technical details. I don't want to go into any technical details. And this is the position of the thumb. It should be ideally like this. And this is the thumb with good web space and good abduction perpendicular to the palm. And this is the child with good function. You can see a small video. He's using his right hand where the thumb was operated. You can see he's got only 4 fingers in that hand. Another common abnormality is polydactyly, and they should be again operated around 10 months. But most of the time we get these patients a late referral. It is very important when the joint is shared, the joint should be restored well. Otherwise, they get different abnormalities. And sometimes, if you are not able to operate them well, and if you destroy the joints, they will have finger deformities. So sometimes operating them early becomes detrimental for the patient if the surgeon is not good or if the surgery is not good. So it has to be a good surgery so that the good axis of the thumb is restored and they have a normal function after that. If there are shared tendons, then you have to share the tendon with the residual thumb, which you want to keep. Constriction ring syndrome, sometimes this constriction is so severe that you will find extensive edema of the distal foot and sometimes venous congestion or sometimes even the arterial ischemia. If this is the case, they need to be operated very early and you need to release at least half of the constriction ring. Otherwise, they can be operated any times after the 10 months. This is a large confusion amongst the doctors. All community confuses these conditions, hemangiomas and vascular malformations, to a great extent. Hemangiomas, they are usually present at birth. You will have the telltale signs of something at the birth. Many of them, they are cutaneous hemangiomas or capillary hemangiomas, but there can be capillary venous hemangiomas also. There is no intervention to be done in this patient except if the hemangioma is leading to respiratory distress or amblyopia because it is in the eyelid. Otherwise, you don't have to do anything. For such patients also, you can start steroid prednisolone in specific doses so that the size of the hemangioma is controlled and you don't have to operate. The basic thing in hemangioma is most of the hemangiomas will start, they will grow up to the age of 1.5 to 2 years. After 2 years, they will start regressing in size, and by 5 to 7 years, most of the hemangiomas regress. There may be residual telltale signs which you may operate, but otherwise they disappear. Whereas vascular malformations, they may not manifest at birth. They are venous, arterial, or combined, or it can be AV fistula, or it can be whole limb is involved by a Klippel-Trenaunay syndrome, for which there is at present no treatment. This is a involuting hemangioma, and you can see within 1 year, this child, this lesion has regressed, and I'm sure this will regress to a great extent, and sometimes there can be no sign of hemangioma later on. Again, another child, involuting hemangioma. I don't have his photograph at the birth, but it was larger, and then it is going on reducing, and I'm sure this will disappear completely. Another residual hemangioma after involution. This girl, they don't have a preoperative photograph, but this hemangioma was very large. So we operated, you can see a small scars out here. And when she came in adulthood for revision of the scars, you can see a transformation. The residual hemangioma regress. It is easier to operate them and remove their scars. So hemangiomas ideally should not be touched for surgery. They should be left alone. Whereas venous malformations or arteriovenous malformation will require some form of treatment. I am not in favor of doing sclerotherapy, or I'm not doing in favor of angiography and embolization unless they are in the trunk region or head and neck region and they are extremely large and vascular to control the size of the malformation, or to facilitate the surgery, you can use embolization. Otherwise, many times embolization and sclerotherapy, they have adverse complications of skin necrosis. One of my patients, against my will, went for a embolization in the upper extremity lesion, and he had gangrene and his hand had to be amputated. So it is not worth going for it. You can do a palliative excision and inform them that this may require a repeat surgery, and they get a good result. You can see a small bump out here, but inside there was a large lesion. So we did surgery and remove it, and you can see a very minute scar, but this is the early stage. So you are seeing scar, otherwise this scar will not be visible later on. Another patient with a large lip hemangioma and after, vascular malformation. This was again a venous malformation. So we excised it and reconstructed it. There are small lesions, but then whenever they grow again, you can always excise them rather than giving them a greater deformity. This was a pre-auricular venous malformation. Now you have to differentiate when you see the malformations, whether there are localized malformations. So we do a CT angio in almost all these patients, and we see if it is localized, it is always better to excise them, and they are amenable for excision. This is again a gluteal malformation like this. It was a larger inside. We excise it and close everything primarily. There are some ocular anomalies which needs to be dealt early, because in this patient there is upper lid coloboma, and this coloboma, because during sleep the eyeball rotates upward, the cornea may remain exposed, and she may have corneal ulceration. So you need to operate this coloboma very early, and you get a good result if you do them, operate them early. Whereas in ptosis, a ptosis like this, if you operate them, and in case of children, the post-op, they may have lagophthalmos. So inability to close the complete eye after the surgery is the commonest problem of ptosis. And in children, there are chances of corneal exposure, and the self-care by patient is very important, and children may not be able to take care of it. And that is why you need to wait till the child becomes of adequate age so that they can take care of themselves, or at least the parents are so good that they will take care of it very well. If the closure is not there, then you need to instill the ointments and the Moisol eye drops so that they don't get a corneal ulceration. Another contraindication in this is myasthenia gravis. If it is myasthenia gravis, you should not operate. This is the ptosis surgery. After doing the levator resection, you can see a good equal length. a good eye closure. This was one of the excellent result. Another patient with bilateral severe ptosis. So we operated. So in such patients, we may not try to achieve to a normal level because she doesn't have a normal level. The surgeon will give a normal level, and little subnormal you can accept if it is bilateral, because there is no question of giving asymmetry. A minor asymmetry in such cases is always always acceptable, but then there should be no lagophthalmos and there should not be any complications. Many times we feel really bad for torticollis patients, because if you allow these patients to grow with torticollis for a longer age, then they have this the deformity, permanent deformity of the cervical vertebrae and the neck muscles. So it is better to operate them early, and torticollis should be operated within 2 years of age if you really want excellent result. Now this is operated by bipolar release, a small incision surgery, but then you see he has got a complete good posture, normal alignment of the eyes also. You can see here the axis of the eyes is also changed, but here it is normal. But the only difference you will notice is the breadth of the shoulder is less on the opposite side. Now, if you want to avoid this, I have seen many patients who have presented in adult age, they don't get correction into this, and that is why they should be operated early. If you don't operate early, they will have significant deformity, and it's like a doll, their neck shifts on the other side, and it looks really bad. So I don't know, this video is not working. Then hairy nevi, this small hairy nevi also should be operated at early age before patients develop inferiority complex, because they go to school and then they are teased about it. The another small hairy nevi always can be excised and primary closure can be done to get a good result. The real problem is when you get hairy nevus like this. This is the lesion. She has one lesion out here. She has other multiple lesions, one small lesion here and a big lesion here. And this girl, in spite of being 2 years, very talkative, and she used to say, I got monkey's hand. It is very detrimental if you allow this child to grow in adulthood like this, because she will have body shaming. So what we did, we decided to excise it circumferentially, and we completely excised it in one go and used the IDRT. That's the Integra, which is artificial dermis, which is now available. After Integra, there was an excellent granulation, and then we grafted the whole thing in one go, and you get a result like this, a very good graft tech. But because she is a child, not cooperative for physiotherapy, she got contractures, and you can see wherever at some places there was hypertrophy scar, but we released that also and did it. I yet to get her late post-op photograph, but the parents and the relatives are extremely happy about this. I was absolutely disappointed with the overall texture of the skin and the cosmetic appearance, but the parents are extremely happy because they say the hairy skin is gone, and the child is also very happy after this. Another patient, I saw her around 1 year of age, and she had a hairy nevus in the scalp. So I put off then that we will wait for maybe 2-3 years, let this child grow. And they came after 3 years, and you can see a lesion like this. And they said it is rapidly expanding. And we decided to go for a surgery because it is a big surgery required. I told them initially we will put a skin graft and then we will treat the non-hairy skin. So we put the skin graft, but there was 15 days interval for the surgery and this presentation. You can see a large size growing on, and this was a malignant transformation of the nevus. You can see a lymph node here which is getting enlarged, which needed excision. So we excised those lymph nodes from this same area incision and excised the hole, covered it with the skin graft, and then later on, this is a skin expander which we use for scalp expansion. So whatever residual area of the skull having skin, we expanded it and covered that skin to cover the non-hairy area. This was in between the stages. You can see the half of the area we have covered. She has good hair out there. And then we repeated the procedure. This time we used 2 implants, one here, and then we expanded that. And this is the patient ultimately with absolutely normal hair growth excellent hair growth, in fact. And she's extremely happy. Another big problem in children is hypospadias, and they need to be operated early. So ideally, we prefer to operate anytime after 10 months, but I am comfortable to operate them around 2 years because the penis size is comfortably increased and you are very comfortable to operate. So 18 months to 4 years, but essential is it is better to operate them before 4 years. Everything should be complete because they might require a second surgery or a third surgery. It is important to finish it before they go to school so that they can void urine in a standing normal position like other children. So this is distal penile hypospadias, and you can see the criteria is the stream should be away from the body in a straight manner. This is mid penile hypospadias, again a straight stream, and this is mid penile hypospadias with chordae. You can see a good stream of urine and no scarring absolutely on the penis. The aesthetic appearance of the penis should also be taken care of so that there are no inferiority complexes among these children, because sometimes because it is on the penis, they are very, very apprehensive about it. For trauma patients, many times we get a reference from pediatrician, sir, glue kar do isko na, glue se acha result milega. But mind well, whatever glue is available with us is a cyanoacrylate glue, and which is non-absorbable glue, and it doesn't give a good result. So if it goes inside the wound, it creates a foreign body granuloma, it gets infected, and patient will not have a good result. Nothing can beat a good suturing under general anesthesia for the small children, and they get an excellent result with this. Even the adult patient, you can see a crush injury, but if it is sutured properly, they get an excellent result. So it is always better to suture them. Many parents are apprehensive. They will keep insisting that use glue, but this glue is not suitable. What glue is available ideally should be used is a fibrin glue, which costs around 8,000 to 10,000 rupees. But then the problem with fibrin glue is the edges are not hold together. There are no dermal support, and that is why the scar spreads later on. It doesn't give a good result. So you should not use either a fibrin glue or a cyanoacrylate glue, but it should be sutured. This patient, a spoke valve injury is common. You have to immediately intervene this patient because this is the tendoachilles, which is tendon has got shriveled, and there are a lot of fibers. The calcaneum has got trauma. So you debride it and do. I normally for a small children, you cannot put a graft even if it is graftable area, because any graft in children, if it is used, is contracts. It doesn't grow with the age, and the children will have different problems for this. Whenever there is a bone exposed or a tendon exposed or a vital structure exposed, it has to be covered with graft. I use a microvascular flip flaps even in pediatric age group. So this is a microvascular flap of perforator free flap based on one perforator, done anastomosis on the posterior tibial vessels, and you can see there are no added scarring in the leg elsewhere, because there is a sural flap, a distally based sural flap, which can be used here, but then it leads to scarring in the leg. So if you do a microvascular flap, there is no excess scarring in the leg, and patients are absolutely happy after a few years about this. The fingertip injury, we get many patients like this. Children usually put their fingers into the door trap and they get either amputation or a small injury. This was a distal thumb amputation. So we use a component separation where we use the bone and the nail bed, separated it, dissected it, and then covered it with the cross finger flap from the index finger, and you can see this is the donor area of the flap, but then you can see a good thumb restoration. So sometimes this can be used if the distal thumb is not replantable. Normally, if I get a vessel, I would like to replant it, do the anastomosis and replant it, but many times in children it is not possible, or either they are crushed. So in that case, this modality can be useful. Another patient treated elsewhere, a gangrene, then we use the thinner flap, and even a thinner flap like this, a flap taken from the thinner area, gives excellent result and good restoration of the fingertip, but then need to be sent immediately. Very often I get amputated hands and fingers like this, and then they need to be treated within 4 hours. So it is important that we get these patients early. We had no alternative but to orthotize the elbow joint, but then we were hoping that we will have a good result. This is the early result, and this is the child. And you can see a good restoration of the left hand. And he has a good function, except the he has a good flexion. This can be improved later on because he's got good. The nerve recovery is good. He has good sensation. So this can be a very, very functional hand. Another patient with firecracker injury, 12-year-old boy with complete total avulsion amputation of the thumb and avulsion amputation of the ring finger, and they need very early treatment. It took almost 12 hours for him on a surgery, but save both the fingers. You can see an excellent result. The skull burns. Many of these patients, pediatric patients, they put their hands into the hot water bucket or a hot oil and they get a skull burns. Mind well, the skull burns almost always are superficial. If they become deep by treatment or after treatment, it is the surgeon's responsibility because we have given them the depth of the burns. Otherwise, they should heal without any scars. So what we do is I try to avoid repeated dressings in these patients. So under sterile conditions, we dress them with non-adhesive tulle dressing, put plenty of ointment, and I just put them into plaster and then open that plaster after 10 to 12 days and they are healed, and then they can be mobilized and they get an excellent result function wise also. So this is my way of treating because I don't want them to get exposed to repeated dressing. Repeated dressing is one which gets where the patients won't get exposed to infections. So I prefer to treat them in theater, do a complete dressing and leave them. Another face burns is very common and you need to be very careful about this. You need to give a good result. This is one of the video, in fact, but it is not running. But then we clean it under anesthesia and cover it like this. And this collagen sheet slowly starts separating, and you can see face mask like this comes out and the wounds are healed and patients get a normal result. Extensive burns can be even used by collagen. And some of the burns will need a graft. But then they need to be sent to an expert very early. Post-burns contracture is one of the very difficult thing to manage in children. You can see two fingers are completely adhered to the palm and the ring finger has got a contracture. So we released it in one stage. All these patients, if you try to treat them with grafts, will have recontracture again. So you need to put a flap. So this is a groin flap. The hand is put at the groin and then it is divided. So they need a multiple stages of surgery. So the fingers are got syndactylized. So you need to release the syndactyly. And then at the end, you will find it's a good result with complete extension. We did again a small jet plasties so that she got an excellent result. And this is at the age of 14. Though there is scarring on the fingers, but she has got normal growth of the fingers like a normal hand, and she's got a complete face and complete extension with no contractures. But then this is the ideal way of treating, because with this there will be no contractures, the length will be restored. If you try to put even a split thickness skin graft or a full thickness skin graft, they don't work and the patient will have a recontracture. So timing of the surgery, if you overall consider cleft lip to be operated around 3 to 6 months of age, cleft palate around 9 months, but should be within 15 months, because whatever speech abnormalities are developed, they establish. Hypospadias 10 to 18 months, but before 4 years treatment should be complete. Syndactyly, polydactyly should be operated around 10 months. Constriction band, if it is limb threatening, then as soon as possible. Post-traumatic wounds as early as possible within 6 hours. So what should be the policy? Refer to an expert and take opinion first. And I'm always sure whenever I talk to relatives, if you do a timely referral to an expert, the patients and relatives are very happy about it and you increase your goodwill. Thank you very much. And again, thank you for inviting me for this talk.
Thank you, Rajendra sir, for this nice lecture with a lot of photographs. So we got means a lot of knowledge about when to refer the patient to plastic surgery. And I heard a lot about you from Manish sir. Thank you, sir. So first of all, I want to just thank to all the delegates who have with patience, they have listened all 12 lectures. And basically we we apologize for exceeding the time. And being we try to provide good knowledge, our speakers have prepared a lot for giving the best knowledge to you. So please bear for us for getting this knowledge and for exceeding the time. And I want to mention that there were maximum number of registrations we got for this digital platform, and around 350 delegates have attended this CME. And basically, I would like to thank all the speakers who have prepared these presentations, and they have tried to put all their efforts to show the work and the best work which can be done in different parts of the pediatric subspecialties. This is the first kind of CME we have arranged, and people have appreciated for that. Thanks to all speakers for that. I would like to thank IMA Nanded also. And specifically, I would like to thank Manish Deshpande sir, who has since beginning, I remember from planning to execution, he has helped a lot. And today he has to go to for a function, and basically he has postponed that, and after that only, after finishing that only, I requested to go early. In spite of that, he stayed here and organized this CME. Thanks to Manish sir. And last but not the least, I would like to thank DigiShield team. Mr. Piyush, he is there with us since yesterday. Not today only, he has taken our trial run for our speakers to give a best to all the delegates. So I declare that this CME is concluded. I would like to thank everybody who has helped us to conduct this CME. Thank you very much.
Thank you, Sandeep.
Manish sir, are you there?
Thank you.
You want to say something, sir?
No, it's all done. It's all done.
Okay, thank you, sir. Thank you, everybody.